Fistulacon 2023, which was held in Mumbai recently, was a huge success. We had selected a single theme subject and we did not expect this huge response that we got. I thank all of you who attended the conference in person. This was a 2-day event which had lectures and a live operative workshop which essentially dealt with not only the simple basic things about anatomy and fistula surgery, but also very practical points which the delegates enjoyed thoroughly. Of course, we had a limit to the number of delegates who attended it live, but we were flooded with requests from others to make this online so even they can benefit from this huge conference that we had. I'm very pleased to announce and inform you that we have made it available live and all of you all can watch this 2-day event in the days to come, and I'm sure that you will benefit immensely. Of course, I'm here to answer all your queries. If you have any queries, you are welcome to ask me questions, and we hope to have this sort of conferences in the future too. Thank you. A unique conference, which is single-themed conference. And over the next 2 days, you will see the whole gamut of the basics behind how to manage anal fistula. So we start right from the basics, the anatomy, the pathogenesis, how to detect, and the various options and the various complications. And also tomorrow you will see live surgeries. So on behalf of Dr. Niranjan Agarwal and myself, I welcome you all to Fistulacon 2023. And without wasting much time, I would like to call Dr. Ashwini Wagh to please take over and conduct the conference. Ashwini, please.
Good morning, everyone. I welcome you to Fistulacon 2023. We'd like to be absolutely on time for all the sessions, so we'd like to begin on time. I'd like to start the first session, which is on anatomy and classification. I'd like to invite the chairpersons, Dr. Rajesh Yadav, Dr. Debashish Das, and Dr. Manmohan Kamath to come to the dais and take over the further proceedings. Thank you.
Yeah, good morning, everyone. Without any delay, we'll start with the first session. May I invite upon Dr. Jayalal, the first speaker for today. He will be talking on surgical anatomy of the anal sphincters and spaces. So let the opening batsman begin with the tail end anatomy. Yeah, so Professor Dr. Jayalal does not really require any introduction per se. He's a very well-known professor and HOD of surgery of KGMCH. He is a Secretary General Commonwealth Medical Association. He is the IMA National President 2021, National Coordinator IMA UNESCO Chair of Bioethics, Member of Senate and Board Studies, Dr. MGR Medical University, Academic Director of IMA CGP Headquarters. So, Dr. Jayalal, please.
Thank you, Chairpersons and distinguished people. A warm good morning to you all. It's a great honor and pleasure for me to be here from Tamil Nadu and participate in the wonderful conference organized by Dr. Niranjan Agarwal and Pravesh Shah. And it is a moment when Niranjan Agarwal was getting an honor in Tamil Nadu. I'm going to talk to you about the anal canal. We have a lot of organs in the body. One of the most sensible and most powerful organ in the body is the anal canal. It is a tube which has fecal matter, fluid, solid, and gas. But it decides when to pass this fluid, when to pass the gas, and when to pass the solid because of the anatomical structure which it has. We all know, we are familiar with Dr. Park, a great man, who always said it is impossible to perform operations without the accurate anatomical knowledge. And this is particularly true in the case of fistula and ano, where intemperate surgery can lead to such disastrous results. So anybody who wants to do a safe surgery, it is mandatory that we need to know much more on the anatomy. Thanks to this great man, Dr. Morgan, in 1936, he published an article which depicts the interior anatomy of the anal canal in much fascinated way. Way back in 1936, after his illustrious work in the anal canal work, he was able to describe the perineal triangles, the anal triangle and the urogenital triangle, which constitute the upper and lower part and where the anus is situated. And he was also able to explain the interior of the anal canal, which was divided into three parts, which all of us are aware, and we are going to have a talk much later, so I am not going to talk on that much in detail. The topic for me to discuss today is an anal sphincter, and this is one of the most complex mechanism with which we are having. We have both an internal and external anal sphincters, and this is a picture which is put in the 1936 paper by Dr. Morgan, which is well explaining the concept of the different types of sphincters, both internal and external, and the details of which we are going to talk to you. Internal sphincter, as we all know, it is a thickened circular muscle coat of the anal canal, which is in continuation. It is not coming fully. It comes only up to the 2/3 of the anal canal. It is involuntary. It is responsible for maintaining the anal tone of so this structure, which we are showing as an internal anal sphincter in the midline, and it is a structure coming down in continuation from the rectum and comes at the lower end just above the subcutaneous external sphincter. It ends there and it forms a groove here, and this is very... So this is important for us to know about the... Now, the most important structure we have is an external anal sphincter, which is divided into three parts, and we say that it is as a subcutaneous part, superficial part, and the deep part. Each section is quite interesting and quite important. Please see, and this is an anal canal, and this is a subcutaneous structure, external sphincter. It is entirely annular structure. It has no bony attachment. It is just around the canal at the outermost part. It is here coming like this. There is a gap between the internal sphincter and external sphincter. When you are doing a operectal examination, that you will be able to see there is the sphincter groove or the spectrum you are able to see. So internal sphincter is here, external sphincter, but it is not always like this, the gap. When the anus contracts, it overlaps the internal sphincter. Sometimes even it can go medially. So this is the second and most important part is a subcutaneous, this is a superficial sphincter. This has attachments posteriorly and anteriorly. Posteriorly, it is attached to the coccyx with the anococcygeal raphe. Anteriorly, it is attached to the perineal body. So this is most significant. What the subcutaneous sphincter, even if you cut during your surgery, nothing much is going to happen. Yes, this superficial external sphincter also we will be able to cut sometimes, but especially when you are going to do operation on the female or in the Crohn's or in the recurrent fistula, and if you cut this, and it will be leads on to the fistula incontinence. So you need to be careful about the superficial external sphincter. The third and most important is the deep external sphincter. Again, it is also having no bony attachment per se. And it is also a circular or annular thing which is attached to the anal canal at the just above, in continuity with the puborectalis or the levator any part of the puborectalis part. And this has, but some connection goes anteriorly, and it has some fibers connected with the transverse perineal muscle, and which is attached to the ischial tuberosity. This transverse perineal muscle attachment gives the stability for the deep external sphincter. Otherwise, deep external sphincter do not have a bony attachment, or it is just a circular like subcutaneous external sphincter muscle we have. So these three are the most important pertinent structures we have. And there are potential spaces between that. There are a lot of controversial topic also. So there we will come to it later. So deep and superficial and the subcutaneous, that's the three component of the external sphincters which we are having. And this is a picture, if you see, again, this is a subcutaneous, it's a circular muscle. This is a superficial, which is coming in the anococcygeal raphe, and anteriorly which is attached to the perineal body. And the third one which we are seeing is the deep external sphincter, which is very significant one that. Professor Arun Rajanskal, which says that the deep external sphincter itself is a myth. He said that there is no gap between the levator part, the puborectalis part, and the deep external sphincter. And he proposed the theory that it is only a single muscle. When the superficial, the external sphincters has only two parts, which is the subcutaneous and superficial external sphincter. But the deep part fuses with the pubic muscle. It is working as a single component. Even when we look into the 1936 paper of Morgan, he says it is not possible to separate puborectalis and the deep external sphincter. So either it works together, or we can still consider it is a separate part, and depending upon the situation which we are operating. And this is the coronal section of the cadaver dissection, which also clearly says, and you have the separate portion of the levator ani muscle, and then we have only the two portions, the superficial external and the subcutaneous external sphincter, and we are not able to differentiate deep external sphincter from the levator ani. And this is a three-level concept of the endogenital striated muscles, which is explained by Rojanaskel. And the three component, like what we say about the three muscle, and here is the deep is entirely covered with the levator ani, and the middle one is the posteriorly you are having the superficial external sphincter, which comes anteriorly also. It continues with the perineal membrane, and here the last one is the subcutaneous external sphincter, which continues with the bulbocavernous muscle. And we also must know there is an anorectal ring, which is a very, very significant one, which plays a major role. All these fused together, all these components, the puborectalis muscle part of the levator ani, the deep external sphincter, the conjoined longitudinal muscle, and the highest part of the internal sphincter, all these constitute this conjoined tendon muscle. And we must also know another term called conjoined longitudinal cord. And this is an area of the muscle which the fuses with the longitudinal muscle, fuses and either muscles, and they form a conjoined fibroelastic sheath or fibroelastic tendon. And this is very significant because few other part of the significant areas also attached to that. This is a fusion of the puborectalis with the longitudinal muscles of the rectum. The conjoined longitudinal term is also coming. And another muscle we have is a Treats muscle. The Treats muscle has two parts, which is an anal submucosal muscle, and which helps in the fibers submucousally fixing the anal cushion. And it is a muscle area, the fibers, which has a tendency or playing a major role in fixing the anal cushion. And similarly, we have the mucosal suspensory ligament of the Park, which penetrates the internal sphincter and helps to fix it with the conjoined longitudinal muscle. This is the anal cushion. This both the Treats muscle and the Park ligament helps in the fixing of the anal cushion, which has a significant role in maintaining the continence. Then next we come to the spaces. We know there is a lot of spaces in the important. This is a levator muscle, and we have the levator ani and the external sphincters. A space above that is a supralevator space, and the space below that is a infralevator space or the ischiorectal phase. And this is a fascia or the septum which divides this space, which extends from the Alcock's canal to the internal muscular layer. And this has a lot of neurovascular bundles are here. So the area above is the supralevator, area below is a ischiorectal space or infralevator space we are having. Then we are having the ischioanal space, perianal space, and perineal space. These are different spaces which we are having. Two important anatomical concepts which we want to know. One is the deep post-anal space of Cutney. In his article, which he has well explained, this is a space which is anteriorly posterior aspect of the deep external sphincter, and superiorly the levator ani, and the inferiorly the superficial external sphincter. This is an extra sphincteric space. It is not within the space with the sphincter. It's an extra sphincteric space, and this is one of the primarily this is an area where most of the time the infections start, and it can extend to the ischiorectal, ischioanal, all other spaces it can communicate. And most of the time we must know that the deep anal space of the Cutney, which is a very significant space. There is also another space which is being described by the Karihara. It says that the posterior deep space. And this is a space within the external sphincter. The external sphincter, the deep external sphincter and levator ani, it constitutes a V-shaped potential space, and there the collection can be according to him, and this is the primary site. And Cutney says is the post-anal space is the primary site of infection any fistula in anal contain. The difference between the Cutney space and Karihara space is the Cutney space is extra sphinctery phase, and the Karihara space is on the intrasphinctery space. And this is an area where we are having this deep space.
Sir, you'll have to fasten the...
Yeah, 1 minute. And these are the different areas of the space which you see in anatomy. This is anogenital fascias. We are having the ischioanal fossa fascia, transverse septum fascia, and perianal space is constituted there. These are final slides. One of the important is anal cushion, as I told earlier. It plays a major role. Please remember, hemorrhoid and anal cushion is not an abnormality. It is a normal structure, and it is a cavernous the corpus cavernous recti. This is a plane in which the sinusoid is acting on that and is helping us to maintain the continence. Internal sphincter helps in 60% of the maintaining the continence, and the anal cushion helps the 20 to 30% of the maintaining the continence for that. Thank you very much for your patient hearing for this topic on the anal sphincter.
Only 1 minute for questions, please. Any questions? No questions, so we go to the next speaker. Dr. Rajesh.
Thank you, sir.
Thank you, Dr. Jayalal, for that elaborate lecture. And can we call upon the next speaker, Dr. Atul Deshpande, who would be talking on anal gland complex and its significance in fistula.
Just to remind the speakers that at the end of your time, Dr. Atul Deshpande, we just inform the speakers that at the end of the time, your screen will black out. So please keep to time.
Good morning, everybody. Thank you, Colorectal Foundation, Mumbai, for always organizing such theme-based conferences, which are really very useful to us. And thank you, all the organizers for inviting me here as a faculty. Our topic today is anal gland complex and its significance in fistula. This is a very theoretical topic, which is the causes of fistula formation are multiple. Where we'll be talking about cryptoglandular fistula. Then other Crohn's disease, tuberculosis, trauma are the other causes of fistula formation. In historical review, first reference of anal gland was made by Swiss physiologist Albert von Haller in 1751. Since then, we have been looking for the origin of fistula, and which we see in anal gland. Further descriptions made by Chiari in 1878, Desfosses in 1880, and in 1929, Lockhart, Mummery, Harris and others supported the theory of cryptoglandular origin of perianal abscess in fistula. Synopsis of their views was varied opinions on the relationship of anal gland and internal sphincter. The another inference was anal glands are analogous to scent glands in other mammals, and they play role in the pathogenesis of fistula in ano and may give rise to tumors as well. They extensively studied and compared scent glands and anal glands of humans, dogs and cats. They concluded that anal glands are absent in cats and anal fistula is rarest in the cats. Attempts to produce fistula in dogs' scent glands failed, but anal fistula is not uncommon in dogs. The fistula in dogs probably arise from anal glands in the internal sphincter, which are homologs of human anal glands also. The theory of fistula formation is such: first step of fistula formation is obstruction to the outlet of the duct of anal gland. Then there is formation of cystic lesion, which may or may not get infected. If it gets infected, it will form an abscess. If abscess arises in the submucosa, it may discharge spontaneously in the anal canal. A submucous fistula may develop and there may not be any symptoms. If anal gland extends through the sphincter, abscess may form in the intersphincteric plane and spread downwards to discharge spontaneously in perianal space and there is formation of intersphincteric fistula. The abscess may drain in other direction as well to form more complex fistulae. A surgical drainage may supervene if we intervene, and the anal gland rudiments may be destroyed by thorough cutting of the abscess cavity. The cause of non-specific anorectal abscess and fistula is blockage of anal gland. This is by Chiari. There are about 6 to 10 anal glands and its ducts are located around the anal canal and they enter at the base of the crypts of the anal canal. Park in his study demonstrated that half of these crypts are not entered by the glands. The ducts, they end blindly. If in 2/3 of the specimen, one or more membranes enter into the internal sphincter. In about half of them, branches cross the internal sphincter completely to end in the longitudinal layer. No branches, they cross external sphincter. Then the Schaefer and his colleagues, they also studied the fistula in infants, 52 fistulas in infants, and they noted that there is a markedly irregular and thickened dentate line. This theory implies that fistula in ano is a result of congenital anomaly or its predisposition. It makes the person predisposed to the fistula formation. But this theory does not have many takers. Pathophysiology, perianal fistula as a result of inflammation or infection of the anal gland. Abscess may or may not develop in all the cases. Infected glands are caused by obstruction of the duct by fecal matter, foreign body or bacteria. That results in stasis, the bacterial overgrowth and then abscess formation. Original report from Parks in 1961 showed that 8 out of 30 fistula cases displayed gross cystic dilatation of the anal gland. 13 out of 30 showed gland epithelium lining intersphincteric abscess or fistula tract, and 7 out of 30 anal gland present which was not part of the fistula tract. Authors so concluded that in about 90% of the cases, fistula started from the infection of the anal gland. The enteric organisms, they begin the process of acute inflammation by infiltrating perianal gland channels and spreading in inner longitudinal path, causing perianal abscess and further passing through the longitudinal muscle, resulting in ischiorectal abscess. Once chronic anorectal abscess has developed, infective material will continue to seep through any of the channel through to the skin surface. So, anorectal abscess and perianal fistula are continuous process of common pathologic spectrum. The development of anal fistula may depend on the presence of specific gut bacteria in anorectal abscess. Patients in whom E. coli and gut-specific bacteria are found in abscess are more likely to present later in anal fistula. To conclude, the underlying reasons for development of the cryptoglandular perianal fistula remains incompletely understood. The recent studies suggest crucial role of multiple elements such as histological, microbiological and molecular factors. A better understanding of pathogenesis of cryptoglandular perianal fistulas is fundamental to helping surgeons achieve better treatment outcomes. Future research following observation from recent studies might contribute to comprehensive explanation of the role of adipokines in the pathogenesis of fistula. It will also provide reliable markers for the disease course and treatment efficacy. It may also provide more rational therapeutic approaches for the treatment of fistula. So we'll see few figures how the anal gland in the adult human anal canal lies. This is sorry. This is how the anal gland opens in the crypt. Last page. This is how this is a coronal section of anal canal. It shows anatomy of the anal gland. This anal gland is seen here, and this is how it opens, and it lies in the intersphincteric plane or in just at the submucous region. This is a microscopic picture of anal gland. It contains blackish portion. It shows there is a mucus. So these are the mucus secreting glands. This picture showing fistula formation. The anal gland seems to be dilated and it will form an abscess in this short course, and then fistula formation would be there. There are different types of fistula. This depends on how the pus travels, whether it goes upwards, downwards, or in which direction it is going. This is the picture of anal canal in Crohn's disease. In Crohn's disease, one specific peculiar point is the anal gland is inflamed, but at the same time, both the sphincters are also inflamed. That is the difference between normal fistula and specific Crohn's fistula. Thank you, friends. Thank you so much.
Any questions? Only 1 minute is there for the question. If there are no questions, I think it was a wonderful talk, Dr. Atul Deshpande. Beginning of the fistula, understanding the anal gland from where it begins. I think the Fistulacon really has taken start from here. Thank you so much.
After our first speaker from Tamil Nadu, the second from Aurangabad, Maharashtra, our third speaker is from Haryana, from Himani. We have Dr. Sanjay Singla from Singla Hospital, Bhiwani, to speak on how relevant is classification of anal fistula. Dr. Singla is having an hospital of his own where he conducts a lot of workshops also on anal diseases. And I now hand it over to him for his talk on how relevant is classification of anal fistula. Dr. Singla.
Good morning, everybody. Myself, Dr. Sanjay Singla. I bring greetings from Haryana, Bhiwani, and my presentation is on how relevant is the classification of fistula in ano. Why you need any classification? For the good results of the surgery, we have to have accurate anatomical knowledge of the area as well as the knowledge of the anatomy, how the abscess, which has not been drained properly, travels into these intrasphincteric spaces. We all understand that anatomy is quite complex with vulnerable physiology. Some damage to the sphincter mechanism is inevitable, but keep it to minimum to have the good results. What are our expectations from a classification? It should give us a detailed roadmap of the routes taken by the fistula so that we can make a 3D model on the screen or at least in our cortex. Categories, common patterns should be categorized in order of the increasing complexity. Classification should guide us the method of treatment. It should be simple, a common language for the medical fraternity, so helpful in future for development and research. Goodsall, in 87, tried to explain the internal opening corresponding to the external openings, but he has more of exceptions than the statement of the rule. As we understand, we have anterior horseshoe also. Then in last 90 years, there's a lot of evolution in describing the classification of fistula and ano. Park's classification becomes the most popular, with the working classification of Park showing intersphincteric, how it goes between the sphincters or across the external sphincter. So means the basis was whether it crosses the external sphincter or not. If it crosses the external sphincter, it is transsphincteric. If it goes above the puborectalis, it is suprasphincteric. If it is outside, it is extrasphincteric. Another category has been added in 2022 by ACRS, that if the fistula is still there because of the retaining endothelium, a submucous fistula can also exist. And giving you some details about this is the intersphincteric fistula, very common to treat. You just have to cut out this much portion, take this out, and it heals. In acute cases, it can have an perineal abscess also at the lower end. So these fistulas are most common and easy to, but it can go up within the rectal wall blindly or can enter into the rectal lumen. And this is a problem here. You can have two openings, which is primary opening here, but secondary. Or it can go outside the conjointal longitudinal muscle and make a supraelevator abscess like this. At times, the lower part is not there, and you have only the suprasphincteric, this component, or it can enter also here. But the fistula can then transgress through the transverse, this muscle external, and making a low transsphincteric fistula. It can transfer here also, other also. Or in extrasphincteric component, there may be infralevator extension. At times, it can perforate this levator plate and becomes a translevator fistula, and it is a problem. you can have a fistula not opening on the perineum but an abscess in the isuretal fossa. And if the tract goes above the puborectalis, it becomes a suprasphincteric fistula, another, though very rare condition but difficult to treat. A suprasphincteric fistula can behave like this, coming down into the perineum, or may be associated with a suprasphincteric supralevator abscess also. While draining this abscess, you may iatrogenically create an extrasphincteric fistula like this. Or because of trauma, there is nothing to do with the cryptoglandular, you can have another extrasphincteric fistula. Or all these fistulae, they can have a horseshoe configuration, intersphincteric space, from extrasphincteric space, and from the supralevator space. Then, at that time, when Parkes gave this classification, it was a beautiful classification given by a surgeon, elaborating everything almost, and his paper, if you read in 1976, British Journal of Surgery, gives you detailed treatment also. But that time, MRI was not available. So then St. James University Hospital classification came. The strong points of this classification are, it is MRI based. If you have intersphincteric fistula like this, it is grade 1. If you have something with an abscess inside or above, this is grade 2. Grade 3 is a simple linear transsphincteric fistula. If associated with abscess, it is grade 4. But the problem is that they have graded suprasphincteric fistulas also into grade 4, while the treatment of all these two different fistula is quite different. Extrasphincteric fistula with an out. So the weak point is grading is not correlated with the severity, and vertical level of the external sphincter involvement is not defined. Otherwise, for an MRI person, it is very easy to tell you that from where the external sphincter has been punctured. But probably this classification doesn't show that, and that is the weakest point of this classification. I can tell you that nobody tells you that extent of the external sphincter involvement, because this was not grouped in their classification. Otherwise, they should be able to tell you that. Then while trying to simplify the fistula, a task force simplification came, and it made fistulas, trying to make simple. Simple fistula involving less than 1/3 of the sphincter complex, all other was categorized into complex fistula. But actually it is not so. Certain fistulas are easy to treat, intersphincteric fistulas. They were also grouped into complex fistulas. Then Pankaj Garg came out with a grading on the basis of the involvement of the vertical extent. If it is a low fistula, not involving 1/3, maybe transsphincteric, maybe intersphincteric, were graded into 2. If it is a high transsphincteric or with some comorbidity, it is graded 3. Other fistulas, high transsphincteric, multiple abscessive tracts, they were graded 4. Strong points are, grading corresponds to the severity of fistula, considers preoperative weak external sphincter, that becomes at grade 3. MRI based, 440 operated cases, guides management of the patients. Weak points are that he kept supralevator fistulas into grade 5. While the supralevator fistula may not be difficult to treat at times because of the intersphincteric extension to the suprasphincteric space, it doesn't cause much of a problem. But yes, it is difficult than if it is only low intersphincteric fistula. Though detailed but was confusing, he came out with another thing. He tried to concise it and added one more fistula that is called as riffle fistula, which we can discuss separately. Arun Rajanskul, who is the inventor of the lift procedure, tried to make this 3D diagram of his own classification. Instead of all these classifications we have studied, still there are certain fistulas, like rectovaginal, rectourethral, though they are transsphincteric fistulas, but they cannot be categorized as simple transsphincteric fistulas because their management will need something special. So, answer to the question, how relevant is the classification? Anatomical roadmap given by the Parkes is wonderful roadmap, even when the MRIs were not available, and this is the management of this complex disease. Goodsall's rule has limited relevance as it has more exceptions to learn as compared to the rules of the statements. Task force classification got too simple and loses the relevance. John's classification or the Morris classification should be modified to make relevant to surgeons. Garg classification is relevant as an order of complexity and deciding treatment, but a question mark. If one is doing a primary sphincter repair after fistulectomy, it loses relevance. A sphincter saving surgery, even in low fistula and like lift and other things, again the relevance is less. So how I put it, how I understand, I will take a minute of you. See in front of you an anal canal. The middle component is the external sphincter or the skeletal muscle. Anything inner to the skeletal muscle is the inner component. Anything outer to the skeletal muscle is the outer component. We all understand that this inner component is to be taken out or open into the anal canal, or you can excise it, commonly called as central disease. Now we all understand, to have good results, we have to excise this, but the problem comes when it is a supraelevator or supraelevator space. You have to be cautious, because still if you damage this area, you will weaken the puborectalis sling, because the puborectalis or the anorectal ring is not only made by puborectalis, it is made by the deeper component of the internal sphincter as well as the conjoint longitudinal muscle. Outer component were clear. If it is not causing breach in the rectum, you have to excise it, or you may drain it, curate it, and leave it open. The problem comes with the middle component. The level of the sphincter involvement vertically. If it is low, less than 1/3, you can do fistulotomy. If it is more than that, you may cut, but you have to repair it. You will never cut puborectalis. You will never cut the deepest part of the external sphincter. This will lead to 100% incontinence. And the circumferential component of the external sphincter also. External sphincter may not be breached at one place. It may have a breach in two places. Especially in posterior horseshoe fistula, at times, it is not opening extrasphincteric and then opening inside. They may come like two different tracks, opening two openings in the external sphincter, then getting one in the intersphincteric space.
Sir, your time.
So, dear friends, you have to know the preoperative sphincter status, and then you can have this thing in mind. You can play with the fistula. Thank you so much.
Thank you, Doctor. It was a wonderful presentation. Any questions from the audience?
I would like to just make a comment. I think Dr. Sanjay Singla, next conference we have to give 1 hour. He has so clearly told us what we couldn't gather till now. By drawing on the board, those pictures are not in the book. Thank you, Sanjay. You have really made a day.
Thank you.
Thank you. I have one question for you. Wonderful presentation by those diagrams which you had shown. How common is the intersphincteric fistula, which you had shown, getting up and getting into the rectum? Because you showed in a diagram, it's how? What is the percentage?
Yes.
Because that's the only confusing part, because I don't...
It's not, okay. If you understand the anatomy, there is mucosa, submucosa, the circular muscles of the inner, what we call as internal sphincter. Then we have a CLM, conjoint longitudinal muscle. Then comes the external sphincter. So when from this space, intersphincteric space, things go up, they go in between the internal sphincter and the CLM, conjoint longitudinal muscle. Or they may go outside the conjoint longitudinal muscle and make a supraelevator abscess. Pertaining to your question, if it goes up between the internal sphincter and conjoint longitudinal muscle, it will remain within the wall of the rectum. Within the wall of the rectum, it may end blindly at the upper end, or it may rupture into the mucosa, giving a false secondary opening. We have two openings then at that time. One is at the dentate line and one higher up. As far as incidence is concerned, I see in a year I operate almost 200 fistulas, and I see almost 2-3 cases of that opening inside. But other people may have different reporting series.
Thank you so much.
Thank you so much. Thank you. Good day.
Thank you. So here we bring the end to this first session now. Thank you so much. Thank you.
Come on.
Thank you, chairpersons. I'd like to invite the chairpersons for the next session, which is on imaging. Our chairpersons here are Dr. Yuvraj Singh, Dr. Fani Reddy, and Dr. Anshul Shah. Thank you.
One request for the speakers to please stick to the timings. Now, after this excellent session, let's come, after this opening session, to the first hurdle. That is, you have diagnosed a fistula. Now what to do? What to investigate? How to investigate? And most of the time then not. We are in a sort of some different planet as to our radiologist. You don't know what is reporting and what you are supposed to make out of it. So let's hear from the horse's mouth. We have
Dr. Ravi Thapar, who is a renowned radiologist in Mumbai. Almost all the complex fistulas is being reported by him, and he is the favorite of all our leaders, Dr. Parvesh Sheikh, Dr. Koshan Mittal, and Dr. Niranjan sir. He is an expert faculty of also IM Mast. I have learned from him the radiology there. So he'll be delivering this lecture. Sir, Thapar sir, please. So please do let us know what surgeons need to know from the MRI reports. How can we diagnose it, not depending upon the reportings?
Hi, thank you for the introduction. So I am Dr. Ravi Thapar and I will be discussing the imaging of perianal fistulas. So this is a very simplistic line diagram, but it is very relevant to understand the perianal anatomy, especially with respect to radiology. So that's the rectum, that's the anal canal. This is the dentate line where most of the fistulas originate. This black band is the internal sphincter, which is nothing but a continuation of the circular muscle layer of the rectum. The gray band is the external sphincter, which is contiguous with the levator plate. In between these two sphincters, this is the intersphincteric fat plane. And beyond the external sphincter, on both the sides will be the ischiorectal fat higher up and the ischioanal fat lower down. Again, on the actual images, the black band is the internal sphincter, the gray band is the external sphincter, and in between the two is the intersphincteric plane, and beyond the external sphincter is the ischiorectal fat at a higher level and the ischioanal fat at the lower level. So what are the imaging modalities available? We have MR, which is the current gold standard for the imaging of these patients, and I will very briefly discuss the other two modalities, that is conventional fistulogram and anal endosonography. Conventional fistulogram we used to do during our residency days. We have almost given it up now. So we used to inject iodinated dye from the external opening and then take X-rays in 2 or 3 oblique planes. So obviously, if the fistula has still not created an external opening, then you cannot do this investigation. If it's an abscess which has still not burst, you cannot do this investigation because there is no external opening to instill the dye form. Also, what is obvious here is that we are relying only on the bony landmarks. There is no soft tissue details, you cannot see the sphincter complex, and everything you are just extrapolating the relationship of the fistula to the sphincter and all. So really the information that you are getting is very limited, and hence this has almost been given up now. Anal endosonography is a very good investigation and it has the potential to compete with MR in the recent future. But when I say anal endosonography, I mean a 360-degree firing probe giving you the complete circumference of the anal canal. Many centers, what actually they do is they use a 180-degree probe, which is the routine probe available in the department for TVS ultrasound or for TRUS ultrasound of the prostate. And so there the radiologist has to see half the circumference, rotate the probe, see the other half of the circumference and move in and out. So that becomes very subjective and very operator dependent. With a 360-degree probe, you get the entire circumference in one image and then the radiologist only has to pan in and out. So here if you look at the anatomy, the one most conspicuous thing you see is this dark ring, which is the internal sphincter. So everything below that is the mucosa and the submucosa, and beyond that, this brighter area is the external sphincter. So on ultrasound, when something is dark, we call it hypoechoic. Something is bright, we call it hyperechoic. So basically this dark hypoechoic ring is the internal sphincter. The heterogeneously hyperechoic band is the external sphincter. And here you see this fistula, which is fluid-filled hypoechoic structure. It is between the two sphincters, so that is the intersphincteric fistula. And here you can see the fistula cutting across both the sphincters, and therefore that's a transsphincteric fistula. Also, during ultrasound, if the fistula is not very conspicuous, we can instill hydrogen peroxide from the external opening. That will create effervescence and that will increase the reflectivity. So you see the fistula now appears very bright and hyperechoic, and that makes it more conspicuous. This is an example of a typical horseshoe abscess along the posterior wall of the anal canal as seen on an anal endosonogram. But there are limitations of endosonography. Basically, we use high frequency probes, so there is a limitation on the depth of penetration on the field of view. So if, for example, there is a historectal abscess going way laterally, you will be able to identify the abscess, but you may not be able to define the lateral extent of the disease. MR is the gold standard. It is not limited by the field of view, multiplanar direct acquisition, and there is no ionizing radiation, no need to instill anything from the external opening as well. So no preparation is required. It is done in the supine position with surface coils. There is no need for endorectal coil. So in MR, we always hear these T1 and T2 weighted images. So fat is bright or hyper intense on both T1 and T2. The fluid filled structures like the urine in the urinary bladder, and for that matter the fistula, which is fluid filled, will be hypo intense or dark on T1 and hyper intense or bright on T2. Now if you look at the T2 weighted images, the fluid filled fistula is bright. All the fat in the perineum, the ischiorectal, ischioanal, intersphincteric, gluteal, all the fat is also bright. So there is no conspicuity. So what we do is the T2 fat sat or the stir sequence. So where all the fat now becomes suppressed, it becomes dark, and the fluid filled fistulous tract becomes very obvious. So this is the sequence which is the workhorse of MR perineum, and you should look at this sequence first. It makes the fistula the most conspicuous. This sequence is done in all the three planes, and in certain specific scenarios we also add intravenous contrast. So this is the stir anatomy now. So you see that that's the anal canal. So this bright gray band is the internal sphincter. That's the mucosa, and this is the external sphincter. The fat plane, intersphincteric fat plane, is suppressed and therefore not very obvious. And this fat here is the ischioanal fat. Those are the ischial tuberosities on the two sides. That's the anal canal. So this is the ischioanal fossa or the ischioanal fat. On the T2 weighted images, coronal, you can see those are the levator plates. That's the external sphincter. That is the anal canal. The internal sphincter is merging with the wall of the anal canal. So this is the ischiorectal fat, the ischioanal fat, and anything above the levator plate is the supralevator compartment. And these are the zoomed up T1 weighted images. You can now appreciate that thin intersphincteric fat plane between the internal sphincter and the external sphincter. So in all the three images, you can appreciate that thin intersphincteric fat plane, which is best appreciated on the T1 and the T2s. So when we do an MRI perineum, we want to pick up the relationship of the fistula to the sphincters. We want to pick up all the secondary tracts and abscess cavities, and if it's a recurrent fistula, we want to pick up the site of the residual sepsis. So sir just referred to the St. James classification. I'll briefly talk about it. It's grade 1 and 2 are both intersphincteric. 1 is a straight linear tract, 2 is with branching or abscess. 3 and 4 are transsphincteric. 3 is a straight linear tract, 4th is with branching or abscess, and 5 is anything above the levator plate. So this is a grade 1 simple intersphincteric fistula. So it will come from the dentate line, reach the intersphincteric plane, and then go out without any branching or abscess. On the axial images, it will always remain confined to the intersphincteric plane. So it will never go beyond the external sphincter. So that is what we as radiologists look on all the images. It should never go beyond the confines of the external sphincter. So this is an example. You see that's a fistula there. This is the internal sphincter. That's the external sphincter. This is the fistula, which is best appreciated on stir. So if here someone stands up and says, why is this not the intersphincteric fat plane? I cannot say anything. I cannot argue back. It very much does look like the intersphincteric fat plane, like the other fat, because this is a T2 weighted image. That's why we do the stir. So on stir, all the normal fat is now dark and suppressed, but this fluid filled fistula stands up, stays bright, and that is why I know this is a fistula. So why do we need the T2 then? Because now if you see the fistula here, you are seeing the fistula, but you are not understanding the anatomy well because all the fat is suppressed. The fat planes help us to understand the anatomy. So here I can see the fistula, but then when I correlate with the T2, I know that this is where the fistula is lying. This is the internal sphincter, this is the external sphincter, so I am dealing with the intersphincteric fistula. So we as radiologists need to combine the information we get from the stir and from the T1 and T2 to make the complete diagnosis. So this is another example. You can see that's the internal sphincter of the anal canal. This is the external sphincter, and that is the fistula in between. And in all the images, it is remaining confined to that intersphincteric plane throughout. Moving to grade 2, so there is either a branching in the intercentric plane or an abscess in the intercentric plane, but it remains confined to that intercentric plane. So this is an example. You see there's a fistula coming from the anal canal, divides into a superior branch and an inferior branch. The superior branch is what we radiologists have to highlight to the surgeon, because that high intercentric branch has the potential to go supralevator because it has nothing really stopping it. So that's the high intercentric branch which we have to highlight and which is sometimes clinically not very obvious. Another example, this is a abscess which is anteriorly midline at 12 o'clock, and there is a lot of edema around that abscess, and you can, because of that, we cannot be really sure what's happening with regards to the sphincter complex. So again, the other sequences come to help us out. So on the T1 weighted image, you can now see that the external sphincter is clearly wrapping around the abscess. It is not really, the abscess is not going beyond the external sphincter. So because of that, you can be sure that this is still contained within the external sphincter, and therefore this is an intercentric anterior midline abscess. The marker has become dimmer. Moving on to the grade 3, that is the transsphincteric fistula. So this will cut across the internal and external sphincters, but it will still remain a straight line. There will be no branching or abscess. So this will go beyond the external sphincter, and it will therefore contaminate the istiorectal or the istioanal fat. So this is an example. You see that's the anal canal. The fistula is starting at 6 o'clock. The fistula, no, the mouse is not seeing. So the fistula is starting at 6 o'clock and then goes right posterolateral transsphincteric and reaches the right istiorectal fossa, and therefore it's a transsphincteric fistula without any branching. Then it goes down and reaches the external opening. Moving on to next case, this is a coronal data set. I am starting way anterior, right at the base of the scrotum. मेरे बैग में I hope this time is not counted. आएगा कि नहीं आएगा? नहीं आएगा. माउस भी नहीं आ रहा है. So should I continue? I mean,
Yes, sir, I think.
So I hope you can appreciate there is a fistula just to the left of the midline. I am tracing it backwards. So this is the fistula which you have to focus on. Okay, so as I am tracing it backwards, you can see it's going horizontally back all the way, and then it goes up and reaches into the anal canal. So this is the kind of fistula. So it's starting at 12 o'clock. Left anterolateral transsphincteric and then going horizontally all the way to reach the base of the scrotum. So it's a long track, but it's a straight linear track. There is no branching, no abscess. It's transsphincteric, so St. James grade 3. Now the important thing is here, if you are doing an endoanal ultrasound in this patient, your probe will be in the anal canal. You will see the fistula going out, but you may not be able to trace it all the way till the base of the scrotum because of the limitation of field of view. So that's the advantage of MR. It has a very wholesome field of view. Entire gluteal areas, thighs, lower pelvis, even the upper thighs, everything gets covered in a single modality. Moving on to St. James grade 4. So this is a transsphincteric fistula with then branching or abscess formation. So it will go out of the external sphincter, will contaminate the istiorectal istioanal fat, and these are the most complex fistulas because they will be having a lot of branching or abscesses in the istiorectal istioanal fat. So this is an example. You can see.
You can use your mic.
मैं कर्सर ही ट्राई किया. हाँ, cursor आया. Okay, I'll use the cursor. So basically here you can see that this is the external sphincter, and there is an abscess which has gone beyond the external sphincter in the istiorectal fossa with a small air locule within, and this is the typical post-contrast peripheral rim enhancement of the abscess. Another example, that's the external sphincter. The fistula has gone beyond the external sphincter, formed a right istiorectal abscess. The abscess is more obvious on the stir image. That's the stir image. This is the T2 image. On T2, the fat and the abscess have almost the same signal, but here you can see the abscess really stands out. And this is the levator plate. You see that? That is the edematous levator plate. So it has not gone above the levator. So it's a right ischiorectal abscess. That will be St. James, grade 4. Now, this case again highlights the importance of MR. This patient had come with a single external opening in the left gluteal area. When we did the MR perineum, you see there is a tract basically starting from 6 o'clock. And then there is a branch in the left ischiorectal fossa, this one, which is coming down all the way and reaching the external opening. So that is what was clinically obvious. But there was another clinically occult branch which is showing a right posterolateral transsphincteric course and ending blindly in a small abscess in the right gluteal area. So this was clinically not obvious because it didn't have an external opening. So that is basically what MR can do, show you other hidden branches which can then be tackled at the first surgery itself.
Sir, the time's up. Can we conclude?
You counted that loss of time? I'm almost done.
Finish it off.
Almost done. 2 minutes. Not even 2 minutes. 1 minute.
Finish
so
it
this,
off, sir.
Yeah. So this is a so this is a supralevator or a anything which is going above the levator plate. That will be grade 5. So here you can appreciate this is the levator plate which is intact. But here you can see there is a breach in the levator plate. Again here you can see that levator plate, there is a breach there and the abscess has gone supralevator. Now most of the times this translevator extension has a iatrogenic cause because abscess itself really does not have the capacity to breach through the levator plate on its own. Most of the time there is some iatrogenic procedure which has caused this breach in the levator. Another way the abscess goes above the levator is basically an intersphincteric tract. So this is basically you see the horseshoe tract here and then it has a easy access supralevator through the intersphincteric plane and this is a large abscess in the left side of the pelvis pushing the prostate gland to the other side. So this is frank supralevator abscess formation. So just briefly I will not talk about the reporting format. See, this is the type of reports you get, a very verbose descriptive report as the radiologist is trying to describe the entire fistula. It becomes very difficult for the surgeons to understand exactly what the radiologist is trying to say and it is difficult for the radiologist also to describe a complex fistula. So what is better is we do a line, on that same anatomic line diagram, we draw the fistula. So this, in a very brief moment, the surgeon gets the entire information about what the fistula is doing. And then obviously he can go back to the report and read about the details, what is the diameter, what is the length and what and so on and so forth. Also what we do is that we make a glamour film whereby 5 or 6 important images which show the fistula the best are zoomed up and labeled just like we do in a MRCP. So here you can see we have labeled the internal opening, we have labeled the external opening and we have shown the entire fistula with respect to the anal canal. And so the surgeon in his busy OPD does not have to go through all the 5 films and the small images. He can just look at this glamour film.
Sir,
he can look at the line diagram.
Sorry to interrupt, can we conclude fast?
Sorry?
Sorry to interrupt, but can we conclude fast?
Yeah, I'm concluding. This is the last couple of slides. So IV contrast we use basically when a portion of the tract is fibrotic and not very well seen, does not have the fluid signal. We give IV contrast because the granulation tissue enhances and you can see the fistula in its extent. Certain complications we come across like mucinous adenosea developing in long-standing fistulas which may be mistaken for abscess on MR imaging, and coccygeal osteomyelitis again because of a posterior fistula that is involving the coccyx. This will again not be seen on an ultrasound. Thank you.
So can you give us 2 messages?
Anshul, no questions. No questions.
Okay, sir. Thank you.
I have a request from the audience. People in the back cannot see the screen. So I request them please see on the monitors. The other complaint they have is that everybody is raising their mobile to take a photo so they can't see the screen. So please think about the person behind you. Do not raise your mobile. If you want to take photos, take it. Go on the side and take the photos. Yes.
Thank you for the wonderful presentation, sir.
Thank you.
Thank you, chairpersons. So after understanding the anatomy and classification of anal fistulas and seeing or understanding regarding the imaging part, now we come to a very important and interesting session 3, that is symposium on anorectal abscesses. Here we will see the surgeons in action. So to have the chairperson for this session, may I request Dr. Lakshman Salve, Dr. Naresh Chavatia and Dr. Samrat Jankar to be come on the stage, please. May I call upon the first speaker for today for incision and drainage of an ischiorectal abscess, Dr. Hemant Patil. You take the cursor.
Good morning, everyone. Thanks to Colorectal Foundation Mumbai for giving me the opportunity. With the permission of chair, can I start? Yeah. So my time starts now. Okay. So this is me doing my JR post. My CR told me this Thursday all minor OT, septic OT is yours. I said, sir, what should I do? They said, all abscesses are there. There is a breast abscess for you. There is a infected hematoma after trauma is for you. There is a diabetic foot abscess for you. And number of abscesses. Just go and do the abscess. So I was very delighted. So let's see. First post mein mujhe cutting mila hai. What happened next to that? I'll again thank you for the organizers for giving the opportunity. So I'll quickly go on to what happened to me. No disclosures. So we have seen in the morning what is the causes for ischiorectal abscess. The topic given to me is ischiorectal abscess. So blocked and infected anal glands, as Dr. Deshpande said, is very important. There are few patients who has got underlying features, but there are other problems which has been there, which can cause fistulas other than infected glands. So these diagrams you have already seen. You have seen these are the spaces. These are the spaces are only separated by few of the suspensory ligaments of path. The bloody fistula should not travel from one part to other because it is traveling because there is no restriction and fluid travels from the least resistant path. So these are whatever you are saying, the anal glands and the fiber structures that can be easily break down. So the fistulas are notorious to go in different places. So as the spaces, the abscesses, and so as the underlying fistulas. So diagnosis, everybody knows it's a clinical examination. Sometimes we can see on a rectal examination, palpate the internal opening also. USG, endoanal ultrasound, everything has been covered. MRI, CT, I will not go to details. There are few investigations we need to know to rule out other factors which can cause the problems. Coming to the treatment part. So what is the treatment? It's an emergency situation. Incision drainage is the treatment. What are the principle of abscess drainage? Now here comes what my CR told me. Sir, mera dance ho gaya. What should I do? How I drain the abscess? Kuch nahi karne hai. Go there, see the most pointing part, take a big incision, put your finger, break all the laculi, remove the pus. Sir, bleeding hua to kya? Just pack it and come out. This is the simplest way. Is it the simplest way for everyone? Bas. So, what is the difference in ischiorectal abscess? And there is difference in the breast abscess, a diabetic foot abscess, or a traumatic hematoma which has got infected. So the difference in ischiorectal abscess is this is not a local tissue is infected. As you are seeing how the development of fistula is the gland, block glands, a cystic formation of the collection, and then it becomes infected and forms an abscess. So the pathophysiology is totally different. In a breast abscess, there is a local tissue which is infected. In a hematoma, there is because of trauma, the local tissue has got infected. In diabetic foot, the local tissue is infected. So we need to drag down all the septides and remove all the sloughy material because the local tissue we want to clear. Here the pathophysiology is totally different. If within these 2 minutes I can change your approach to the management, I'll be happy. Oh, it's 3 minutes waiting. Please don't count this. इतना सिंपल दिया इसके लिए बंद कर दिया जल्दी 2 मिनट से ज़्यादा नहीं क्या गिवन 6 मिनट्स उतना टाइम में तो हम लोग ड्रेन कर देंगे जितना टाइम एनेस्थीसिया देंगे इट्स ब्लैंक हियर आल्सो नहीं यहाँ पे है
It's done.
So what is the patient position? Anesthesia already, somebody has already started anesthesia, given the anesthesia. What is important is extended lithotomy position, what I give. Patient comes out of the bed at least 1 or 2 centimeters beyond the edge of the bed. This is the position. Anybody has sat in front of the patient and thought for 2 minutes, ये abscess का fistula opening कहाँ हो सकता है? I want to change your approach looking at the patient. So if this is a fistula and you are given a position, wait for 2 minutes or 2 seconds rather. Goodsall's rule is there for us to give a route map. We are used to for the GPS now. So If the abscess is above, you have got a simple tracks. If your abscess is below, think of a complicated or a horseshoe track or a posterior midline opening. There are exceptions. Dr. Singla has told a number of exceptions. Most important is the long entry fistula is the exception. We are not going to 100%, but at least sit in front of the patient and see what is that. So first step is what? Just do an aspiration, take out the pus, send it for culture sensitivity. What is the next step is finding a fistula track. Just put in methylene blue or hydrogen peroxide and you can get a, see the anterior opening at the fistula. So what is the important? My topic is drainage. I will not go into the fistulotomy. What is important is simple drainage. Put a small nick, drain out the pus. Don't make too much of loculi. Don't make a bigger incision. Your incision should be as close as to the anal verge. If at all you are not getting a fistula opening, so next time the fistula tract will be very small. So this is the way you have to drain out. You don't have to put your fingers, don't have to break the loculi. What is you are going to harm by doing that is you are breaking the blood vessels and the pudendal nerve fibers. So you don't do like that. Just a simple drainage is very important. This is video given by my friend Lakshman. Thanks to you. So what I do is a fistulotomy. I got a track straightforward and no IND, straightforward fistulotomy is the treatment. So what is important principles in the abscess drainage? Look for the opening, internal opening. What are the ways how to look for? Next speaker will tell you how to go do that. So stab knife, simple small cruciate incisions, just drain the abscess. Don't be too much of rigid for breaking out the loculi. Just drain the abscess and give a wash. Come out. Some people do a corrugated drain and just do a saline wash for in the follow-up dressing. What is important is your post-op care. So if at all 95 to 7% you can see the underlying fistula opening. If that is okay, then you can do a fistulotomy once and for all, job is finished. Thank you.
Questions are allowed? Questions?
So I am JR1. You can bombard me with n number of questions. I am ready to face the viva.
Okay.
No. I said no. No packing. Just drain it, wash it, ask the patient to come for follow-up or they can do a saline wash at home.
Okay. You said the Goodsall rule is the guiding force, guiding most of the time. Is it always right that Goodsall rule?
I said there is exception. Dr. Singla also said there are n number of exceptions. I said those for tier 2 or tier 3 cities where there is no MRI, they could not find the abscess on clinical fistula tract on clinical examination. So wait, there is a roadmap. This is not that every time roadmap will be right, but at least you will get some amount of idea that rather than just hurrying, just doing a drainage, wait, just put a methylene blue, just put a hydrogen peroxide. If at all it is giving you a roadmap, finish off the surgery same time, no second surgery.
So Goodsall rule is not always applicable in
Yeah, it is. There are a number of long anterior fistula is one of the biggest exceptions for that. But 95% you can locate the internal opening. So that is what my talk is. Just drain the abscess as near to as possible to the anal verge. Wait for that fistula to mature.
So next speaker will talk on that about fistula opening and what to do about the fistula opening. So I asked Dr. Kushal Mittal sir to give talk on the next topic.
I'm going to be talking about primary fistulatomy for esophageal abscess. As Hemant has already mentioned, you can get 95% the fistula opening inside. We don't look for it, or we think it's not important and we go ahead and do the drainage. Perhaps it's time to change. So you see all fistulas, all abscesses, doesn't matter where it is, has a fistula tract. That in green is the fistula tract. When you do an MRI, please focus on that fistula tract, and you will see that fistula tract can be seen in the abscess. This is the ischiorectal abscess, and the fistula tract can be seen. So locating the opening is quite easy. Go to the medialmost part of the abscess, aspirate 1 cc of pus, put in 1 ml of methylene blue with a couple of drops of hydrogen peroxide, and it comes into the internal opening. And you know where it is. So from the internal opening, pass the probe, come out where you have injected. Pointer is, so you go from inside, come out, and just do a fistulotomy over that. Why is this important? Because when you do a primary fistulotomy, the recurrence is 2.8%, and when you don't do it, you just incise and drain, it's 40%. So the internal opening is invariably at the dentate line. You got to remember one. Secondly, primary fistulotomy is done from the internal opening to the medial edge of the abscess, not from outside inside, but from inside outside. So this is this is your abscess, and this is how you're going to cut it, and you do a primary fistulotomy. Now the question is, how much sphincter can you cut? In females, anteriorly nil and posteriorly 30%, in males anteriorly 30% and posteriorly 50%. If that much sphincter can be cut, then why cannot do it? But if you're cutting that much, you also have to close it. So this is a primary fistulotomy in a very large abscess in a young unmarried female. So do we do a cruciate incision? No. Her ultrasound shows that there is a tract, and if the tract is there, you have to find it. The probe is inside the tract, and I'm just cutting it. The moment you get the pus, you stop, because that portion is the fistula tract, and you just have to excise that portion. The rest is only a cavity where the pus is collected. What's the point of doing a cruciate incision? To drain a cavity where the original problem is the fistula tract. So take the fistula tract out, clean this hole, just do a lot of curating till you see fat coming out. Make sure that is done. Put a small tube in, and 5 days healing. Can you imagine a healing in 5 days? So, ischiorectal abscess, primary fistulotomy, I advise avoids subsequent fistula surgery, and that's what I've already told you we have to do. So this is a large, sometimes when you give anesthesia, the pus starts coming out itself. So press on it, put your SIM speculum inside, and you will see the pus coming out. And if you see the pus coming out, you know there is an internal opening, and from there you come down the external opening. Since I have a waft, I go inside and look for it, but you can do without it. All you need to do is curate it and simply cut the muscle. If you cut the muscle and you think the muscle is less than 30%, well and good, leave it open, you can splice the edges, and that's it. You finish the surgery, and do it beyond the inner word so that you can irrigate it post-op. Now, American Society of Colorectal Surgeons, what they say is the role of primary fistulotomy at the time of abscess drainage remains controversial. But they said if it gives you a gain and no loss of muscle, then you should go. The biggest problem is false tracts. Now, if you do a false tract, the reason is because we point the probe upwards and not at the dentate line. And this patient, what you see here in the center, had an abscess and he was probed, and you see 3 internal openings made because the probing was wrong. And that's what it looked from outside and inside. We don't want this. In the process of trying primary fistulotomy, don't do this. So if there's incontinence, there may be 3%, if you do a primary fistulotomy, 3% had recurrence, 39% had some post-op sphincter disturbance. And what can you do? Well, this is excising the internal opening. Then you take out the whole fistula tract. Then you can wash everything, curate everything, then close the external anal sphincter with 20 PDS, and close the internal sphincter with 30 polygalactin, that is Vicryl. Let's see it in action. This is a video by Dr. Kamal, thank you. Just put it in, you see it's coming out, you know where the internal opening is, make a small incision, drain all the pus, look inside, clean it, wash it, and then put in a speculum, and you can push in the dye to see where it's coming from. Obviously it's coming from outside. And one of the important things, like I said, incise the internal opening. That is, incise the internal opening with a 5 millimeter margin of internal anal sphincter up to the intersphincteric groove. Then curate everything, and this was extending to the base of scrotum. So you can't leave such a big abscess like that. You need to put in some sort of a ceton or a drain or something in there. So infant feeding tube was used to put in. And then this is the external sphincters are closed. with 2-0 PDS. And the distal part is left open, and inside you can close with PDS if you want to, with Vicryl. So this is closing the external anal sphincter. Just a couple of sutures are suffice. And that's muscularizing the edges so that they don't collapse and close. So again, putting in methylene blue, you see where the internal opening is, and that's how you trace the internal opening and make a small incision. And since you have a 11 number blade, that's all. 4 millimeter incision is all you require. Why do we need to make large incisions? And through that, put the probe in, and over the probe, you can cut the whole tract. And cutting this tract, you have to just be careful that you have taken all the components of the internal opening. That means you don't leave any anal gland behind, so you take a margin and clean it out. That's managing inside. That's taking out the internal opening. And after you have done that, you're very sure this is not going to recur, and then you can close the muscles, as I mentioned, with PDS, muscularization of the edges. After that, so most abscesses can be managed by primary fistulotomy. We should start doing it. If you feel after doing it too much muscle has been cut, whenever you're doing it, always feel the anorectal ring. You should not go anywhere near the anorectal ring. At least have 1 centimeter margin, then you're safe. If you're going up to anorectal ring, you're not safe. If you do it, then you got to stitch it. You can't leave it like that. I invite you all to our Akarsicon 2023 at Indore. Stall number 1 is for registrations. You can go there and do the registration. Thank you so much.
So, any questions? Any question?
Sir, how will you, how will you assess the sphincter involvement? How much sphincter is involved? How will you assess, sir?
So, you assess by putting the probe inside, and you feel the amount of sphincter over the probe. If you actually cannot feel the tract itself, that means it's quite deep. But once you put the probe in, you get a good idea. After you've done enough fistula surgery, you get a good idea how much muscle is there. If you feel the muscle amount is too much, or if you're doing it anteriorly, the muscle amount is too much, don't do it. Or if you do it, it's okay, but you need to stitch it. You can't leave it open like that. You don't want incontinence. If I didn't go because this is a video session, if you read literature, the amount of incontinence is significant. It's not significant when you compare it with just incision drainage. So this is the experience which will tell you how much muscle is there. Basic rule of the thumb: when you put the probe, you feel how much muscle is there.
So and if any doubt, then we should put a set on and come out.
Yeah. See, basic principle. You find the internal opening, you put a probe in, you find too much muscle is there, just drain it and put a sit on. You feel the muscle is enough that you can cut it, you do a primary fistectomy and come out. So
thank you, sir. Thank you, sir.
Yeah. So, sir, every time hydrogen peroxide or methylene blue will not come through the internal opening.
Yeah.
And then how will you proceed for fistulotomy in such abscesses?
Don't do it. Don't do it. IND.
Okay, just an abscess and drainage.
Yes.
Incision and drainage, and
don't make a false tract. You can't find it, leave it alone.
For the experts to manage.
What I'm saying, 95% you can find it.
Okay.
But if
you
can't
cannot
find it, leave
it to the experts or whatever next time.
If it's going to develop in 60% of the cases, it will develop over a course of few months, then you manage it. But your job is to make the incision as close to the anus as possible. The fistula tract is going to be small. How far out the abscess is of no concern to anyone.
Any cases you do MRI preoperatively, it will help you to identify?
I met a few people who asked me, MRI karte ho? I do MRI in about 80% of my cases.
Even
most of them are
abscess?
Mediclaim, yes. Abscess especially, because I really specialize in abscesses. So I do it because I need to know. And all these abscesses are complex abscesses, not just one plane. It's like ischorectal abscess, postanal abscess, ischorectal abscess, or even suprasphincteric. Yes, I will do an MRI. Not for small perianal abscesses, but everything else.
Okay. Here I would like to invite next speaker, Dr. Shekhar Suralkar, for his talk on drainage on low intersphincteric abscess with fistulotomy.
ये आगे का ना? Okay. At the outset, I would like to compliment Dr. Niranjan Agarwal for making this a very fabulous and magnificent event. In my history of ACRS, I have never seen a hall so much full that even the rear side, people are finding it difficult to get a seat. Let's give a big round of applause to Dr. Niranjan Agarwal and his team for making this event a very grand one. I'm going to speak on drainage of low intersphincteric abscess and primary fistulotomy. For a beginner, this is the best way to learn a fistulotomy in an abscess, because low intersphincteric abscess is the most common. 70% of the cases you will find this type of abscess, and it is within 2 centimeters of the anal verge. And more than 90% the tract would be in the same sector. So it will be very easy to find the internal opening, which is at the dentate line. And you can see the abscess collection always starts in the intersphincteric space. And from here, it is spread in different directions. The most common route is taken. No, I want to pointer. What? Okay. This is the place where the pus collection would be there. And from there, it is presented at the anal verge. So whatever you do is very minimal space, minimal sphincter you will be cutting, and there is no chance or complication of incontinence. And as my previous speaker has said, you should make the opening as close to the anal verge as possible, because in case if the fistula occurs, it will be very easy to dissect it. And what is the advantage of primary fistulotomy? Because in any abscess, in any perineal abscess, there is a 50% chance of recurrence. So you can avoid this recurrence very well if you do the primary fistulotomy and in this low intersphincteric abscess. These are the various places. All the patients are not same. If you attain mastery in dealing with the low intersphincteric space, slowly over a period of time, as my previous speaker has shown, you can even do the primary fistulotomy in complex abscesses as well. So this is the low intersphincteric space. I have made the opening as near as possible. The another one is the transsphincteric abscess. Since it was already presenting little away, I made the opening directly on the top of that. And then this is another very unusual case. The low intersphincteric space has presented inside the anal verge. It is just that space which is presenting, and in such case, you have to do a minimal incision. I have given incision in the intersphincteric plane. And you have to just do the internal sphincterotomy as you do in fissure in nano. That's all. In case of, I am especially showing this transsphincteric abscess because that topic was not covered. Here the abscess has been drained and I have passed. You can see that it is in the almost same sector, and instead of doing the primary fistulotomy, I have inserted the probe and I have inserted the primary draining set on. So it can be removed after a time span of 4 weeks. It doesn't give any incontinence, the wound heals very well, and there is no recurrence. So in a nutshell, friends, if a abscess is present, this is a small video of fistulous tract. The opening, you can make the opening, you can negotiate and
cut directly over it without any fear of creating incontinence. For a beginner, this is the best way to do the primary fistulotomy. And you can see the amount of sphincter mass is very minimal. You have to just skew it out and extract the infected anal gland, and that will give almost recurrence-free disease cure to your patients. So recurrence is drastically reduced patients if you do the primary fistulotomy, and incontinence, even in complex fistulas, is very minimal. And healing with ceton is also very faster. It doesn't give any complication, and the wound, water abscess collection is there, it drains over that, and patient doesn't get any recurrence. With this, I thank you. I'm most happy to welcome any questions.
Okay, any questions from the audience? Yeah.
No, absolutely there is no pain. I have been putting this ceton even in complex fistula after lift also I do draining ceton, and in the various complicated abscesses also I put just ethylon, 2,0-ethylon. Even patient doesn't feel the presence of that. He can move with that ceton freely, he can see it, he can work. Draining ceton.
Okay.
It's a draining ceton.
I thank Dr. Shekhar Soradkar, sir.
Sir,
for
a
his
question. Clinically, how do we know it is a low intersphincteric fistula, abscess?
Hello? Yeah, please.
Sir, clinically, how do we know it is a low intersphincteric abscess? Because if we want to take the incision where you showed, we should preoperatively know that it is an intersphincteric abscess.
I think my previous speaker has already deliberated on the classification of fistula, where the very presentation of various fistulas are very clearly marked.
Okay. No, we are shortage of time, so we'll just conclude this session. I mean, this talk, because we are running out of time.
You can ask me after the session.
Yeah, you can after. Yeah, thanks. I welcome. I asked Dr. Jaisingh Shinde, next speakers, Dr. Jaisingh Shinde sir, to give his next talk on his master video of drainage of high intersphincteric abscess with primary fistulotomy.
I must thank Dr. Agarwal and Dr. Niranjan Agarwal and Dr. Parvesh Sheikh for giving me the opportunity to come and present my talk on this podium. Yeah, it's good. And पुढे कसं जायचं? मी असं आहे ना? My topic is drainage of high intersphincteric abscess with primary fistulectomy. We have already covered that the anal glands, it's a cryptoglandular infection. The hypothesis, the anal glands are situated in the intersphincteric space, and this occurs as a result of infection of the inflammation in the crypts. There is obstruction in the crypts of Morgagni, so there is blockage, stagnation, and this leads to the abscess formation. Some of them, now this is the picture on which we are going to our hypothesis based. This is the internal sphincter, external sphincter, this is the intersphincteric space, which is a potential space, but because of collection of fluid, it really expands in size. Those below will be the low intersphincteric abscesses, those above, but they will not cause the levator ani. So this is what we are going to discuss, how we are going to train this area. And aortic sepsis is one of the commonest surgical emergencies faced by all of us. The recurrences are common after doing, if you do only an incision drainage, the recurrences are quite common. And 80% are associated with formation of fistula in ano if you do not do a primary fistulectomy. So that is the significance of doing a fistulectomy. In a fistulectomy, as has been already all of us know, that it involves cutting along the whole length of the fistula or the abscess, you can say, to open it up so it heals as a flat sector. This surgical treatment is very effective for fistulas with minimal sphincter involvement, resulting in healing in 90% of properly selected cases. Marsupialization of the fistulectomy edges has proved to be decreased incidence of recurrence and postoperative pain and hemorrhage also. Here, I would like to say that it needs to be emphasized that the operative treatment of anal fistula is often far from simple and calls for both caution and boldness based upon wide experience of the disease in its various patterns and a confident appreciation of anal anatomy. This is what Golliger has to say about this. There are few operations in surgery where the quality of the result is so much influenced by the technical skills of the surgeons, which means we should be well skilled to do these procedures. Now this is a video which I am going to show. Things are difficult because patient only comes with pain, doesn't allow examination, and there may not be any signs of perineal signs on the perineum to say that there is an abscess. So under anesthesia, you have to examine this patient. Here we have given spinal anesthesia, a proctoscopy is being done. You can see there is a bulge in the anal canal or just above in the rectum. Above the dentate line there is a bulge, and most probably that I think that is the abscess. All attempts are made to identify the internal opening. In majority of the cases, one will be able to identify the internal opening. Then just to confirm, we can do aspiration of the suspected area where boginess is found. It is easy when you get a boginess like this, but at times you will not get any of the signs, so it is best to aspirate. Once you aspirate, and I already know where the internal opening is, it is always going to be at the dentate line, even in high intersphincteric fistulas. And if it is very rarely, it can be above that. And in that case, majority of the times, it is an iatrogenic opening that has been caused. So this is you can see the amount of pus, that means the amount of space that has been expanded because of the pus. The internal opening is already visible there. So I just lay open the whole thing. So this is what we mean by a primary fistulectomy. Then a part of the lower border of the internal sphincter may also be divided while doing this. It doesn't cause any harm, and the cryptoglandular complex is excised. Whatever is remaining is cauterized so that the crypt is destroyed in that particular area, and hemostasis also. You can put in a finger and find out, assess the depth. Here you can see the internal sphincter is anterior to my finger. Hemostasis is achieved by cauterization. See, this is the internal sphincter, this is the external sphincter, and this is the intersphincteric space that we are talking about. A video, right? Here video. Okay. Video is not running. Actually, this video is supposed to show after the drainage, after maybe 48 hours, 72 hours. I want the video, please. We know that the space is there. We take the patient for dressing again. So that is the time I wanted to show how the intersphincteric space is wide and it is quite big. Just as in TEP, we create, there is a potential space which we enlarge into abscess, enlarge and then put a mesh. Here similarly, this space is quite, no, I want this video. टेबल डाउन बघा ह्याच्यात आहे ह्याच्यात आहे ना प्रेझेंट हा ना व्हिडिओ चालत नाही हा हा व्हिडिओ नाही जमा हां काय
Sir, do you have anything to speak or it's a last video presentation?
We have two more videos there.
Because time is up, but I think if they are not able to play it, they will try. but we can discuss.
So what
We
this,
can discuss.
The clip intended to show was that the space is quite large, and I have put a colonoscope inside, and just that you should get an idea of the space, how big and high the space is. So that is the intention in showing.
Sir, how much? Sir. Shinde
Yeah,
sir.
yeah.
How much entrance sphincter can you divide?
You can do one-third of the entrance sphincter. Up to the dentate line, there is no issue. Up to the where the abscess openings are there, you can safely divide. You don't have to repair or anything.
And it is, suppose intersphincteric abscess is high, then up to what level?
Even then, the opening is going to be at the dentate line. So
Right,
you
sir.
don't have to do anything for that. The other clip that I wanted to show was that if you cannot see the internal opening in spite of all your efforts on the examination, what I do is where I suspect that the abscess is collected, I aspirate, then throw that pus, take 2 hydrogen peroxide methylene blue, inject, and invariably I have been able to find the internal opening
Yes,
and
that
then
is-
do the same procedure as I have shown.
Yeah, that is the best way to identify the internal opening.
Can we play the video?
Sir, can you conclude the session?
So to conclude, I would say that one must attempt to identify the internal opening. You will find it in 95% of the patients, and you must do a primary fistulectomy so that otherwise these abscesses will result into fistulas in about 80% of the patients, and then they will require repeat surgery. If you do a primary fistulectomy, this may not be required. So that is how it is. It is worthwhile doing a fistulectomy, and the chances of recurrence and repeat surgery are very few.
Thank you, sir.
So we will conclude this session here. We are not able to play, I think, that video. So
Thank you all the speakers. While doing incision drainage with primary fistulotomy, one should have a assessment of the sphincter, either pre-op assessment and MRI, or by intraoperative assessment of the sphincter involvement. Then only you divide the sphincter. Otherwise, patient will have incontinence. So assessment of sphincter while doing primary fistulotomy is very important.
Thank you so much, chairpersons. We'd like to move to the next session. We are already running a little short on time. I'd like to invite the moderator, Dr. Praveen Gore, for the debate on primary fistulotomy in abscesses of the perineum. I'd also like to invite Dr. Sanjay Kolte and Dr. Pankaj Modi. Dr. Praveen Gore to do the honors, please.
Thanks. Good morning, everyone. Moving straight away, can I invite Dr. Sanjay Kolte? Now, we have seen a lot of discussion, the whole session on perineal abscesses and drainage and all. Now, we will just go ahead and make a final judgment. I'll call it. Come. Sure. Dr. Pankaj Modi also on the stage, please.
याच्यावर क्लिक करू का याच्यावर नाही सर याच्यावर हां लगा के रखते हैं ना नहीं चलेगा इसमें चलेगा वीडियो इसमें है दिस इज स्लाइड दिस इज after their photo session is over Should I begin? Morning, sir. Morning. Since this is a debate and we are hearing primary fistulotomy since morning now, and people have already batted Dr. Mittal sir, so Tendulkar, Virat Kohli, and already they have batted for me. So I don't know what to say more to convince people and everyone. But still, this is a debate, so I probably go ahead with this thing, and I do give respect to my the colleague. It's not happening. It's not working. So fistula armamentum, we all know that these are the things which are already there. The Marvel, the Disney's, we all have this. And we still discuss primary fistulotomy in the beginning of the conference. So I feel there is still a place for this surgery in perineal abscesses. And sorry, there are no political interests here. So please excuse me. Since I'm in Mumbai, I should say this. So available literature for both pro and against is still limited, as Dr. Mittal also, sir, had said. And taken all abscesses for itself is wrong, as we need to segregate simple and complex, and probably based on the risk of incontinence. When I started studying about on Google, there was hardly any this thing for pro and against as well as pro. But then yes, when you have quotes, you don't get anything. So that's the thing. There are no results found for both. So why are we saying for or against? So first, when I'm saying for, it is like it's a single setting. It's definitive treatment, better quality of life. The pain, suffering, monitor loss is less. The days you suffer from this disease is less. You're not operating for abscess first, spend 3 weeks, and again go for another 3 weeks. 3 weeks of surgery next time. The single sitting, yes, we are just worried about those 20% cases which are complex ones, where we do not wish to have this procedure done, because then we do not want a patient to have an incontinence. The data that we actually go through, that yes, every perineal abscess can have either spontaneous closure, or there may be 70% cases which may result into fistula. But that data itself is actually studied only for 18 months maximum trial, which is not being studied for a long-term trial like years. So we do not have that much data. So confirmation of whether they develop fistula or no. As we since morning we are saying this is an anogranular disease, and it has to be there has to be some start of this disease, right, from the anus. So we should always consider that this is going to form a fistula and try to treat at the same time. And yes, depending on the risk of continence, if you have a low intersphincteric, high transsphincteric, or high intersphincteric, or high transsphincteric abscess, we need to consider depending on that and surgeon's knowledge. Everyone has discussed about how to identify the internal opening. Yes, before drainage, we put a manual pressure on the abscess cavity and see inside, trying to identify the culprit duct. Maybe sometimes it's a simple probing and injection of course, hydrogen peroxide with methylene blue. So see, this is an abscess we have already seen since morning. So abscess which has been first initially pressed from outside, identified the internal opening at 9 o'clock, and then we went ahead with fistulotomy at the same sitting. Why anyone doesn't want to do a fistulotomy at this stage? Of course, everyone should be doing fistulotomy. Why patients should suffer for the next time? This is another similar case where the abscess was posteriorly, you inject, you aspirate, and you confirm that there is an abscess and induration. You inject in the same opening, again the methylene blue, and you see the internal opening at 6 o'clock. And the same thing, since these are low intersphincteric fistulas, you can just drain the abscess as well as you do the primary fistulotomy. High intersphincteric abscesses. Yes, of course, when you have such kind of MRI experts with you, like Dr. Ravi Thapar, who has already explained us how to, and you have similar kind of MRIs, you read yourself, or your colleague radiologist is helping you in this, you can definitely attempt certain high intersphincteric abscesses as well. So this was an intra-anal fistulotomy done, and this was the result. 45 and 60 days this thing was closed. I thank Dr. Samrat Jankar for giving me this video. The high transsphincteric abscess. So such kind of abscess, if you are, see here, there is an abscess at 6 o'clock and the opening, small opening. Here you can see the opening at 6 o'clock of the abscess. Then you can just go and do a transsphincteric dissection. This is a prone position patient. So you can see it's 12, you can now understand this probably at 12 o'clock. You do a transsphincteric dissection and trying to identify the internal opening, do a fistulotomy at the same, with the probe, you can dissect the same track going behind, and drainage along with primary fistulotomy can be done. And then made the patient again in supine position and irrigated the other wounds, drainage. So when you see the literature, this is a Cochrane study which was which was done in 2010, and there were 6 trials which were seen, and there were 479 patients, and all that there's a significant reduction in recurrence, perianal abscesses, repeat surgery in favor of fistula surgery, same at the time of the drainage. Another 1997 article which also suggests the same, that primary fistulotomy at the time of drainage of perianal abscess results in fewer persistent fistulas and no added risk of fecal incontinence. This is a Bulgarian study, again the same, which says that primary or ligation fistulotomy should become a method of choice for radical treatment of anorectal abscesses, eliminating the possibility of recurrent inflammation or fistula in ano. Not only in adults, there were studies which were made in neonates as well as in children where fistulotomy was advised at the same time. This is very important to note, that even in the children, we need to do a fistulotomy at the same time. So in my conclusion, I will say low intersphincteric or low transsphincteric fistula, simple fistulotomy with IND, high intersphincteric, of course, along with intra-anal fistulotomy, and transsphincteric, depending upon your this thing, either you can be safe by putting a set on, or you can just go ahead with fistulotomy. If there is some sphincter can be compromised, yes, as Dr. Mittal said, you can compromise some part of this external sphincter and still do a fistulotomy. Thank you everyone for your patient hearing. I thank Team Fistulacon for giving me this opportunity to speak. Thank you so much. I rest my case.
Thank you, Dr. Kolte. We will take the question answers in the discussion time frame. May I invite Dr. Pankaj Modi for his talk against doing a fistulotomy for perianal abscesses.
Pankaj, 3B2. Fine. Great. Okay. From here also? Okay. This okay. Start. I think. Okay. Good morning, everybody. And thank you, Parvez and Niranjan, for giving me this opportunity, this thankless job. I think whole audience is in favor of fistulotomy at the time of IND. I have been given the job that don't do it. Let us see. This is what actually happens if you try to do something which you are not used to do. This is where you can end up with like this. That's what I want to convey. If you don't know ABC, don't do fistulotomy. Simply go ahead with IND. This is I'm not going to go in much detail of this. Everybody knows the ABC of the anatomy. These are the various, so there are so many of fistulas. And particularly when you are doing IND, many a time, particularly younger surgeon, they don't know exactly at which space they are working. And in enthusiasm, they will try to do always a fistulotomy because it is glamorous, it is a one stage, and result may be better, and you can explain very easily to the patient. But is it always right? I don't think so. Though, as a disclaimer, I say I still do sometimes fistulotomy, but here I am going to say for everybody, not for myself or some very senior surgeons or good surgeon who always do it. But there is if you want to say in one sentence, if in doubt, don't do fistulotomy. These are the various spaces where you will find it. I will just run through it. This is just to complete my list. There is a one, please sir. This is the one in that book, it is written just for writing whether you are the back paper will not. 2/3 of patients with anorectal abscess never progress to fistula in ano. So more than 50% of the time it is a prophylactic fistulotomy. It doesn't mean that there is no internal, there may be internal opening, there may be or may not be, but it is not necessary that all patient who has this will progress to fistula. So why to do prophylactic fistulotomy? So that can, and the second, it is always an acute disease. From day one, I have been taught in 88, 89 by my teachers, do no harm. And that is the motto of not doing fistulotomy. Most of the time, in enthusiasm, you are likely to injure, and there is no marker or the criteria or the meter which will say you have cut only adequate sphincter and not more. Inflammation is always a nemesis of a surgeon, particularly fistula surgeon, and it will create a problem not in the same. And that is for you are not sure whether patient is going to develop fistula or not. This is the, again, these are all just to, for that purpose, because this can be the actually, from outside it may look very simple fistula, but it may be iceberg. 2/3 may be inside. And in enthusiasm, once you start doing it, you may go up to levator ani and create a problem. Nothing to take away from the persons who are doing fistulotomy, but this is the other side of coin, which I am trying to show. It is not always rosy. You have seen so many videos. It looks excellent. It looks, and it is not as easy as the experts have shown. As an average surgeon, be ready not to do it. When not to do it, it is individual. Again, there are certain fistula which can, abscess you can do very well and no need to do the fistula because they are simply abscess. Why to try to find even internal opening? Don't try it. Simply come out with IND and it should be all right in 40 to 50% of patients. If you say 80% develop fistula, I don't agree. Literature also shows only 40 to maximum 50% of the patient who had undergone IND developed fistula, not all of them. So this is the various classification. We don't need to discuss last two. This is the actually where we do it. But the point, sorry for the slides, because the last moment is prepared, but this is what people do. And when not to do it, this is a one slide message. If you find this patient had a Fournier's gangrene with perianal abscess, never ever try to find the internal opening. There might be internal opening, might be initiated of that, but never try to, you will end up with a lot of problem. The same my patient, we did a fistulotomy in a second stage with putting a set on, but not at the first stage, because the life is more important than result. Treatment. Usually we put a cruciate incision, which is been taught in a first year residency. Always cruciate incision, that has been taught to me. This is anorectal and fistula are common cryptogenic disease which are more common between 10 to 50 years of age. At presentation, fistula is associated only, literature says 26 to 37% of the time. So this is not actually recurrence. This is at the time of doing IND. In a simple, it is only 35, at the most 40% of the abscess patient will have an actual internal opening. Many a time in enthusiasm, we feel that this is internal opening, and many surgeons do not use methylene blue and will end up with the problem. This is the chronicity of problem. Why to make it? So when you do only IND, if it occurs, it is sequelae. If you do fistulotomy, it occurs, it is a recurrence. We want sequelae, not the recurrence. These are the some of the journals. They say drainage of abscess fistula develops in 45% at the most. In according with the most, which say 35%. This is the actually one of the, say, in their study it was 45%, higher side. Literature say it is 35%. This is again, they say the choice of method is, there is some controversy still going on. That's why we are here. So many surgeons recommend that do only IND and leave for the next day when the fistulotomy may be required. At the most, they recommend that you can do set-on and not the complete fistulotomy. So it is a chronic disease, more sphincter loss, particularly in the presence of inflammation, better delineation of subsequent fistula when you go again next time. And surgeons experience judgment. It is many times MRI may be misleading because of the associated inflammation. They may give wrong idea about that. So MRI has a limited value when there is a presence of abscess. And recurrence after second stage fistula is less compared to recurrence of fistula after primary fistulotomy. These are the some already discussed. These are the disease where you never do it. You should not. This is against that. Drainage and all is strongly recommended for abscess where high intersphinctering suprasweat. That is a very obvious. IND only alone puts only a few patients at the risk of recurrence. The prudent rule will be to defer a fistulotomy till a fistula become obvious rather than to do a prophylactic. Thank you very much. Yes, you have a right to soar high, but keep your feet on the ground. Thank you very much.
Thank you very much.
So we'll have a stand or which is better stand?
Sit.
No problem. This is your side.
Yeah. Hi, friends. A long session of perineal abscess. Because we are running short of time, we will just make it as short as possible. Can I request you one thing? Can everybody raise their hands, please? Everybody raise their hands. Everybody. Thank you very much. Now, only those who have questions, keep their hands up. Otherwise, you can keep it down. Very good. Yes, please.
That abscess should not develop into the fistula.
He is asking about how do you counsel the patient?
Okay. Convince the patient or treatment or the dressing. What do you want? I don't understand.
What precautions or what would you take care of the patient that IND should not develop into the fistula?
It's a very difficult. Let me tell you. Here, what I am trying to tell is, don't try to treat as a fistula. Treat it as a IND. Take a precaution as you take in any IND. Do not poke it too much, do not pack tightly, and do not try to create a false passage at the first time or later on. Just treat it as a abscess and put a dressing and let the granulation appear. I am not saying whole 100% will heal. The 40% may develop fistula, that will be taken care later on. That is the basic idea of this presentation.
Thanks.
Thank you, sir.
May I ask the house, whenever you encounter a perineal abscess, what is your primary focus? Drainage of abscess and getting rid of the patient's acute symptom, or getting the patient absolutely all right that he needs only one-stop method? So how many for only IND, focus only on IND, majorly? If they find a fistula, well and good. How many would do a radical surgery in the first sitting? Right.
It's a 50-50.
50-50, a tie. Now, the next question. We have already seen the earlier speakers who have shown nicely when we aspirate and then put in a methylene blue. One small take-home message is, when you put in a methylene blue, if you have a retractor or something in the anus, at times because the sphincters are stretched, the methylene blue may not come inside, right? So just don't use an instrument, just put in a methylene blue, you will be able to find out the track. Now, if you find out the track, Dr. Kolte, if you find out the track,
yes, sir,
would you open up in all the cases?
As I've already discussed, that probably if it's a low intersphincteric or somewhere I can compromise on external sphincter, I would definitely open and do a primary fistulotomy, because I would not want my patient to come back and suffer all those dressings, sitz bath, everything for next after the second surgery.
Dr. Modi, as
Yes.
you mentioned the deep spaces and all those things, in them would you advocate primary fistulotomy or just IND and come out?
So, frankly speaking, it is a logical when there is a low fistula, like what has been shown many times. People can go ahead with the fistulotomy, patient is convinced. For a high fistula, I would definitely not go, come out with IND.
Correct. So that's another take-home message, I believe. Whenever you approach the patient with perineal abscess, obviously the bacteria or the organisms have a path from where they had traveled. You don't always have to tackle the path. First, address the severity of the situation, evaluate clinically, radiologically, or by any other means under anesthesia and all, and then take a bath. Don't go with a pre-decided mindset to approach. So whenever there are deep abscesses, it's better to be safe than sorry. Now, we all have seen all our experiences and all those things. Let us just see what the guidelines also say. The guidelines say that abscess drainage with concomitant fistulotomy may be performed in selected patients, right? So, if I can ask some stalwarts over here, Dr. Ladda sir, Dr. Parvez sir, Dr. Begani sir, or somebody who can just mention 1, 2, 3 points where you will do a fistulotomy, where you will not do a fistulotomy. If the fistula opening is already present. Anybody from slide? Yes, sir. Sir, with your huge experience, in a perineal abscess, we are able to find the internal opening. In which cases you will do fistulotomy, in which cases you will not. 1, 2, 3 here, 1, 2, 3 there, if I may.
If you go by the literature, is this working?
Yes, yes.
Yes, yes. Tell me, perianal abscess, how many can really figure out the internal opening? Because if there is an internal opening, perianal abscess doesn't acquire or achieve the size that it does. Is there a perianal abscess with an internal opening? Never goes so tense because it automatically drains inside. And if that happens, then your life is much easier. You must open the tract. You can, if you look into the literature, you can very safely open at least half of the sphincter complex. You can cut it without causing any significant incontinence in due course of time. There's a very nice study from Egypt. They have quantified the sphincteric complex and figured out that up to 50%, including both the internal and the external sphincter, if you cut up to 50%, the long-term incontinence is not that bad, patient can go on. But you definitely avoid a second surgery. So if the opening is there, I would do a fistulotomy.
Yeah, thank you very much, sir. That was very crisp and straightforward. So,
well, that's what I said. That's what I said. And that's what this whole symposium is all about. This is for young people only. If you can figure out that there is an internal opening, I particularly find very difficult to push the dye in an acute abscess through the internal opening. It's difficult.
Thank you.
I'm sure this is the experience of many of us.
Yes, sir.
Yes. But if you have a good sonologist, all my cases undergo
mic in the audience, please. Mic in the audience, please.
A transperineal sonography. All my cases undergo a transperineal sonography. And it's entirely experience of my sonologist, who has a huge experience now. He is able to tell you where exactly this abscess is arising. And I tell you, 10 out of 10 times he is not wrong.
Thank you very much, sir.
I even opened that crypt where the pus is impinging and making a dent at the anal canal.
Thank you very much, sir. Let us, sir. Can we have a question, please?
Can we do this fistulotomy anteriorly because we'll be cutting the internal sphincter?
Yes.
When we do fistulectomy anteriorly or something, we always talk about not cutting the internal sphincter. What about
Dr. Kolte,
the situation here?
You said for Dr. Kolte.
Can you
anterior fistula?
Anterior fistula.
Can you do a fistulotomy?
Yes, why not? Only the internal sphincter can be taken
what about
away.
a lady?
Yes, I would say males and females. How would you approach the males with anterior fistula and females with anterior?
If it is an internal sphincter, I would definitely consider the same for both. But then, yes, if it is external sphincter, I would not go for fistulotomy. I would rather spare the external sphincter in females.
In female particularly, there is one more condition you should keep. You should always ask history of previous episiotomy.
Yes.
The many time it is in a space between rectum and vagina, and you may end up, if you do very enthusiastic, with rectovaginal fistula. So it is preferred in female that go for only IND. For a male patient, it's what sir has said.
But
Fantastic.
we always keep on talking that we should not cut the internal sphincter anteriorly in females. That's a
yes, because if you are damaging the perineal body, if the anovaginal bridge is small, the perineal body is at stake, then it is preferable.
What is the take-home message?
Take-home message in a female anterior fistula, let's be as conservative and as cautious as
IND, that's what I said. In female, IND. That's what I believe.
So what happens is it can really make us difficult to accurately access the anatomy because there is a lot of edema around. And as Dr. Ladda sir already mentioned, it is not very easy to find out the internal opening every time. So potentially the surgeon may underestimate the degree of sphincter involvement. So that is why it is better to avoid. So primary fistulotomy plus set-on and a second stage fistulotomy, no fistula recurrence, no abscess recurrence, no fecal incontinence, according to the journal in 2016, a paper published in 2016. Now the last slide which I would, that went away. Anyway, so the final take-home message, which if I may just sum up is, as Dr. Kushal Mittal had already mentioned, If you consider these 4 fingers as the 4 different parts, one is the subcutaneous part of the external sphincter, the superficial part of the external sphincter, the deep part of the external sphincter, and the anorectal sling. So anything which is sacrificing the superficial and the subcutaneous part of the external sphincter, you can go ahead with the fistulotomy. If you go up and beyond, sorry, that is called as recurrence. That is called as recurrence. Okay? So that is number one. And the second is, as Dr. Singla had mentioned, you have the conjoined longitudinal ligament which is coming down. So all the infections, abscesses and fistulas medial to it, you can straight away go ahead and do a fistulotomy. Anything lateral to it, then you have to be cautious. At any given time, it is better to err on doing just an IND and a set-on placement, or IND and counseling the patient. I believe we all agree with all this?
Yes, that's what I want to say. If in doubt, do IND.
So anything medial, you can just think of doing fistulotomy. Anything lateral, yes, you stay.
Thank you. We will conclude this session.
And
Thank you.
One more point, sir. You have highlighted, but very important. If slightest doubt is there is an internal opening, still you are not sure, set-on will take you better way. Because then you will have a second chance to see where actual opening, once the patient is out of anesthesia, you can judge the sphincter. So rather than to go for a fistulotomy in doubtful case, go with the IND and set-on, if possible. Yeah. Again, the rider is there. You should bring out set-on from proper place.
Thank you, Dr. Golte. Thank you,
Thank
everybody.
you. Thank you so much, sir.
Thank you, chairpersons. Thank you, Dr. Gore, for giving us certain time. We are already running short of time, so we will call for the next session, that is section 4 on the symposium on simple fistulas. May I call upon the chairpersons, Dr. M.G. Narayani, sir, Dr. Chetan Mahajan, Dr. K. Balu, to chair this session. Can you come, please come on the stage, please. To present the first master video here, may I call upon Dr. Mahesh Malu on fistulotomy.
Good morning, all of you. As we are running short of time, I request both the distinguished speakers to please stick to the time for the benefit of all. Any questions or queries we can always ask one-to-one once we are done. So we request the speaker, honorable speaker, to start. Thank you.
Start? Okay. Good morning, everybody. Greetings from Nasik. At the outset, I wish to extend my sincere thanks to the organizing committee of Fistulacon for offering me this opportunity in the galaxy of stalwarts in the field of coloproctology. My topic is fistulotomy. The commonest cause of fistula in ano is the infection of the anal gland. Anal glands are racemose glands which are situated in the intersphincteric plane or within the substance of internal sphincter. They are maximally concentrated on the posteriorly and they open into the anal crypts. So most of the fistulas are posterior and the internal opening is situated at the dentate line. The less common causes are tuberculosis and Crohn's disease. The infection starts in the anal gland, which is situated in the intersphincteric plane. It may remain there or it can spread in various directions, and thus the tract form are classified as intersphincteric, transsphincteric, supraelevator or extrasphincteric. The tract further classified as high fistula in ano or low fistula as per their relationship with the puborectalis muscle. Here is the video of fistulotomy. The patient is given lithotomy position after spinal anesthesia. Then a combination of methylene blue dye and hydrogen peroxide is injected through the external opening. Sometimes we inject a solution of xylocaine with adrenaline around the tract. An incision, a grooved probe is passed through the tract and incision is made over it to cut the anoderm, skin, fat, and the sphincteric musculature distal to the tract. Then thorough debridement is done, and the edges of this wound are trimmed so that the tract is marsupialized. It prevents the bridging over during the phase of healing. Then after thorough debridement and curating of the wound, a betadine soaked pack is kept in the wound. This is the definitive simple treatment for low fistula in ano. It is a useful procedure because here the part of the sphincter which is divided is much below the puborectalis muscle. I have a case of perianal abscess where I did primary fistulotomy. This is perianal abscess. This is suspected internal opening. Then pus is aspirated and methylene blue dye is injected in the abscess cavity. There is slight staining of the methylene blue at the internal opening. Then fistula probe is passed from inside out. Fistulotomy is done. And betadine soaked gauze piece is kept. So this is all about the fistulotomy. I take this opportunity to invite you all to the Massicon 2024, which will be held in Nasik on 8th, 9th, 10th and 11th February 2024. You can avail the benefit of early bird registration, which is extended till 31st August 2023. So thank you very much.
Thank you for keeping up the time. It's all open to the house. We still have 1 minute. Any questions? Any suggestions? Good question.
See, that is another thing. Fistulotomy, here we lay open the tract, and this is the simplest definitive treatment for fistula.
It will be easier for the patients to, if it is
If
closed.
you are confident that thorough debridement is done, then you can close the tract also.
Thank you, sir.
Yeah, I have mentioned that the edges should be marsupialized to prevent the bridging over during the phase of healing.
Hello, sir. If the fistula is intersphincteric and there is no external opening, that is blind internal fistula going supralevator, can we do the fistulotomy in that case? Complete fistulotomy.
In such
dividing
cases,
the internal sphincter up to the level of
fistulotomy is the procedure useful for the low fistula inlet. If the tract is going supralevator space, then it becomes difficult to treat only with the fistulotomy.
Is there any chances of incontinence if we do the fistulotomy in such cases?
Okay.
In cases
Okay,
of
last
low
question.
fistula in ano, there is no chance of incontinence.
No, I am not
Because the
asking about the
sphincter-
low fistula. I am asking about the high intersphincteric
Unless and until you
fistula.
touch the
That's for the
puborectalis
next-
ring,
next, sir,
there is no
person to
chance of
answer.
incontinence.
Thank you.
Right, so bye.
Sir, thank you very much for a lucid presentation. May we invite the next speaker on.
Can we call upon Dr. Chivte? Chivte, right?
Folder.
Dr. Chivte is not.
Can we have Dr. Chivte?
Can we have Dr. Chivte? Dr. Chivte is one of the few innovators of new things in colorectal surgery.
चिवटी लिखा नहीं चिवटी लिखा हुआ है ना सिंपल फिशुला देख हाँ फिशुला का अरे सब निकाल के रखा है इसमें ये चिवटी का दिख
Dr. Chivte is a great teacher and an innovator.
खाली वीडियो हाँ हाँ थर्ड
I think
Just so.
I think he's one of the first ones to start with the minimal access surgery in a fistula, especially with the pediatric size cystoscope which he used to
मेरे को
do.
क्या करना है?
I remember those days,
चालू करने के लिए?
and the other lasers and all have come after that. So Chipte, the innovator.
मनु जरा सुनने का एक ऐसा बात करना यार. मेरे को सुनने को नहीं आ रहा है, उनको कैसे जाएगा?
अरे उन लोगों को सब सुना है यार.
तुम्हारा आवाज़ तो चलता है सब जगह, मालूम है. Okay, thank you very much for giving me this opportunity. I'll call team Fistulacon, Dr. Parvez, Niranjan, including Manu and all the teams. Thank you very much for calling me. Today I am going to present you only simple fistula, only video. And why I selected this? Because all people, we are doing fistulotomy, fistulectomy for simple fistula, not from today. Last 100 years, you may say it is same thing going on. 1337, this fistulotomy was developed. This was on record. But if you see, this fistulotomy was done by Sushruta 1500 BC. So you will imagine how old and gold we have just keeping preserved. So let us see this video, what we can do. Yeah, please. कुछ है माइक वगैरह मेरे? अच्छा इधर से बात कर. ये बाजू करता है, क्या होता है? नहीं दिखता है. Well, this fistula we are doing little different way. Is I think. अरे अर्लियर रिक्वायर किया गया, उसका पहले से करो. This is what simple, I think we are doing this simple fistula with simpler way. Simpler means we don't cut much and we don't want to divide anything. This is a male of 42, another thing you can read it. First, for all anorectal surgery, we do dilatation, that is to measure radial uniform dilatation, not just push a dilators of any size, anything. These are all measured from 2 centimeter, 3 centimeter and 4 centimeter. They are calibered, not only calibered, their tapering is 1 to 10, means 1 millimeter is tapered with 1 centimeter. So 1 centimeter is tapered with 10 centimeter. So these are tapered, so there is no damage to the, or minimum damage to the sphincters. So this is what we do for each case. I'll give you a reason for that later on. So once we do dilatation, this is the case not only with the fistula, but it is with the hemorrhoids with the thrombosis. That's what case I selected it, and both can be done at the same time. We keep dilator for sometimes at least a minute to accommodate that sphincter in that. Step 2 is external opening of the fistula is dilated with Hagar's dilated up to 4 Hagar's. And this is what procedure we do. We do curettage, we do endoscopy and pack with collagen. This in short, this procedure is there. This is what we are doing. You can see dilator through the internal opening, and this dilator is of number 3. So Hagar's we are dilating external opening, not through the fistula. So why we will do? Because we want to put scope also inside and see. That's why we are dilating only external opening up to Hagar 4. And once we dilate this, you are seeing that we are not pushing dilators, but just at external opening. And both ends we have this. And once we do this dilatation, usually we do endoscopy on that also first, and then we start curating. I'm omitting some steps, I'll show together. And this curating is done under your finger guidance. We are not very severe to perforate anything. Even internal opening can be curated under your finger guidance. And this curating you should stop where gritting sensation comes, and this will be 360 degrees, not only one direction. And now you can see with endoscope what you have done for that. And you can record whether you have removed whole, infected tissue or any debrided tissue or debris inside. So once we do this and see inside, this is what before curating you can see it. Now this is what you are seeing inside. Internal opening is there, plus all muck is there, pus is there, plaques are there, debrided tissue is there, everything is hanging into inside. And this you can see everything you are seeing inside. So you will differentiate this is now and after curating. So all this you are hanging tissue, this all should be removed during curation, because we are not excising anything, but you are curating only. So this is all tissue and methylene blue earlier what we have used. I have not shown you all step. This is first curating what you will see inside. As soon as you see inside now, you will see bright red. What it was, little whitish and those debrided tissue was there. So this is, and again you are going to see the margins of the internal sphincter and internal opening. This you can see everything, but still some loose tissue is there and some plaques are there. So better we have second debridement also. So I mean curating, and we can do that. See, some tissue is there. So we second time curated, and this curating can be done 1, 2, 3, 4 times as till you satisfied. You are not going to cut down anything. This is, see now, you are better clear than what earlier you were. You are seeing internal opening, you are seeing that flap which was raised by a dilator, and internal sphincter muscles you are seeing marking of that. So all this should be visualized, and this whitish tissue is a fibrous tissue, you need not to remove that. And now you are seeing very clear that fistula is nearly clear, and you can do it. Earlier we used to pack this tissue with something, gauze pieces or anything, but nowadays we have started packing this tissue, I mean fistula, with collagen. You will say why collagen is to be required, because collagen will take care of dead space, and not only that, it will stimulate the fibrosis and healing procedure will be fastened. So all these things will be achieved with the collagen. Once you put this collagen inside, now you will see it will go up to internal opening, and now we'll suture this internal opening with the including this collagen inside. So that will become second layer of the collagen, I mean second layer of the internal opening along with the mucosa and internal sphincter itself. So all this suture like regularly, because already collagen is there, so second layer is there. And we don't tight these sutures very much. We just approximate, because if you tight too much, during defecation when it opens, it will have cut through. So better, this cut through can be avoided with keeping the sutures loose. Second thing, why I dilated this sphincter for fistula, now you will realize, because fistula will be relaxed while passing stool also, so little less tension will be there on the sutures. So both will occur, and this we are, once we suture 1 or 2 or 3 sutures, whatever required, because we have put dilator inside, so internal opening has been torn a little bit. So usually whatever tissue is there around, we take inside. And we take deep bites. Remember, deep bites means we want fibrous tissue of the fistula tract should come in that, because fibrous tissue will hold your sutures, not the mucosa and internal sphincter. So all this, once you do it, you suture it, so your work is nearly complete, and you clean it up, and you will see that its results. This is what ultimately, this is post-operative what you can do it. And this is the fistula after 4 days, and this is 10th day fistula has been over. So this is what you can see, the different type of fistulas are there. Bleeding can be compared with this all, and this is the, usually healing is near about 90-95%, but you can see the particularly incontinence, it is a very different in all these things. Nearly 10 to 12% incontinence is there, whether it is fistulotomy with marsupials or fistulectomy with repair, all 10 to 12%. I am not saying very severe incontinence, but it is 0 to 2 degree incontinence will be there. Healing time is much more different. Healing time in all these cases will be 5 to 10 weeks, And in particularly this simple fistula, what we are treating with the endoscopy is something like 2 weeks. Maximum you can have third week. For some cases, about 10% cases, you can require 3 weeks. But all these cases heal up to 2 weeks. Thank you very much for giving me opportunity.
Thank you, sir. I think any questions, we'll probably take it later on now. Maybe one question, if at all.
Sir, the 10 to 12% incontinence you said, is it only for liquid stools or both liquids and solids?
This 10 to 12% incontinence has been described for the platters as well as liquid stool, that too very occasionally. That's why 0 to 2 degree they are calling because of that reason. That is not regular. Only one thing you should remember, that these patients are around mid-age, and these patients, when they grow, this incontinence can be increased by 6 to 7%. So this should be kept in mind.
Sir, what is the rejection percentage of collagen?
What is it?
What is the rejection percentage of collagen?
Yeah, extrusion of collagen can always occur in about 16 to 17% cases when fistula plug is there. But in these cases, what we are suturing collagen with the internal opening, exclusion is nearly not there. But other cases where collagen we are just pushing it without suturing, that 17 to 18% that extrusion can be there.
Thank you, sir.
Thank you. Okay, thanks.
Thank you.
Jute. Thank you very much. Thank you, audience.
Thank you, chairpersons. Thank you, Dr. Jute. It was a wonderful session. Can you have now the debate coming up for whether fistulotomy is considered as a gold standard? May I call upon moderator, Dr. Naresh Rao, to come here as to moderate this particular session. And the speakers also, can they come up on the stage? Dr. Ravi Wankhedkar and Dr. Anjali Dhaule. Please come on the stage.
Hello. Good afternoon, everyone. Or is it still time? There is still time. We are running a little late, so we will catch up. The first presenter for this debate, fistulotomy is the gold standard for simple fistula, is by none other than, okay, Madam say pehla. Dr. Ravi Wankhedkar's presentation. Switch, please. By Dr. Ravi Wankhedkar.
Yeah. Thank you, Chairperson Naresh, my fellow debater and my good friend Anjali, and thank you the organizers, especially Parvez, Niranjan, Roy Patankar sir, and I fondly remember that it was Parvez and late Dr. P.N. Joshi sir who way back in 91-92 introduced and inducted me into the field of proctology. So today I am going to speak for that the simple fistulotomies are the gold standards. Chivte sir has made my job much easier by giving the reference of more than 1,000 years documented reference that fistulotomies and setons were definitely used as a treatment since ages. These are we all know this is the Parkes classification. This is just trying to create a background of which type where we can use these fistulotomies. This is the current procedural terminology where subcutaneous fistulas are mainly added. And these are the treatment guidelines which are extremely clear and which strongly support my case that yes, simple fistulotomies for simple fistulas is the gold standard. What is a simple fistula? This is just a definition. We all know it. I will not repeat it. And mind you, 50 to 80% anal fistulas are simple fistulas. This is the procedure. Since morning we have been discussing this. This is what most easiest procedure to perform to the freshest surgeon, to the experienced surgeon. You don't need anything extra, no expensive instrumentation, no expensive training. Hence, easiest surgery to perform with the best possible results. Cost is definitely a factor, especially practicing in mofussil areas. It is time tested, as Chivte sir said, and which I demonstrated in my first slide, that since ages, this was the treatment. And in surgery, so many things which were time tested are still practiced. Bassinis repair or a Halsted mastectomy with certain modification still is the mainstay of treatment. Same with fistulas, where simple fistulotomy will take care of most of the anal simple fistulas, that is the subcutaneous fistulas or the intersphincteric fistulas. Of late, along with the science and art of medicine, the commerce of medicine also has come in. And hence I have included the insurance issues, wherein health insurance is rapidly increasing, especially in the urban areas. Urban areas now the penetration is up to 27%, and in rural areas it is 16% still. And if you will see all the packages of insurance, what rates they are offering, they sustain only simple fistulotomies. Most of the insurance packages for first year don't allow fistula surgeries to be covered under the health insurance packages. So that is also another point of consideration. And we all, over the years, have found out that it is the best for simple, uncomplicated fistulas. Lastly, this quote by Lord Hutchinson, from too much zeal for the new and contempt for what is old, save me. Right technique for right indication, especially in the age of augmented reality, where things are fast changing in the field of medicine, and so much instrumentation is coming every day. And just because I have bought a laser machine, I have bought a DGHL, I have bought a WAFT, I will use it. Please don't do it. Right technique, right procedure for right indication. And for complicated fistulas, you can combine various techniques. Thank you. I have tried to be brief, Naresh, so that you can have more time.
So much, sir. Thank you very much. And now I invite Dr. Anjali Davle, who is going to speak against the motion of fistulotomy is the gold standard for simple fistula.
Good morning all. Thank you very much Team Fistulacon for the wonderful opportunity. Dr. Ravi Wankhedkar sir has said that his patient is ready for the sphincter weakness. But sir, the audience patients and my patient is saying, I am ready for recurrence but not for incontinence. Fistulotomy is the gold standard for simple fistula, yes or no? My question to Wankhedkar sir is, sir, what is the gold standard? As the gold standard term derives from We have borrowed this term from the history. Economist previously, for the currency comparative analysis of various countries, it used to be taken into consideration. It is a gold standard and not the golden standard. And secondly, this gold standard was also used, the term frequently, from the Olympics, in which the best performer in the sports used to authorize with the gold medal and rest with the silver and bronze. But that doesn't mean the bronze or the silver medal has lower efficacy. Even the simple things that look simple can be complex. Yes, it is a tip of iceberg. As since morning we are listening that even simple fistula can have a manifestation into deep ischiorectal space. Does it mean that the simple fistulas are having the abscess in the midline, anterior or posterior? They do not have the cryptal theory, or they have a simple cryptal theory. So, simple fistula even at times have a complex anatomy, and simple fistulotomy is not going to suffice. As you look at this slide, the classification of the fistulas. Since 1976, the first classification introduced was Parkes classification. Next to it was the second classification, and now we have come up with the Gerk's classification. The basis of any classification, if you see, there are grades, there are simple or complexity of the fistula, but yet we have not reached to the consensus, yes, that for type 1 simple, type 2B, this is the only standard treatment offered. So we have yet to reach some conclusion. Rosanna Sakul has a beautiful classification who has defined where it is very much helpful for the clinician to know where exactly the internal opening of the fistula is located. So this is one of the novel classification for a clinician, for a surgeon, so as to how to approach, and it is defining actually the extent of fistula from where to where it is extending, and thereby making the sense that always simple fistula can have a different anatomy, although you term it as a simple fistula. As since morning we are discussing that the cryptal theory, understanding the new ideas in the cryptal theory of the fistula in ano, this is one of the oldest and the modified theory where we believe that somewhere there is a cryptal gland infection, it forms an abscess, this abscess ruptures inside, it forms its way and it melts and it gives into various directions, and the branches can be innumerate, which are invisible to your eyes underneath the skin, underneath the sphincter, intermingling the sphincter. So where is the question that always it is going to have a simple straightforward tract? As you come into the various details of this paper, there are classification where they have studied n number of patients depending upon what type of fistula it is, what is the procedure which was offered, whether there was a septic focus present during that fistula tract was dealt or not dealt in the same sitting, whether the complete tract eradication, I mean branching or the straightforward fistula, was dealt with or not. So I mean to say that every time when you are comparing fistulotomy with other modalities like fistulectomy, lift or other procedures, these 4 parameters are very much important. Here are 2 papers where, as Wankhedkar sir says, that the comparative outcome of fistulectomy versus fistulotomy treatment in fistula in ano and long-term outcomes. These 2 studies, they are pro for fistulotomy, but my dear friends, in both the studies, the limitations are the cohort group is very small. They have given excellent comparative analysis where the operative time was less, there was wound healing was very faster, post-operative pain was very, very less. But what about the incontinence and what about the recurrence? What is the standard method which was used for the diagnosis, whether MRI is for which fistulas, endoanal ultrasound for which fistulas? So this is one more landmark paper where surgical management of anal fistula, a systemic review. This systemic review is a wonderful paper everybody should read with, because here 1429 search, research articles from PubMed, Google, scholars, everybody, every study was taken in this systematic review. Only, you will not believe, 677 studies were considered for the comparative analysis because other methods, rest of the 75% methods were not having the standard parameters for the comparative analysis, that what is the extent of the sphincter involved, that is one. Second, whether the all 4 parameters which we were discussing have taken into consideration or not, whether manometry was done prior to the surgery and after surgery, whether incontinence scale was J scale or some another scale. So these are some of the important landmarks where we have to think what type of study we are comparing with. We should not compare apple with oranges. So simple fistula in ano is all that simple? No, not at all. In this paper, almost 12.5% of these simple fistulas, they are having incontinence, which is quite large. Second thing is, it admits that here they have a beautiful illustration where they have taken into consideration the pre and post-operative incontinence scale very standardly.
Madam, I'm sorry, time.
Yes, sir. This is the last slide. So,
thank you.
Let us discuss about the challenges, whether the standard approach is there or not, whether uniform studies to compare the standard of incontinence, recurrence is the procedure and not failure, or incomplete disease understanding is the motto. So, this is the thread of fistula. Wankhedkar sir is standing on one side, I am standing on one side, audience is in the middle. We have to decide, we have to balance which type of procedure for which fistula. And at the end, choti, which is the Indian tradition, where you know that whenever a mother is doing this choti for her daughter, every string of the hair is important. If one of the string gets loosened, it is going to have a incontinence, or you can say the failure of the choti. So with this, I conclude. Thank you, ladies and gentlemen.
Thank you very much, madam. Very excellent against fistulotomy. Now there is a rebuttal of 1 minute each. So I will invite Dr. Wankhedkar to rebut. Yes, please. No, you can go ahead there, sir.
Thank you, Anjali. Just 3 small points which I need to question Anjali. She mentioned about gold, that gold is not still in the context of economics. But we all still know whatever currency, whichever country is still backed by gold. And those interested in economics or in the investment cycles very well know that last few years gold is giving one of the best investments. It is much better physically also than silver or bronze. I agree, simple fistulas are not that simple. Anything simple which appears simple is not that simple. But I think with newer investigational techniques, a very good sonologist can even see, which as sir said, with a perianal ultrasound and a very good MRI, we can very well see. And as a standard, we subject those patients to minimum ultrasound before proceeding with any. So we come to know what is simple, what is not simple, and we can do a fistulotomy. The most important point which I felt, which Anjali missed, is that she is talking against fistulotomy but not giving alternatives. What else you need to do? That is the moot question. And if you don't have alternatives, go for the best possible, best available thing. Thank you.
Thank you very much, sir. As sir said, I am not giving alternatives. I have straightforwardly and openly said that we are comparing maximal studies are in comparison with fistulectomy and n number of procedures which are sphincter sparing procedures. But at the end, I will say, how are you going to assess the sphincteric involvement, whether it is 1/3 or more than 1/3? What is your standard evaluation of simple fistulas by ultrasound? Do you mean to say that in simple fistulas you are doing MRI for every patient? That is one. Second, if you have done an endoanal ultrasound, does it mean, and if the patient comes after rupture of abscess 2 weeks after that, are you going to get any positive findings on the endoanal ultrasound? Third thing is do you mean that simple fistulas are always having the cryptal gland within the vicinity of the tract? So my question is, the evaluation, incontinence or the continence evaluation standardization are not practiced in any of the large meta-analysis or systemic cohort studies. That is the only thing I wanted to emphasize. So before cutting the sphincter, may it be an internal or external, continence is more important than the recurrence. Thank you so much.
Thank you, madam. So, Dr. Chivte wants to make a point.
Hello. See, Fistulotomy has been described, I told you, by Sushruta also. And this fistulotomy has, treated Louis V in France. Before that, surgeons were not called royal surgeons. They were called barbers. But after this healing of the fistula, all surgeons started calling, they called by kings as a royal surgeon. So whatever is given royalty to us, we cannot forget. Thank you.
Sir,
So,
one question
madam,
from my side, and it is for everyone stalwarts here. What you do in fistulotomy? You put in a probe. We are talking about simple fistula. You put in a probe. You are just cutting on the probe. Okay. How much is the fistula tract width? It's at 5 millimeter. It is never more than 1 centimeter thick fistula tract. Otherwise, you can put your finger there through and through. So 5 millimeter, that too you are cutting on the probe. You are cutting only half of that 5 millimeters. Is going to cause incontinence for simple fistulas.
Thank you, Hemant. Before I put it to vote, I think like what Sir said, that this has been going on since the days of Sushruta, and we are still debating about it. Though we have come a long way from being barbers to royal surgeons, my debate was on fistulotomy is the gold standard for simple fistulas. What I have concluded, that even simple fistulas can be complex. So you need to know your anatomy very well. The various classifications you need to be aware of and deal with the simple fistula in a simple way, keeping in mind that surprises can happen. So the gold standard, as we say, is as of now. It might change tomorrow. So it is dynamic. With that, we need more studies, more data to become wiser, and more such conferences by the stalwarts in the field, like Parvez and Niranjan. Thank you very much for bringing us here. We are still debating about it. Now I put it to you by raise of hand. All those who are for fistulotomy is the gold standard for simple fistula, put their hands up. So remember, do no harm or do minimum harm. Is there anybody against it? I should ask him why.
He can think chivalrous.
Sir, can anybody take the mic to Dr. Sanjay Jain? He is the present president of the Association of Surgeons of India, sir.
Thank you, sir. But what you yourself has said, that the surprises may be inside. So there is always good to be cautious and not be overconfident by cutting and going and facing the problems at a later date.
Absolutely agree with. I think everybody agrees. Everybody agrees with this? Yes. Thank you very much.
Thank you.
We'd like to go to the next session, which is the Symposium on Complex Fistulae. I'd like to invite the chairpersons, Dr. N. Srinivas Rao, Dr. Asif Mehraj, and Dr. Mukesh Srivastav. In the interest of time, we are cutting this session to 7 minutes for each person. And the 2 minutes discussion time, we will take the discussion at the end where all the questions would be clubbed together. Thank you so much.
So we begin the session, and Dr. Begani is already there. So may I ask him to please start his proceedings?
Yeah.
Dr. Begani will be speaking on
Friends,
identification of internal opening.
good afternoon, chairpersons, and I thank in the beginning Parvez and Niranjan for excellent presentation. Now, since morning we had been listening about the fistula and the management of fistula, low fistula, high fistula, complex fistula. The most important thing is the internal opening of fistula, complex fistula in ano. This is one of the most important thing, because when we say, you are all surgeons, and there had been few problems in surgery which necessitates as much judgment on the part of surgeon as the treatment of complex fistula. I'll run these slides because it has been covered by my previous speakers. Anal glands, dentate line. I'll concentrate more on the video. There are multiple external openings, but the internal opening is one. Now, the palpation, by various methods we can locate the internal opening. The best investigations, the direction of tract can be felt at the core by inspection, palpation, and induration as a nodule, and tenderness. By physical examination, one can know that where is the internal opening. And the various investigations, X-ray fistulogram, CT scan, endoanal sonography, as Dr. Ladda has said, and MR fistulogram. Some of my colleagues has said that 80% of his cases, he does MR fistulogram. Endosonography, MRI. I think now the dye study with various materials which has been used for dye study is diluted methylene blue, the commonest with hydrogen, milk, saline, providone iodine. One should not probe blindly because it can cause, one can create false passes. Video, please. Can you help me? Video. No, video is there. There is video here. Yeah. So you can know that this is the fistula and the internal opening. You can find out by just repeat. The previous two also are the videos. इससे पहले वाले तो दोनों में वीडियो है. इससे पहले हाँ और इससे पहले एक और है. So the localization of internal opening is very important, and you had seen in the video how we can locate the internal opening. Thank you very much. And eradication of a fistula, if you locate the internal opening, one can eradicate the fistula.
Since the organizers are asked to ask the questions later on, so we'll move to the next speaker.
The next speaker is Dr. Parsati. He is going to discuss on the lift. As we know that why these all procedures has been developed, the lift, various lift, sloft, or fistulotomy, waft, other things. They are because we want to prevent the recurrence as well as the anal sphincter damage, because that is the very troublesome thing post any complex fistula. When we are dealing with the complex fistula, we have to be cautious, like the previous perianal abscess or simple fistula. Fistulotomy is definitely not going to do anything with the fecal incontinence, or it may be there, which will recover with due time or healing. So in dealing with the complex fistula, one should be very, very cautious. One should have plan of what he is going to do. Dr. Parsati, are you ready?
Yeah, yes, sir.
Okay. So please start your talk.
Yeah. Very good morning to all. First, I like to thank the organizer to giving me this opportunity. And I'm going to talk on lift for fistula. No, this is the only one procedure. Initially, I tried many procedures, and then I stuck with this lift surgery. So almost from 2012, 11 years, I'm doing only lift surgery for fistula nano. Initially, I was very, select the case for lift surgeries. And nowadays, I can do almost any surgery, any fistula, I can go for lift. And I'm just going for a video. The technique is I do under anesthesia, spinal anesthesia in a prone position. And then I saw the video, the cut scope, and then 2 centimeter incision at mucocutanous junction. And then I dissect the intersphincteric space, I ligate and division of the sac. So this is the blade, it is both as designed by Arun Rajanaskal, that is the inventor of the lift. I think I shifted my video a little up. I think back, doctors also can be visible. So this is the prone, and this is the 6 o'clock internal opening, and this is the external opening at almost around 7-8 centimeter from above. Almost this patient had an abscess in the coccyx region also, very deep abscess. So with the 2 centimeter incision at 6 o'clock, I am going deep. This is my left hand instrument. This is my right hand. I am retracting the external sphincter. My assistant is retracting the internal sphincter. And some cases it will be the tract will be very deep. We have to go around 2 to 3 centimeter depth. This case almost 4 centimeter depth I went. And there is the internal sphincter is retracted here. That is the external. And still I couldn't see the tract. And even we can able to palpate the fibrous tract with the cautery tip itself. So after that, I used a large right angle forceps to hook the tract. It was around more than 3 centimeter depth. I hooked it. Initially, I used to do the transfixation suture, and this type of deep seated tract, even transfixation sutures are slipped. So that nowadays I'm using this endo loop with the 1-0 vicryl, and then after that I take a figure of 8 suture or posting kind of suture with the 2-0 vicryl for additional support. So now I divide the tract, Again, I tightened the loop because previously it was lifted with the right angle so that it will not be tight much. So after that, again, for a double secured way, second knot I made with the proximal divided end. It is very close to the internal sphincter. And then externally, I core out the track, or I curated as much as possible. And this is the end of the surgery. And then it was skin incision being closed with the simple mattress sutures. That is, the external wound is also closed. I leave something that is not fully closed. It was for a draining purpose. So this is a classical way of doing lift. And this is another case with the multiple fistula. It's a little bit challenging one. This patient had 2 fistula, both are transsphincteric fistula. So mainly, initially I started doing a transsphincteric, and then I am going for almost all kind of cases now. Now you can clearly see there is a track, fibrous track is seen. I inject the hydrogen peroxide, it is coming out. I lifted the track with the right angle. Again, I form a loop knot, ruders or anything. I used to put a gem knot, a loop knot, tightened it. It's compared with the hand knot, this mechanical tightening is good. So now hydrogen peroxide I injected, it's not coming out there. So I divide the track, and then this, as much as possible, we can curate it. If most of the time, it went into the track is going through the internal and then most part of the external, and then it travel in the subcutaneous plane almost around 1 to 1.5 centimeter, then it will open. This was seen in most of the cases. It is not that from the initially it is going deep. So subcutaneous portion of the track can be removed, and then as much as possible on the traveling on the external sphincter also will be removed. So again, double ligation. Now I turn the anoscope. Now it is a 1 o'clock track is done, and then now this is a 5 o'clock another track is there. And this track I inject the hydrogen peroxide. I couldn't find out the internal opening. Even if you not find out the internal opening, we can go for the radiology image. And my patients, I used to do only transrectal ultrasound. Rarely I do the MRI fistulogram. So again, I went into both the external and internal. Now you can see this is the track. So both sides the track, now I could able to identify. Same technique applied in both sides. So they both fistula treated simultaneously. So that is the opening. I cauterized the mucosa. And then again the bursting kind of stitch so that it will give additional secure of the proximal ligation of the track. And then I try to excise the sac as much as possible. And mostly if it is a subcutaneous track, I used to extract, otherwise the patient will have that feel. So this is the way we have done for a multiple fistula. And this is the complex fistula in anterior fistula in female. It is very complex. This patient had a rectal vaginal fistula. Anovaginal fistula. See, the dye is, saline is coming here. The patient complains of passing liquid stool and gas through the vagina. Again, the same principle. In the anterior fistula in female, you have to very gentle because the perineal body is around 11 mm to 13 mm. We should not enter the vaginal wall also. Or if you go this way, you will enter the rectum. So here, a little bit deeper fistula track. And I could able to find out the fistula track. I ligated. The same principle, taking, and then I make a loop knot, Ruder's knot or any other loop knot. I am just tightening with the plastic rod. Like appendix, appendix base, we are ligating same way. And now you can see the puckering of the internal opening. Now I am injecting through the internal opening. So now it is not, hydrogen peroxide is not come. So that means the track is being ligated. So again, after ligation, I went here on this vaginal side. So I am injecting hydrogen peroxide now from the vaginal side. It is coming out. So that means the track is there. So it is not a straight. It is like an oblique kind of track. So from the lower end of the vaginal side also, I am taking the coring out of the track, trying to I remove the entire track.
Dr. Parsarthi.
Yes,
please.
Sir. Time up. Okay. So these are another case of anterior fistula in a male, and just I finished. This is a 1 minute 40 seconds video, sir. It is a multiple fistula. You can see 1 o'clock, 5 o'clock, and 6 o'clock. hydrogen I inject. Here again 9, 10 and 11. Here also the same principle, multiple external opening. Most of the time the internal opening will be on the one internal opening. The 6 o'clock I ligated. Now I injected hydrogen peroxide from 1 o'clock. It is coming on 5 o'clock almost in the sacrum level. Since it is 6 o'clock is ligated, it is coming on the 1 o'clock. That means it is a horseshoe abscess become a fistula, and it was ligated at 6 o'clock. So this one simple ligation of the tract. Only thing you have to enter the intersphincteric plane in a correct way so that you can ligate the tract. In most of the fistula, you can able to ligate the tract. So the fistula will get cured with proximal ligation close to the internal sphincter. So these are some of the post-op pictures. Sorry. Thank you.
Thank you, Dr. Parsarthi.
Thank you.
We'll continue the session. We'll invite the next speaker. He is going to talk on the WAFT. Dr. Arshad Ahmed.
Video चलेंगे ना? Good morning, everyone. Thank you, Dr. Parvez, Dr. Niranjan, Dr. Roy, and all the organizers for inviting and giving this opportunity to me. So I'll be talking on video-assisted anal fistula treatment, that is WAFT. So I have no conflict of interest and no disclosures to make. No, there are many sphincter preserving procedures. WAFT is one of them. As you can see, many of them have not been able to stand the test of time, like fibrin glue collagen plug, but some have stood the test of time. And a lot of evidence is emerging in favor of use of fistuloscope as well as laser for management of complex anal fistula. Now, when we talk of sphincter preserving procedure, because the treatment of anal fistula can be either a sphincter cutting, where we do a fistulotomy or fistulectomy, which is suitable for simple fistulas. When we talk of complex fistulas, either we have one option of doing a fistulectomy with a sphincter reconstruction, and the other option is treating them without cutting the sphincters. Then we have to follow this principle of surgery, that is the central disease elimination, which remains the most important part. And then second part would be debridement of the tracts. Now, how fistuloscope helps us in achieving these basic principles, that is very important, because video-assisted treatment, there is no separate treatment. It is just part of your basic surgical principles. Fistuloscope can be a very good tool to assist you in achieving these objectives, that is central disease elimination. It can help in finding and ablating the internal opening. It can also help us in debriding the intersphincteric space if there is abscess, and then of course debridement of the tracts, especially the tracts where the external opening is located far off. So this is the instrument. This is a fistuloscope which is 18 centimeter long. It has a handle, and then we have a place for injecting, for inserting instruments which can help us in debridement of the tract. A monopolar cautery can be inserted, a brush can be inserted through the same working port, and we use glycine and mannitol for irrigation and making the space clear so that the vision is clear. So this is the instrument that we use for treatment of, in management of anal fistula, and this is the forceps which can be used for debridement, and then there is a brush and monopolar cautery. Now let us come to that how fistuloscope can help us in various steps of fistula management. This is sometimes identification of internal opening can be difficult. Even the saline or hydrogen peroxide doesn't reach there. Then the light of fistuloscope can guide us. So you can see in those cases where nothing is reaching, light of fistuloscope can guide us where the internal opening could be. So in diagnostic phase, especially in finding the internal opening, this could be of help. Then sometimes there are multiple tracts, and we can by doing a diagnostic fistuloscopy, we can find those multiple tracts. So there's a secondary tract here. You can see in this video, the fistuloscope can help us in finding those tracts which are otherwise not seen. Then debridement. This is the debridement part. Endocautery is being used, so we can debride the tract inside, from inside, under vision, and monopolar cautery, endocautery, and then followed by curettage. This can help us. So there are various ways. Then it can be used as a part of hybrid management, and most of the cases actually we are using various tools to achieve those goals which we have defined earlier. This is the case where we did a sphincter preserving surgery. Small video, you can see the internal opening, the external opening is there. This is the methylene blue. So simple fistuloscopy to see the tract, inside of the tract, stained with methylene blue. Finding the internal opening, you can see the light is reaching there. Then because in this patient the tract was mature, so we are eliminating the central disease by doing a lift procedure. So in this patient, a lift procedure is being performed to disconnect the peripheral disease, that is the extrasphincteric disease, from the central disease. So this is the disconnection of the tract. So central disease elimination is carried out. And then after this, the remaining part of the tract we can debride with a fistuloscope, and you can see the brush is being used for debridement. We also use monopolar cautery, and finally we can also use laser to ablate the tract. So as we said that as a part of hybrid procedure where we use multiple modalities, we can use fistuloscope, but it should be, all these things should be in synergy to accomplish the various goals of surgery, that is central disease elimination and debridement of the tracts. Then in patients who have external openings or the disease has spread wide, far away, like patients with abdominal wall, reaching up to abdominal wall, groin areas, in these cases also, fistuloscope can be of great use. Because I'll just want to, can I forward this video a little bit? So as to save this time. So this patient had multiple openings over the groin area. No, just same video. Okay? Sorry. Forward that option. Okay, yeah. So in these patients also, we can use a fistuloscope. It can help us in not only diagnostic part, but also once we have taken care of the central disease by debriding the intersphincteric space, because central disease is from internal opening up to intersphincteric space, and the remaining disease, extrasphincteric disease, is peripheral disease. So fistuloscope can help us in diagnostic phase, where we see the tracts, we try to find the internal opening, and then after elimination of central disease, like in this case, we excise the internal opening up to intersphincteric space, and then we debrided the intersphincteric space. That was the central disease elimination part. And after elimination of central disease, all other disease, that is from extrasphincteric, may be going to abdominal wall, may be going to the thighs or laterally, far off laterally. So that can be debrided, and that debridement can be accomplished nicely with the help of fistuloscope. So fistuloscope itself will not do, just like laser itself will not do anything. You have to follow the basic principles of surgery. And now you can see with the help of fistuloscope, we are doing this debridement with cautery, endobrush, and all these tools can help us do this job in a better way. So we do simple curettage, but definitely with the help of these tools, which are more sophisticated, this procedure can be performed in a more accurate and a more comprehensive way. Another patient where the external opening was far off, up to the thigh.
Excuse me, sir, can you just run through your slides?
This is the last video, just 1 minute. So in this patient also, we first carried out the central disease elimination, and after that we use fistuloscope for proper debridement. Okay, thank you.
I invite next speaker, Dr. Kamal Gupta on PHILAC.
Dear respected chairpersons, colleagues, friends, ladies and gentlemen, a very good afternoon to all of you. So I will be speaking on PHILAC. Just number 5. Yeah. Hope the videos will work. So Filec was a name, that is fistula laser closer. The name itself was coined by one of the lasers company. And the credit goes to Wilhelm, who started this procedure in 2011. So what principle was behind that? That the laser energy will lead to obliteration of fistula tract and closure of the internal opening should be done as an additional procedure. Equipment 1470 diode laser, type of fiber 360-degree radial, mode is continuous, not pulse mode. Dosage, what Wilhelm recommended was 13 watts, but what St. Mark's is using is 12 watts. So that is a 12 watts being used by St. Mark's, and total energy depends upon the length of the track. Myth: laser causes complete closure of fistula tract by shrinkage. Reality: the results do not match with the claims. Success rate 40 to 70%. Wilhelm had written a paper based on 117 cases only, and the result rate which he had given at that time was 88%. So what is the role of lasers? The role of lasers is only as a hybrid procedure. Dr. Arshad has already mentioned about that hybrid procedure. So indications, any hybrid procedure, you can go for fistula tract closure or fistula tract shrinkage with laser, but the strongest contraindication is the presence of an abscess. Please never ever attempt laser in the presence of an abscess. Hybrid procedures, as Dr. Arshad has already said, now initially was in 1961. It is not something he has discovered or I have discovered. 1961, before even I was born, at that time, this procedure had come. So what Park recommended, you remove the central source of infection. That is the internal opening, and distal tract can be cored out. Today, you can core out the distal tract using surgical technique, which all of us know as surgeons, or you can use, fixation, or you can laser ablate it. So you can laser ablate the distal tract even after lift, slot, whatever you want. So how the procedure is done? Video please. Yeah, it is playing. So that is identification of the internal opening. Now that is the first part. Then curate it. Now this is a railroad method that you take the radial fiber from inside out. That means from internal opening to external. And after that laser ablate, dosage 10 to 12 watts per millimeter per second. And once you have laser ablated, again curated, the dead material has to be removed or the ablated material. Now this is the way you can close the internal opening. You can place a probe inside the tract and go behind the tract. That is circumambulation stitch, taking mucosa, submucosa and few fibers of the internal and sphincter. So that is how the Filec is done. Of course, alternative methods initially which were described, advancement flaps or linear staplers. So that is how the external opening is excised for irrigation purposes. So coming to the next video. Now anterior fistula in females. Since morning we have been discussing. So if you don't want to cut the perineal body, what alternative you have? So that is the anterior fistula starting from the external opening to internal. That is demarcation of the tract. That is how you excise the internal opening. This is Park's technique. You cut mucosa, submucosa, fibers of the internal sphincter and do curate the deep intersphincteric space. Laser ablate the tract. Now this is a fixation instrument. Now the laser will cause only shrinkage, as I said. So after that, if the tract is less than 5 centimeter in length and 5 millimeter in diameter, you can use this instrument. That is fistula tract coring or fixation. So that is how tract can be removed. In some cases, you can take out the whole tract. And after that, marsupialization of the margins, which is very important because below where we have removed the internal opening lies the submucosal plexus. The bleeding can be there. And later on, that is how the internal opening can be, the tunnel which we have created can be closed. So next, the same procedure we can do in males. So that is penoscrotal junction. That is how you can identify. Now that is anterior fistula in males. So instead of creating a large area, what you can do is you can just go for this technique, excision of the internal opening. After that, take the laser fiber inside, laser ablate the tract, and that should be followed by placement of acetone. So that is laser ablation. So all these steps, they remain same. Sir, it is not even 5 minutes. It is not even 5 minutes. So take home message, do not rely too much on technology. Use lasers as a hybrid procedure. And if you want to read more about it, we have got book Lasers in Proctology, and 2 good books are coming, which we are going to release at a Garsicon. The first book is Atlas of Anal Canal Anatomy, and second is Operative Proctology. And very lucky to have my mentor, Dr. Kushal Mittal, and my very, very dear friend, Dr. Niranjan Agarwal, as co-authors. Thank you very much.
Thank you, Dr. Kamal. Now I invite Dr. D.U. Pathak, sir. He is also a very good one. I have seen him innovating this technique of slough, which he proposed instead of lift, where it may be difficult to do it, but the slough he has developed and has propagated internationally. Dr. D.U. Pathak, sir, please.
May I request all the speakers, since this is a video session, just go to the video directly in the interest of time. No
It
theory.
will take few seconds, it is important. See, this is submucous ligation. My greetings from Jabalpur. And inception since 2014, it has gone a long way. The level of ligation is this. There is always a feasibility for all procedures, but real indications are very few. This talk is based on where slough should not be done. Deep natal cleft, recurrent with scarred internal opening where lift is possible, and in high internal opening IBD, and of course where internal opening is not found. I am presenting these 4 videos. Video first, second half. This is the original method. Probing was failed. Injection saline. This is the incision of slough. This is the incision of lift. Incising. Going around the probe, it is effectively around the tract, tightening it and ensuring the resistance of probe. This is ligation, this is transaction, confirmation of the transaction, and distal tract I have lasered it. And this is the final picture. Next. A few modifications. I could not enter into the tract. I did a coring. And you can do this routinely after coring when you reached near the mucosa. Now I could put in the probe. Still further dissection. Going around, I love this instrument. Aneurysm needle. very simple. And the benefit is anorectum is intact. I always do a marsupialization. Next. This is again modification by Dr. Kamal Gupta, has already said. He directly takes the suture without dissecting. That makes it still more simple. And I feel this is a better way to do slough. Last video is where my selection of case was not good. It was a bad selection. Scarred internal opening. I did a slough. The dye conformation was there. The transaction, dye was there, so I thought it's okay. But when I tried with the second external opening, there was another internal opening which I would have missed. I tried to close it by all means, including the mucosal covering, but it failed. So finally, I landed up into a fistulotomy. So the take-home message is, not attempt every patient in every procedure. लेप्रोस्कोपी बना था लैप्कोली के लिए, रोबोट बना था प्रोस्टेक्टेक्टमी के लिए, रेडिकल प्रोस्टेक्टमी के लिए. But the proponents of their procedures, they try to prove that उनके procedure से हर चीज़ हो सकती है. That is not a good thing. Don't do that. Thank you.
Thank you so much, sir, for your vast experience. May I request Dr. Niranjan Agarwal to speak about primary sphincter repair?
Good afternoon, everyone. Thank you for coming here on our call for this Fistulacon, and I'm sure all of you are enjoying the academic sessions. I am going to speak on primary sphincter repair. Friends, fistulotomy or fistulectomy, we all know, since morning we are listening, is probably the most successful surgery yet described for any anal fistulas. Why? Because one, it eradicates the complete sepsis, and we heard the debate that it is still the gold standard for simple fistula. But when we say gold standard for simple fistula, that means it is not a gold standard for complex fistula, otherwise it would have been for all, right? Why it is not gold standard for complex fistula? Because there is a lot of division of muscle involved in a complex fistula. So as a general rule, how much muscles can you divide in a complex fistula? In complex fistula, in a male patient, at least half of the external sphincter posteriorly and 1/3 interiorly, and in a female patient, 1/3 posteriorly and never anteriorly can be divided without much compromise. But at all cost, one must remember to protect the puborectalis sling. Fistulectomy and fistulotomy both leave a large open wound which heals by secondary intention, and therefore it takes a lot of healing time. There is a lot of fibrosis and deformity which definitely increases morbidity and morbidity. When we do a sphincter repair, what does we do? We do an immediate repair of the incised sphincter, which causes healing by primary intention, and therefore the functional part of the sphincters are much better. There is significant reduction in size and healing, and the anal verge anatomy is least disturbed. And if there is a recurrent fistula with already existing incontinence, this is probably procedure of choice described. So I am going to show you some videos of how a primary sphincter repair should be done. This is an abscess hysterectal. You can see you do a primary fistulotomy as was shown today morning in the abscess session, and you inject methylene blue into the cavity which has decompressed, the internal opening is identified, and then you do a primary fistulotomy. Now when you do a primary fistulotomy, you saw that the intersphincteric tract was also identified, curated and cleaned thoroughly. Once you clean, you can definitely suture the muscles back. You leave the mucosa open, you leave the skin open for drainage, but the sphincter muscle which you have divided, though it is below the puborectalis sling, you can suture it back. If you leave it open, there will be a lot of scarring, deformity, which would lead to some incontinences. And here, what we do is we take 2O PDS suture in a figure of 8 or a horizontal mattress manner with 2O PDS, because it's got a prolonged absorption time, and the wound size, even in an abscess setting, you can see will reduce significantly. So this is the drain being put in the long intersphincteric proximal tract, which could be drained and cleaned through the sphincter. So normally we keep on a lot of big packs, etc. after the abscess drainage, but here the wound gets reduced so to such a smaller size that you really don't require large pack. This is what we do. We keep it open for a further drainage, and only a small pack is required. Here again, there are two openings which are seen with a tract which will merge inside, and here again you can remove the entire pathology. There is a large wound which will happen, but which will disturb the anal verge anatomy, but when you close the sphincter, your anatomy of the anal verge gets restored back, and therefore that keyhole deformity which has been spoken about so much, and that is why Anjali was talking that there will be definitely some incontinence because you are cutting so much this thing, so that even that keyhole deformity can be prevented by suturing the muscle back. And this here, when this is such a clean wound, what you can do is you can suture the internal sphincter along with the submucosa or some bites of mucosa with 3O vicryl suture, and the external sphincter, which is the superficial and the subcutaneous element, can be sutured as I told you in a figure of 8 manner with 2O PDS matter suture. So I'll have to rush because I have 2 more videos to show, and I can see the time. I need to respect my own dictate. So this is another one which was having a set on place for a long time. Here again you see there are multiple tracts which are merging at the common opening. You remove the entire tract. From one side, the rest of the tract can be curated. There is an intersphincteric extension also in this. This is the intersphincteric extension, which is thoroughly cleaned. There is another tract low. That also can be tackled completely, and then the sphincter can be repaired. Now the suturing is same as what is seen, but my time is running out, so let's go to the last video. I have more attention on that watch than all of you. So this is a large anterior fistula where complete excision was done, and you can see the huge wound which is created. But at the end of the surgery, when you do the muscle repair, etc., you will realize that this wound becomes like a small incised wound. Only thing is, don't suture the skin back, keep it open for any kind of discharges or drainages which has to take place. I wish I was able to fast forward the videos, then I could have shown you the end result. So this is kind of the end result which you get. This is, the literature is full of this procedure having the best cure rate so far, and this is the procedure of choice nowadays, especially in a recurrent fistula. Thank you for your patience hearing.
Thank you so much. Thank you so much, sir, for setting the right example of sticking to the time. Now, may I request Dr. Mahesh Sanghavi for speaking on Shat Sutra.
खाली वीडियो है ना आपका? वीडियोस है, लेकिन वो फास्ट करना पड़ेगा तो कर देना. ठीक, 11:30. Thank you very much, Niranjan, Parvesh Six, and Roy Patankar, sir. There is a new subject, you already knows it, but they have completed because in Esikon book they have informed about the Shat Sutra treatment. So thank you very much. So this is the anal fistula in Roman Phillips and Peter Lunis's first time in 1995. It has been there. In American Journal of Proctology, it will have been published in 2008. And last textbook of surgery, also it has been included, number of the texts has been there. In late 19th century, these are the pioneer about the Ksar Sutra standardizations, and they have done extensive work, and these are the reason. Last year, Dr. Manoranjan Shah, who has invented IFTAC technique, and he's been awarded as a Padma Shri. So this has all are been allowed today, and they are doing well. Now the varieties of Ksara, it has been alkaline. Ksar means it is an alkaline. It is in a liquid form, paste, powder, Varti, Pichu, and Ksar Sutra. These are for the local applications, and the latex. What we are using is Nuhi Kshir, Arka Kshar, and Kshira and Udumbur Kshira. So these are been coating on the barbell limber number 20, and if it is standardization, it is a simultaneously cutting and healing. These are the three varieties. It has been normal, medium, and it is in a soft one. So 8.2 is pH, medium is 8.2 to 9, and if it has been the high density, then it could be a 9. Now, what are these material we are using in latex forms? Applying this, it is an Apamarg, Arka, and Guglo Apamarg. These are the varieties is been established in this area, and the last coating of the turmeric in nano. But the standardization is take more than 40 years. Gauge is 13, tensile strength is 5 kg, length it should be minimum 13 centimeter, and pH should be 8.29. So, pH it should be maintained in this area. So, idea is to be that now what is this aid? जैसे आप एक wire को जो है you can pass from the eyes without this cutting the eyes. The same principle, simultaneously cutting and healing we are here. It is excision, scraping, draining, penetrating, debridement, and everything. So these are the mode of action. It has been known as a complete chemically Ksar Sutra, fistulectomy, which without damage the more one. As you know, turmeric is been anti-inflammatory, antioxidant, coagulant, and this latex is chemical situation. So these are the sonography, MRI, and everything we do. Myself and my USG has radiologist has this development, and we do the not in every case. Now the applications I have to run out because in 7 minutes I have to finish Puri Dunya. So that we have to be applied by the external to internal. We passed the probes and applied the Ksar Sutra, but there was a lot of trauma. So we have started the using of infant feeding tube, and it has been reduced the trauma in the internal lumen. So the pain has been very less. It is to be tied as you see posteriorly that we have tied not tie hard and is to be not a loose. So this is the railroad technique. We tie our Ksar Sutra from external opening to the knot, and then we will push it out in a 90 angle or 45 angle, so you will not get a pain, and we tight it again. And our unit cutting time is 0.75 to 1 centimeter if there is no any healing problem is there. So these are the standard has been taken more than 60 years, and it has been established very well. But the couples of years we have found that it take a long time, and we have improved ourselves and find out that up to the sphincter, if we can do the partial fistulectomy, then it is a better result. It be a spine, and we can reduce the time of this our patients. So this is one of patient which was been unsuccessfully previously operated. We have tried. You can see that this Ksar Sutra we have applied from a sphincter also, but step by steps is come out, and it gives you a complete fistulectomy, and the recurrence is very less. In ICMAR, they have done this project, and they have found that it has been better. It was been open 250 cases of the general surgery and this one. So you can see that it has been coming down, and the sphincter is remain same. When do you see it, that is the last moment is come out. So the idea to apply over that in a partial fistulectomy to reduce the time, you can see the post-operative result in this area. Now you can see that this has been only complete hold the things. So this is the last one, and then you can see it that it has been completely out from this area. So the patient is completely healed, it has been mobile, and everything is, you know, it is an OPD procedures. So this is the last result. These are the slides and the videos. I have lost my 44 years of this program from my bank, so it has been provided my friends and my juniors. I will oblige from everybody there. So now, this is the last end result. So it's cut down, both the sphincters has been cleaned out. So these are the, again, which I talk about the partial fistulectomy. We have evaluated, investigated and everything, So then we do, can it make it fast it? So we core it, and this has been, the Alok has been providing me these videos. Thank you, Alok. So we have been core and applied this, and idea is to be that to reduce the time factors and minimize the pain. So next one, fast karo. Kuch hi seconds baki hai. So this is the last technique, IFTAC, which I have talked. There will be, we push this and find out, and the complex fistula, we made it in a simple way, and you can see this without touching more and ugly scar. This patient has been all right. Thank you very much to provide me the time, and I think so, sir, I have saved my 15 seconds. Thank you very much.
Thank you, Dr. Saab. Now I'll call upon my friend, Dr. Prashant Rahate from Nagpur. He is going to talk on another method which is very helpful and is also very important to know, because there are some time you find the internal opening at above the anorectal junction or the puborectalis, and you need then this type of advancement flap, various advancement flap for correcting that.
Yeah,
Dr.
Thank you.
Prashant.
Thank you, Dr. Srivastav. No disclosures, except a lot of thanks to the organizers of this Fistulacon and accuracy. Greetings from 7-Star Hospital, Nagpur, Maharashtra. The best way and easy way to learn and understand the advancement flap in fistula is to discuss about the rectovaginal fistula. We know the various causes, most of them are obstetrics. Incidents, most of them again obstetrics. We will see the video straight away. This is how the fistula occurred. Small video how that fistula occurred. Patient had anterior rectocele, fecolith was impacted, stercular ulcer, ultimately pressure necrosis, and a rectovaginal fistula was formed. And then that patient was given proper care, local care, and then posted for the surgery. Hydrodissection, but don't instill adrenaline because that can compromise with the blood supply. It can't be forwarded. Okay. थोड़ा फास्ट फॉरवर्ड किए तो बाकी के वीडियोस दिखा सकेंगे. नहीं है वो लाना चाहिए. Okay, so I think only one video can be shown then. So that is the fistula, the boundaries. 15 number blade used to take the incision, a C-shaped incision or V-shaped incision. The idea is that the base should be at least 2 times bigger than the apex. Apex is towards the outer side and the base is toward the inner side. So try not to use much of the energy source, proper dissection, proper plane. The important thing is that flap which we are raising, it should not be very thin, and proper breadth should, the breadth should go on increasing toward the base. And once that fistula opening is reached, then the tissue below, they are the anal tissues. So this is the flap which will be advancing towards the introitus of the vagina. This is a 4x speed video. So that is how the complete video, complete tract was visualized. And the clear edges, we can take proper sutures. Once the sutures are taken, the supporting second layer sutures are to be taken. These are taken with 2O-Vicryl. Yeah. So once that is closed, always by intermittent suture, never by continuous suture. Continuous suture, if one part gives way, the complete sutures will give way. Therefore, the intermittent sutures, these fistulas, rectovaginal fistula, they are notorious for the recurrences. In best of the best series, they tell that the recurrence rate is around 30% for the obstetric type of fistulas, but for the So the second layer is complete. Now the flap will be brought down and the fistulous part of the flap will be removed. Your speculum is giving traction to the flap, so that speculum should be released, otherwise the suturing of the flap will be under tension. The vascularity of the vascularity of the flap is most important. So indigo cyanin green dye is also used. So that is how that fistulous part of the flap is removed, and then that flap is sutured properly without tension. You must have observed that I have released the tension given by the speculum. So that is how the flaps, they should be created. The basic principle is the vascularity of the flap should be maintained. And if the vascularity of the flap is not maintained, then you have to bring in some other structure, such as the bulbocavernous tissue from the mons, or a muscle, gracialis muscle, is to be placed in between the vaginal flap or the anal flap, and then that will give the vascularity to the flap which is surviving. I think only one video can be discussed. So ICG is given. Once the complete tissues are given, these sutures should not be very close to each other, otherwise that will again compromise the vascularity of the edges of the flap. So that indigo cyanin green dye was given, and it showed very good vascularity, so no need of any intervening vascular tissue to be brought. So that finishes my time. Thank you very much.
As the fistula is very low near the anal verge, you could able to pull up the flap down easily.
Yeah.
If it is somewhat 4 or 5 centimeter higher, how could it be possible?
Ideally, if it is higher, do it transabdominally by laparoscopy. It is a better method, not by this.
Indication of Marsh's flap in this.
Marsh's flap, again, it will be better for the lower or middle type of fistulas, not for the higher fistulas.
Higher only
It will never
laparoscope.
go. It will never go in the higher.
Thank you.
Thank you.
I invite Dr. Ashish Ganatra. Please speak on to fistula plug.
Good afternoon. Thank you, first of all, to the organizers to giving me a chance to show you this advanced surgery of fistula plug in complex fistulas. Friends, let me ask you, ये जो रिपेयर करने वालों की कब फटती है फिस्टुला देख के? हम सब जब रिपेयर करते हैं, लेकिन कब फटती है? जब फिस्टुला देख के, जब देयर इज अ हाई इंटरनल ओपनिंग. एंड व्हाट इज द ऑप्शन विथ यू पीपल? डू यू हैव एनी अदर ऑप्शन देन प्लग? या नहीं? आशीष फाइव में देखो.
यहाँ पे सर्च कर लो.
ये भी स्लाइड है?
यहाँ से करो.
ये भी स्लाइड है?
नहीं. ये तो इंट्रोडक्टरी स्लाइड है, ये नहीं, ये तो इंट्रोडक्टरी स्लाइड है। दूसरा देखो।
Dr. Niranjan, can we start? Can we ask the other, the next talk too? Or he is okay? Are you ready, Doctor?
Yeah.
Okay.
So when there is a high fistula, सबकी फटती है. And friends, I am bringing with you an option which is the safest one for a high internal opening. I bring greetings from my hospital, Sarvottam Surgical Hospital, Rajkot. What is the ideal treatment for anorectal fistula? It should have least recurrence rates, minimal incontinence, and should give a good quality of life. And that is what the advantage of using an anal fistula plug. It avoids large perianal wounds, preserves the sphincter function, and reduces the postoperative wound pain and thus wound-related complications. It is technically simple and safe, and most of the patients return to work in the first postoperative week. So, fistula plug placement is safe and non-invasive, and the efficacy of plug appears to be much better, as in my series it is more than 90% than initially reported. How to select a patient? All clean transsphincteric, suprasphincteric, extrasphincteric, complex and recurrent fistulas can be taken up. All rectovaginal fistulas can be repaired by fistula plug. What should be avoided? Always try to avoid intersphincteric fistulas. When there is a failure to identify internal opening, don't create any one. Acute abscess cavities, when there is a acute pus, avoid plug. Acutely pus draining fistulas and multiple blind branching fistulas. So in those multiple blind branching fistulas, you can add on hybrid procedures apart from putting a plug into the primary one. Also, we should consider the affordability as the cost of the fistula plug goes up, and there should be a proper follow-up, post-operative follow-up of the patient. ये प्लीज़ मेरे को ये प्ले करवाओ वीडियो पे की. So we should start with scooping out of the whole tract from the external opening up to the external sphincter, and then through the internal opening up to the internal sphincter. We should irrigate the tracts with saline mixed with hydrogen peroxide. Never use povidone, iodine or any other chemical. And we have to identify the internal opening and pass the threads. Next one. Minimize this. As we have debrided the tract, the next step will be passing the threads. I always use a probe with a eye so that it will be very easy, and I pass on double threads so that once while pulling the pulling the plug, if something goes wrong, you can utilize another this thing. Like that. After that, we should debride. We should debride the track with the brush thoroughly. And then we prepare the plug, and sorry, this is the next slide, sorry, just hold on. Yeah, here plug fixation, pulling, passing, thread. Yeah, we must prepare the plug by hydrating it for 1 to 3 minutes into a sterile normal saline solution. And then fix it at the thread on the internal opening side. Pull in the plug gently. The most resistance is at the internal opening. And then once you feel a strong resistance, fix the plug at the internal opening. With Vicryl 2O. You must take the stitch through the internal sphincter while fixing the plug so that plug should not get dislodged. And then you should also close the mucosa above that so that plug is buried within the mucosa. Then finally cut the excess end at the external opening, keep the external opening open. Thank you. Anyway, I think the procedure is over. Thank you.
थैंक यू डॉक्टर आशीष. आपने बोला था कि हाई फिस्टुला में सबकी पड़ती है. Yes, but you showed us a very low fistula.
Yes, sir.
I would have done a fistulotomy, number one.
True.
Or I would have used, like Dr. Chote puts a collagen sheet, 1,200 rupees. You're putting a 60,000 fistula plug in a very short fistula tract. Maybe long ones are okay, but this one I totally don't agree. I mean, it's just a waste of patients' money. And I am sure many patients come to you saying that it came out in the toilet. I know you're fixing it, it may come out. But, using it for high tract, okay, I may understand. Secondly, how many high internal openings do you actually see? It's a myth that it's a high internal opening. MRI says it's high opening.
It's not a question of volume, or it's not.
No, it's not volume.
I never said that use plug in every case. I never said that you should use at least 100 plugs. If you are finding 1 in 1,000, use it for it.
But when you are,
I am talking about indication of the plug.
You started your talk with long, high fistula tracts. Yet you showed a very short fistula tract.
Yes, because
that is giving a wrong message to the audience who have come all the way to listen to.
This was to show the technique, and not to, like, we never discuss about the indications. That's why I said it when you have a high fistula or high internal opening, this is the best thing. What options do you have?
Okay,
this is the best option. That is what I wanted to say.
What I'm saying, the number of high fistulas any surgeon is going to see in his whole lifetime is a small amount. Now, you've done over 400 plugs, correct? How many high fistula tracts have you done? I don't think you have seen 400. We haven't seen, Dr. Parvesh Sheikh probably has never seen 400.
Sir, I have put 2,500 plugs, not a question about that. The point is,
Dr. Ashish, can we have the discussion later on in the lunch session? We are running short on time.
Sorry.
So the last speaker of this session is Dr. Kanagawal. He will be speaking on the miscellaneous procedures, whatever is left.
No, no. I will. It was not added in the final program, I guess. Friends, it is going to be about stem cell. When Dr. Niranjan said, I don't do stem cell by myself, but I do few PRPs. But then I'm going to talk about where do we stand on stem cell? What a conference without a stem cell discussion on. So I'm going to be very brief, and I will save definitely some time for you. Right. So thank you, the Mumbai team, for inviting me. Take blessings from my teacher. Invite to Indore as well as Chennai is hosting for the Accuracycon 24. We soon are planning to release the information brochures. Chennai welcomes you. This is one of the recent program which we did in Chennai, the Advanced Proctology Workshop. And this is about the reference so that I don't want to clutter the slides. And please understand what has been discussed from morning is an immunological reaction which happens and which makes the fistula to heal or not to heal, or whatever happens is fundamentally an immune-based disease. So I'm going to touch upon the stem cells, how it is going to work. Stem cells are fundamentally embryological origin stuff, but then adult stem cells are also happening in hematopoietic, intestinal, mesenchymal stem cells. Principally, they are multipotential and has huge renewal capacity. Please remember these 4 words: regeneration of the local tissue, improves vascularity and migrates the blood cells towards the healing part, increases other fibroblast migration, and it potentially stimulates growth, down-regulates the immune reaction so that it heals off, down-regulates the inflammatory process. So, for you to understand more in deep the mesenchymal stem cells migration to sites of active inflammation, the IL-10, hepatocyte growth factors, TGF-beta-1, and of course it produces a less inflamed environment. So these are the 2 cores, the adipose-derived stem cells, which are much easier, which can be obtained with liposuction, and the other one is the bone marrow derived. So what are the delivery modalities? They can be locally administered, intravenous infusion can be a source, and then a bone marrow transplantation can also be done. Now the recent publications have started telling topical. This looks more exciting. We have to wait for more results. Dissolvable matrix and the fibrin combo has been published. So a quick recap. It is a sort of a technology driven thing. Many centers which has bone marrow transplant facility or stem cell facility for cancer treatment will be able to easily do it. Usually either it can be a liposuction isolation or a bone marrow harvesting. It has to go for an in vitro culture. Cell expansion is done. So you need adequate cell multiplication before doing it. Keep it cryopreserved, and whenever you are ready, you can go for implantation.
Can we have some silence in the auditorium, please?
So, thank you, sir. So, it is a process. This has been studied very, very well in this study. This is an open publication. Initially, prior to treatment, on installation of the treatment, the entire gamut of T cell gets simulated. Eventually, you can see the amount of inflammatory cells have disappeared and only fibroblast remains. Lot of science are involved, but quite expensive. I bring to your notice, this is a scanning electron microscope of this plug therapy, where you can see it is fully loaded with stem cells, and then eventually it can be soaked at multiple things so that you can go for multiple track placement also. People will jump on me how efficient it is. The short-term efficiency, this is one of the very recently well-published meta-analysis of more than 900 patients. The short-term, long-term, over long-term, beyond 1 year, the results seem to be acceptable. So, are we talking about all fistulas? It is more effective in IBD. IBD fistulas are the one which are more extensively studied in this, but they also claim good results in recurrent and complex fistulas. What is the optimal thing? Bone marrow is the most optimal thing because you get the maximum number of stem cells available, but then it is more difficult, painful, it involves a huge cumbersome process. For a fistula, many people will think twice. Then became the easier thing, the adipose cell therapy. All of us have easy access to liposuction. Any one of us can do it. So they have very clearly mentioned the progenitors are also present in liposuction device. Adipose cells can be aspirated from lower abdomen, flanks, inner thigh, whatever it is. It becomes very easy to prepare. 130 grams you can prepare in short time. But it has to be having so many stem cell loads. I will skip the video. It is a straightforward injection, how you do like a Botox therapy. So it has to be 4 quadrants into the fistula tract also. That is the message. In total, the delivery should be 10 into 10 or 7 total cell dosage. This is where many centers, many publications fail. We do not have a foolproof method or standardization for us to say, yes, I've installed so much of stem cells into the fistula. But centers which are robust, the Swiss group have established if you are going to put so many stem cells into it, it heals. But poor man's thing, what is easily doable by us is the platelet-rich plasma. They are nowhere near stem cells, but still it gives equivalent growth factors implied, and the more or less principle of growth factors are 30 to 40% of stem cells, but it gives good results. But again, very short papers ranges from 30 to 80% of success. But over a period of time, the stem cell on adipose seeming to be gaining importance because of ease of doability. At this point of time, healing rates are up of 50%. Again, if you are going to talk about the mesenchymal stem cells, healing rate of up till 90% are being claimed, but please be aware 25% are also claimed on the other end. So to close with, the stem cell recommendations have been included in the German S3 guidelines, but this is one thing you should be aware, which is freely available, IBD fistula therapy, where you get to know very clear indication where non-operative surgical indications are there for IBD fistulas. That is where it holds it. One more thing, easier job. I don't want anything. Commercially available stem cells are there, but the cost is $87,000 for one treatment. So that is the safest stem cells which are available. But I think we have to go very long way to consider this as a standard of care. But sure thing, you should be aware of this surgical advancement which is happening at the other part of the world. Thank you, Chairperson, for the opportunity.
Thank you, Dr. Kangule. Because already, actually, we are running very late for inauguration.
Thank you very much.
Guests are waiting. So we are going to finish this session on complex fistula, and I'll invite Dr. Niranjan for inauguration and other things. Yes, madam. For the all delegates and the faculties, the lunch will be served after the inauguration is completed. So please be seated in the hall. Please don't go. Just wait for the inauguration. Thank you very much.
Blank side.
नहीं इसको थोड़ा पीछे खिसका देंगे इसको पीछे दे बस परफेक्ट हो गया
Left to right get
खींचते बैठना पड़ेगा लेकिन
Hello. Good afternoon, everyone. Now we come to the inaugural function. And me, Dr. Naresh Rao, along with my co-MOC, Dr. Shalakha Indap, will conduct this program. I request all the dignitaries, Dr. Parvez Sheikh, I request you to please escort Dr. Sanjay Jain, President of ASI, who is the chief guest of this function, to the dais. Dr. Niranjan Agarwal to escort Dr. Pratap Barute, Honorary Secretary of ASI, to the dais. Dr. Roy Patankar to escort Dr. Sanjay Kolte, President MASI, who is a guest of honor, to the dais. Dr. Rajesh Yadav, Samir actually is not there. So I also request Dr. Pradesh Sharma, Vice President of ACRSI, and Dr. Kushal Mittal, Honorary Secretary, ACRSI, Dr. Debashish Das, Honorary Secretary, Mumbai Surgical Society, and Dr. Prashant Rahate, President of ISCP, to come on the dais. Friends, Dr. Parvez Sheikh is the convener of this program, Fistulacon 2023. I request Dr. Sheikh to welcome the dignitaries on the dais and everyone.
Thank you, Naresh. Dr. Sanjay Jain, our President of ASI, Dr. Varute, Secretary of ASI, Dr. Pradeep Sharma, President-elect of ACRSI, Dr. Sanjay Kolte, the President of the Maharashtra chapter of ASI, Dr. Prashant Rahate, who is the President of the ISCP, International Society of Coloproctology, the other dignitaries on the dais, Dr. Rajesh Yadav, Dr. Debashish Das, Roy Patankar, my co-convener of this conference, and of course Dr. Niranjan Agarwal, without whom this conference would not have taken place. A very warm welcome to all of you who are inside and also who are outside now. When we, originally this conference was planned by Roy as a one-day workshop on fistula. And it was Dr. Niranjan Agarwal's idea that we should have a conference, instead of just a workshop, we should have a conference on Fistulacon. And since it will be a unique single subject conference, when we planned this, we were not expecting that we would have such a response. But we are overwhelmed by this huge response, and that just indicates how popular or how ill understood fistula is, and the need to learn about fistula. So you can see people have come from all over the country in such a short notice. I think it was just over a month that we decided to do this conference, and already we have such a huge crowd. And Niranjan wanted to stop the registration because he said that we don't have place to sit. So I would like to apologize to all those people who could not get a seat or who had to stand up or otherwise. So I'm very happy to welcome, and I'm really grateful to all of you
Dr. Jailal is there, Dr. Ravi Vankirkar is there, coming all the way here, Dr. Chivte, the past president of ISCP. It's really very humbling that all of you have come to attend this conference. Dr. Shiv Uttare, my ex-roommate, and also president of so many bodies in the IMA and NMC and things like that. It is with great humility that I welcome you all, and thank you very much for accepting our invitation at such a short notice. And at such a short notice. We are also thankful for people, Dr. Sanjay Jain for accepting this, Dr. Shiva Mishra for agreeing to come at such a short notice and gracing our occasion. We have tried to include not only people from the ASI, Maharashtra chapter of ASI, but also for the first time we have got dignitaries from ACRSI and ISCP together in one platform, which I think itself, since this is, we are not, that is the reason why we decided to do this conference under the Colorectal Foundation Trust and not to do it as a society, so that we actually do really academics and get the best of everybody to come and speak here and participate. So thank you once again, and a warm welcome to you all.
We would now be starting with welcoming our dignitaries with floral bouquets. I request Dr. Parvez Sheikh, the convener, to welcome Dr. Sanjay Jain with a floral bouquet. I also request Dr. Parvez Sheikh to welcome Dr. Pratap Varute. We would also like to welcome Dr. Sanjay Kolte. I request Dr. Niranjan Agrawal, the co-convener, to welcome Dr. Pradeep Sharma with floral bouquet. And also to request him to welcome Dr. Kushal Mittal. Next, I would like to request Patankar sir, who is also the co-convener, to welcome Dr. Rajesh Yadav. He's the president of MSS, and also Dr. Debashish Das, who is the honorary secretary of MSS. We would now like to request the dignitaries for the lamp lighting. I would request Dr. Niranjan to request to him to felicitate Dr. Prashant Rahate. We will now proceed with the lamp lighting.
Prashant.
This is a photo that we should keep.
Thank you, everyone. Please take your seats. As tradition has it, we honor our dignitaries by the traditional shawl, memento, and shrifal. I would request Dr. Niranjan Agarwal to start the felicitation process, Dr. Roy and Dr. Parvez Sheikh to felicitate Dr. Sanjay Jain, President of ASI, our chief guest. Please felicitate Dr. Pratap Varute, Honorary Secretary of Association of Surgeons of India. Sanjay Kolte. Please felicitate Dr. Sanjay Kolte. There are a few stalwarts who we would personally like to thank and felicitate who are sitting with us in the audience. I request Dr. Shiva Mishra, sir, please come up, the past president of ASI. Dr. Rajesh, please give him a shawl. Dr. Parvesh, a memento. Pradeep Sharma, the Shrifal, and Kushal Mittal, the floral bouquet.
For the audience, Dr. Shiva Mishra, as the member of the National Board of Examination, as the Vice Chairman, was instrumental in starting colorectal fellowship of 2 years for the people who are interested in colorectal surgery. So a huge thank you from our community of colorectal surgeons to you, sir. We are indebted always with you.
I request Dr. Abhay Dalvi, past president of ASI, I request Dr. Kishore to please felicitate him with a shawl, Dr. Parvez, the memento, Shrifal by Shekhar Suratkar, and the bouquet by Dr. Das. He has been a guiding force for Mumbai Surgical Society and our own member. We're very proud to have him here with us. Dr. Ravi Wankhedkar, sir. Dr. Dharap, please felicitate him by giving him the shawl. Dharap sir nahi hai. Dharap sir nahi hai, le lo. Dr. Parvez, the memento. He's there. Rajesh, the Shrifal and the floral bouquet. Praveen Gore. Praveen nahi. De do. We have amongst us a surgeon who is the Vice President of IMA National, Dr. Shivkumar Utture. Till recently, he was the President of Maharashtra Medical Council. Sir, I request you to please come up on the dais. Dr. Dharap, please felicitate him with the shawl. Dr. Parvez, memento. Niranjan, the Shrifal, and Dr. Gore with the floral bouquet. Dr. Jailal, an eminent teacher. Niranjan, please welcome him and felicitate with the shawl. Memento by Parvez. Roy, please, the Shrifal. And Kushal, the floral bouquet. Dr. Shanti Kumar Chivte, a very senior and eminent surgeon. Sir, please come up. Ashwini, please felicitate him with the shawl. Shalaka with the Shrifal. And Rajesh, the floral bouquet. Our young and dynamic treasurer of Masi, Madam Anjali Dhavle, please come up. Ashwini, please felicitate her with a shawl. Shalaka with the Shrifal. Dr. Parvez with the memento. And Rajesh with the floral bouquet. Thank you everyone, especially the members on the dais and our dignitaries.
We would now request our guest of honor. We would request Dr. Sanjay Kolte, President of Masi, to address us.
Our chief guest, today's chief guest, Dr. Sanjay Jain, President of All India Surgeons of India, and all the dignitaries on the dais and off the dais. I bring warm greetings from the Maharashtra State Chapter of ASI, and I feel very humble and privileged to stand here in front of you as the President of Masi. I would like to thank the organizers of Fistulacon, which is a single theme conference and arranged in such a short span, and what a grand show. Congratulate Dr. Parvesh Sheikh sir, Dr. Niranjan Agarwal sir, Dr. Rao Patankar sir, and the entire team of Fistulacon for arranging this conference in such a short span and such a very well organized conference, one of the conferences I've attended so far. So thank you so much for such a pleasurable experience for all of us and knowledgeable experience, I must say. I'm very happy to see this conference being attended by so many postgraduates and young surgeons as well. For them, such single thing conferences more and more should be arranged, and it's very, very, very beneficial for these in their practice. I thanks again to the organizers for inviting me for this conference, and my best wishes for the remaining conference. Thank you so much.
We would like to welcome Dr. Pratap Varute to address us. He is Honorary Secretary of the ASI.
Good afternoon, dear delegates and esteemed faculties present here today for this fabulous Fistulacon 2023 organized at this scenic premises of Hotel Leela. Chief guest of today's inaugural ceremony, President ASI Dr. Sanjay Kumar Jain, Convener of this conference, Dr. Parvesh Sheikh sir, President, Maharashtra State Chapter, Dr. Sanjay Kolte, President, Mumbai Surgical Society, Dr. Rajesh Yadav, Secretary, Dr. Debashish Das, Vice President, ACRSI, Dr. Pradeep Sharma, Secretary, Dr. Kushal Mittal, President of ISCP, Dr. Prashant Rahate, Treasurer, Masi, Dr. Anjali Dawle, and the co-conveners and our very close friends from National EC, Dr. Roy Patankar sir and Dr. Niranjan Agarwal, honorary past presidents ASI who are here to bless us, advisor to National EC, Dr. Shivakant Mishra sir, Dr. Abhay Dalvi sir, and all the galaxy of stalwarts present here today. It's truly an amazing feeling to be amidst us for this fabulous event organized in Mumbai. They have invited almost all the top-notch faculties from the nation, in other words, Tare Zami Par, for this Fistulacon. With the collective wisdom of all, we are sharing and learning our experiences about this very important, least understood, and many times difficult disease to manage, that is fistula. In fact, there is no gold standard treatment for anal fistula, which makes it more confusing for the entire surgical fraternity. We must congratulate and appreciate the efforts of the organizers who themselves are the who's and who's who in the field of enoproctology, and they have gathered all the experts pan-India under one roof to discuss the intricacies of diagnosis and managing complex fistula in ano. Most importantly, I feel that this kind of single-theme conferences conducted over a weekend give a lot of inputs to the delegates and the tricks which you can practice when you go back home next day on Monday. You all have witnessed the extremely successful ASICON 2022 organized by the same team of organizers in Mumbai. So we are fully confident that there will be no stone unturned as far as the expectations of the delegates are concerned in this Fistulacon. I pay my sincere gratitude for inviting me here in the capacity of Honorary Secretary ASI. It is truly a wonderful experience, and I am deeply humbled by the generosity of the hospitality. In fact, I feel extremely proud to be a tiny part of our great organization, that is the Association of Surgeons of India. And when you are invited and honored our office bearers here on this platform, it is in fact you have honored the ASI and our central headquarters. Thank you very much. Long live Colorectal Foundation Trust Mumbai. Long live Mumbai Surgical Society. Long live Masi. Long live ASI. Jai Hind. Jai Maharashtra.
We would now like to call upon Dr. Sanjay Jain, President of ASI, to address us.
Good afternoon, everybody. It's a good opportunity to welcome you all in this hall. And just I would like to take the liberty as a chief guest. The chief guest is supposed to address the entire the stage and the gathering. So I would like to take the liberty and a request to allow me to break this protocol. And the very reason is because you all know and we know in our heart, the people who are sitting in the hall, they all are our respected seniors, our teachers, our mentors. So I would like to call all of you as the respected members in this hall and all the respected people here on the dais. With those words, this is the moment I would like to use for some of the nostalgic moment and some of the feelings which I wanted to share, which are there in my heart. We have with us Dr. Shiva Mishra, who is the person because of whom I am standing here. He spotted me, I do not know how, because we were not knowing each other before that, but he could point out and he could find me in Jaipur Essicon and told me to work as the secretary could not come because of certain unavoidable reasons. And that is the beginning of my journey. And then Dr. Abhay Dalvi sir, so जो शुरू हुई थी उसको परवान देने का काम Dr. Abhay Dalvi sir, he did, and we enjoyed very good time. He was the president and I was working as secretary, and with all the blessings of you, I am standing here as president. I just want to express my gratitude and say pranam. All of you know Dr. Parvez, and whether senior or junior, we all are his admirers. So definitely we had our relationship. The one special thing which I would like to, my relationship with Niranjan has been little bit Bollywood style. We know whether there are two heroes in a movie, how they meet, so and how they become friends. So initial they will have a big fight, and after that, that will resolve a lifelong friendship. The same kind of relationship we are enjoying. So initial days, because both are straightforward, both are committed to their work, so we had a couple of difference of opinion, but not now. I am so happy to be here, and it was my pleasure to be here. When I see people like Dr. Jailal, who is always our inspiration, Dr. Shivuttare, Dr. Begani is there. So if I start calling everybody is respected here, Dr. Kolte means entire hall. What I would like to say, I would like to congratulate the CRFT, ACRSI and Mumbai Surgical Society. Why? Because if you see the role of associations, it should be complementary, not contradictory, and this is the best example we can witness today. We have been growing, seeing the conferences based on broad specialty, then became the organ specific, and today we are witnessing a conference based on single disease. And what disease it is, you can appreciate by the people not sitting, standing in this hall. And this has been the scenario, even this thing. And this fistula is a notorious problem at the notorious place, creating notorious issues for the persons who treat them. One thing which is very, very important, and I found here that it is not a technology-driven conference, rather it is technique-based. This is the time when we should be remembering that as per the last data, when the world's population was around 7 billions, 5 billions people were not having an access to the safe and timely surgery. Today we have crossed 8 billions, so this number would have gone also higher. The second thing which I would like to share, in India, that 39 million families are pushed every year to the poverty because they have to face one of the surgical issues. So this is the time. I do not say that we should not grow, we should have moon mission, we should have Mars mission, but that is not all. We have to take care of these 43 million people also, and that is why the techniques should always be over the technology, which I think the best example is Dr. Parvez, who will always teach us that how to cut the sphincter and how to reunite. Don't be afraid. So we praise his efforts, but sir, one thing is very, very important, that one Dr. Parvez Sheikh is not enough for this big country. We need more people like you, and I hope you have dedicated your life, because I have seen at least 2-3 times you coming to Bhopal, demonstrating in a very simple and straightforward person. So my heartiest greetings and thanks to them. Finally, before I conclude, I would like to thank the organizers for inviting me and allowing me to meet you all, learn a lot. Even when I came in the hall little late, I was there standing and watching the program rather than standing outside the hall. And what I would like to promise, that in the forthcoming ASICON, in the ACRSI hall, no one who is in the audience need to stand. I will ensure that the hall should be big enough to accommodate all the people who are interested and who are dedicated to this discipline. And I invite you all to the ASICON at Visakhapatnam. So with these few words, once again, thank you all for giving your love, affection, guidance, mentoring, and finally you have gave me this position where I think you should also feel proud, because a father or a guardian feels more proud when their offsprings achieve something rather than they themselves achieving. Thank you, sir. Thank you, everybody. Namaskar.
Our inauguration would be incomplete without a vote of thanks. We request Dr. Niranjan Agarwal, our convener, and the Honorary Secretary for the Colorectal Foundation Trust.
Good afternoon, everybody. I'm aware that I'm coming between you and the food, and I have to restrict myself, but it would be an incomplete duty after working for 1 month and not thanking the people who had made this event possible. So it is my proud privilege to present this vote of thanks, and my first thank is to our National President of ASI, Dr. Sanjay Jain. At one hand, he calls me my brother, and the other side he says कि we have a voluminous relationship. मेरी नानी हमेशा कहती थी, दोस्त जैसा भाई नहीं हो सकता और भाई के से बड़ा दोस्त नहीं हो सकता है. तो सर, आपकी डांटें जो मिलती थी वो आगे बढ़ने के लिए it was like inspiration and improving on further thing, and I am sure you must have noticed that there is some improvement today than compared to last time. So thank you for coming here with us. Dr. Varute, our man from Maharashtra, who brings all the blessings from Mumbai to us, from Kolhapur, whenever he comes us, bless us, and always positive thoughts about us, very positive relationship. Thank you, sir. At one call, he agreed, even he had booked a ticket earlier, but then because of the inauguration, he changed the program and booked another ticket. So much thankful to you, sir, for being with us. Our past presidents of ASI, Dr. Shiva Mishra, again an elderly brother this thing. And Dr. Abhay Dadvi, he is our Swami Samartha, I always call him, he keeps on guiding whether he's sitting back or anything. Right, 1:30 he called me up, Niranjan, you have done this mistake, So he watches everything very barik se apan jo bolte hain. He keeps a very big watch on all of us, what we are doing, and keep on guiding us. So thank you, sir, for coming with us. Our IMA National President, past presidents, our Dr. Wankhedkar, Dr. Jayalal, Dr. Shiv Ture, and so many other dignitaries who are here, Dr. Chivte, Dr. Ladda is also here, and my own trustees of Colorectal Foundation Trust, who are like, not my elder brothers, they are like my uncles, because they all are into that age group. And since a childhood, like when I was a student, Dr. Begani, Dr. Naryani, Dr. Kishore, they all held my hand, and today, whatever I am here today is because of these are my mentors over here, who has always encouraged. In Bombay Hospital, our relationship in the surgery department is completely different kind of family. We don't pull down each other, we bring up each other. We uplift each other, and this uplifted man is a result of what you are seeing today because of Dr. Naryani, Begani, Kishore, and Dr. Shikhande, and all who are. Sir is not here, he is into 90 plus, but his blessings are always with us, and I must acknowledge that his blessings are something which help us over here. Dr. Kolte, who is the first surgeon of Maharashtra, because he is the president of Maharashtra Masi Surgeon Association, thank you for coming with us. Office bearer of ACRSI and Mumbai Surgical Society and IFCP, because they provided unconditional support to this event, without even thinking any much. Fistulacon, yes, go ahead, we are all with you. So Dr. Nishad, Dr. Pradeep, Dr. Kushal, Dr. Rajesh Yadav, Dr. Dharab, Dr. Debashish Das, Dr. Prashant Rahate and his team, everybody, thank you a lot for coming here and joining forces with us. Today what you saw was CME, tomorrow you will see operative workshop. Around 10 to 12 cases are planned up with different fistulas and different modalities, and all thanks to the original idea creator of this Fistulacon, that is Dr. Roy Patenkar and Gen Hospital team. It is because of his idea of conducting the workshop that Fistulacon was born out of that, as Parvez already mentioned that. An event of such magnitude definitely cannot happen without support from the industries, and I must thank all the people who are standing outside in stall and have supported us, and chiefly among them is Torrent, the both divisions of Abbott, GI Pharma as well as Maxima, Juventus, Sun Pharma, Alchem both divisions, and many other instrument companies. Neo V Laser will be taking care of the operative workshop tomorrow. So all these people have helped us, and I need to thank all of them. Our audiovisual team led by Dinesh Pal, our management of Leela Hotel, who is providing us all the hospitality care, and last though not the least, to coordinate all those things, the Vama team, who is always with us in all our conferences, led by Vikram Patwardhan and his team comprising of Pramesh, etc. So they have all worked very hard, and I must take this opportunity to thank all of them. Last, though not the least, your presence here, my dear delegate, is the one which makes me say thank you to everyone. Without you, I couldn't have thanked anyone, So your presence in large number is what has made us successful. We thank all of you for coming here all the way. There are more than 430 registration today, and let me tell you, more than 300 are paid from their own pocket. This is what fistula is. I was told that people are standing. I apologize, because we were, as Parvez said, we were prepared for 200 and we crossed double that. So otherwise we would have booked a bigger venue for that, same thing. So next time we do a Fistulacon, we'll do it in an open ground like we did for SACon. So thank you so much, everybody. Thank you very much.
Requesting everyone to please stand up for the national anthem. We shall be concluding our inauguration.
इसका presentation रह गया, उसके बाद करा.
भारत भाग्य विधाता, पंजाब सिंध गुजरात मराठा द्राविड उत्कल बंगा,
विंध्य हिमाचल यमुना गंगा उच्चल जलधि तरंगा तब शुभ नामे जागे तब शुभ आशीष मांगे गाए तब जय गाता जनगण मंगलदायक जय हे गायत भाग्य विधाता जय हे जय हे जय हे जय 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 हे.
Thank you, everyone. Before we break, I'll request all the dignitaries who are felicitated to please come up on the dais for a group photograph, which will be really very memorable. The lunch has been divided into 3 different parts. We have lunch outside and in that hall. And to make it manageable, we have, for the faculty, lunch is being served at the breakfast area, the Citrus the coffee shop. And before we finish, ASICON has got a promotional video which needs to be played just now. And please come up on the dais for the photographs. शलाका अश्विनी आ जाओ.
ये लेटेस्ट ये 2 फ्लायर्स हैं, आप बीच बीच में लूप में करेंगे. ये वीडियो चलाना है तो उनका फ़ोटो हो जाए, जैसे होगा आप अपलोड कर देंगे. ठीक है. No, sure. That's what I was asking after the photo session. You load it. It's there, sir.
आगे बैठना. नहीं आप बैठिए. निरंजन sit down. You have to sit down. हुकुम सर एक सेट ना अपलिफ्ट करते हैं. एलईडी से एलईडी नहीं अभी तो ओके ready yes some of you look here smile cheers wait hold cheers or cheers cheers during your thumbs up smile. Thank you. We will come back in half an hour. Play the SI. Play. Dal the jaldi dal.
Console. We will meet again at 2:15. The afternoon session will start at 2:15. हाँ चालू करो. अरे इसका स्क्रीन में नहीं आ रहा.
Welcome to Visakhapatnam, the city of destiny, for the 83rd annual conference of the Association of Surgeons of India ASICON 2023 from 13th to 16th December 2023. The workshop and scientific sessions on surgery have been meticulously planned. The aim of this conference is to update our knowledge and skills and to catch up with the rapidly progressing science and cutting-edge technology. Nestled along the coast of Bay of Bengal, Visakhapatnam is the jewel of East Coast located in the heart of Andhra Pradesh. Visakhapatnam is known for its scenic beaches, serene landscape, and rich cultural heritage. In addition to being India's natural port, Visakhapatnam is also home to the deepest port in the country, which is a major base for the Indian Navy. You simply cannot go to a coastal city like Visakhapatnam and not see its beaches. Vizag is dotted with many beaches along its coastline. To name a few beaches would be Ramakrishna Beach, Murata Beach, and many more. With its air connectivity, road, and rail links, Vizag is well connected with the rest of India, located a short distance away from Visakhapatnam. Baraka Valley is one
this session. May I invite Dr. Tamonash Chaudhary, sir, please.
Please. Chalo. Excuse me. Bow. Good afternoon, my friends, my seniors, colleagues. It's a really a different kind of feeling here at a conference of a single disease. And what I realized reaching here, this is a place where we can learn. I think all of us can learn from someone, from other person. It is a platform where everybody can share their experience and each other can be enriched by these conference. And what I realized, that there is a lot of areas where we are not doing good, we are not practicing good, we must refine our practice. Even for a long time, what we are practicing may not that is correct. So these conference, I think one of the very different kind of conference. Honestly, now today, most of the time I am not doing any high fistula repair because I have seen, I have a practice, I have done VAFT, I have done other procedures that I will show, but I have seen a high recurrence. So subsequently, I do some other surgeries, except in lower fistulas, I don't do in higher fistula management by myself. But what I want to share experience, that journey I want to share, where we should stop, we should not do, where we need an expert to do the job. That's the point we should learn. And I think we should understand. Basically, these high transsphincteric, all the nomenclature can be different. I just show you some photos. It's very difficult to treat. And there is a possibility of functional disability. That is the loss of sphincter and continence. And that really create a person's life very difficult. So, it's very difficult to diagnosis. And now I know so many people doing, at least some centers doing very good perineal USG. Some people depends on MRI, CT, fistulogram. But one thing is very important in fistula surgeries, good clinical examination. A surgeon must do a good clinical examination, should not depend on the investigations. That should be, and then we should plan, at least we should have ideas that where the tract can be. Then we should plan for the surgery. What can be the best? There is not a single answer for any of the fistulas. What can be different? These are all standard anatomies. I just come to this one. Normally, these are the high fistula, what we say. It's either transsphincteric or suprasphincteric. In a one line, we can say if any fistula tract opening is above dental line, we can treat it as a high kind of fistula. In more than 90% fistulas, the internal opening we can identify below the dental line and in around. But if 1 or 2% fistulas which is very high, open in the high, it may have some other disease. Until unless we examine properly, that can have a rectal cancers, that can be iatrogenic other injuries, that can be have a Crohn's disease. So a proper examination and to identify the reason for fistula, that is also important. Or if we do the treat only the fistula, the patient may not recover from the disease. So we must do it. Either these are all different kind of nomenclature: supralevator, suprasphincteric, extrasphincteric fistula. But now we have a different options. One thing, the CT scan with fistulogram may be not required where the facilities of MRI there. Where the good perineal USG is there, I think the MRI or the CT which is not required. But one line is important: USG is absolutely person dependent. The person who will examine, he or she must be very confident to identify the sphincter, to identify the fistula's tract. To mapping of the fistula is very important to identify the tract. If someone have a good USG and someone practice it, he or she can do it, but other person may not do it. So, or in that case, we can go for MRI or MRI fistulogram. That normally standard we do. And so evaluation, examination, and another issue, we should not operate in a patient with some infection, discharge or pus, or there is abscess. That to be drained properly. If we treat a fistula, we should treat it like a fistula only, not a abscess along with that. So that to be treated properly, any sepsis kind of thing. And there is a lot of emerging technologies is coming, particularly like a WAFT. I put in the last. Me personally tried almost 10-12 WAFT surgeries, then I stop it. There is a huge number of complications. I can show one of the patient, because we do to see the tract, we put the mannitol, diluted mannitol to see the tract, and that retain, and there is a huge abscess subsequently. And it is a huge number, almost 30% recurrence in fistulas in WAFT, our experience. So after 10-12 cases we are not doing, but WAFT till the instrument is with us, sometimes we check to identify the tract, but not more than that. Laser is other way. There is a lot of people is trying to manage the fistulogram. It is principally the same kind of, it's a burning of the tract, identify the internal opening, ligature of the internal opening, and then burn the tract with the, either laser or by standard monopolar ball cautery which is used in graft. Both can be used, but I have no idea about laser. This is the pathway where we can identify a lot of options. But what options I put that I have practiced these options. I went to BHU for training of Khar Sutra training. Once I take it in a quite long back, 10-15 years back, for fistulogram, seton therapy. And initial 4-5 cases we put seton in a fistulas, even 1 or 2 in low fistulas we put in. It is a huge, there is a pouring of discharge from the Khar Sutra. It's very irritant, it's alkaline, there's nothing but it's a thread, long thread. On thread they put some alkaline chemicals, and that thread we put in and we just tie it. And what happens, it can be done by some local anesthetics, but it's a pouring, lot of discharge. It's very uncomfortable for the patient. And every almost 3-4 days after patient is coming, and it very difficult to cleaning. So truly we have stopped it to use it to give a uncomfortable. But then we used to practice for a high fistula, the set-on therapy. These are all other options are there. Lift, fistula plug, advancement flap, fistulotomy. These are all options are there. We do set-on therapy. How we do it? Just take 1 minute. Corsutra we are not doing. We use polypropylene sutures. We do an initial fistulotomy because the thread should not be come in contact with the skin. Some fistulotomy. Then we probing, identify the internal opening with the tract. Then we put the, particularly for the sphincter only, we put the polypropylene. I used to do at least a 2 to 3 number of proline, but means number 1 proline, 3 number of threads. But I think we have one, Professor Ashok Ladha is here. He is one of the man who is doing a lot of set-on therapy in different types. Sir will talk on how to do the proper set-on. And today I learned from Sir how to do the best of the set-ons which can avoid this fistula. So at the end, we can avoid a recurrence if we have a good anatomy, a good technique, and definitely if required, and honestly, sometimes if I don't do a proper high-end fistula now, I refer to someone, they are doing the best. Patient care at the end of the time is the best. It is not the personal ego. Thank you very much for your patient hearing. Thank you. Yeah, problem. Thank you. Yeah, then you can manage the time, yes. And I'll be happy the sir will answer all the questions. Thank you very much. Thank you.
Dr. S.K. Nigam, sir, we welcome you and request you to deliver your talk on intrasphincteric fistula.
Yeah.
I am talking strictly with the permission of chair on the intersphincteric fistula. I will not cross any other my limit, and I will not talk on any other fistula. As you know, I am thankful to the organizer giving the topic which is most common, because 45% of the all fistulas are intersphincteric fistulas. So first of all, I will tell you how I examine the patient. First of all, in the OPD, I examine the patient and look at its external opening and in reference to its o'clock position and how much distance it is away from the anal verge. Then I palpate the trach. We see whether it is directing radially or going towards the 6 o'clock position. Then we see the distance of external opening from the outer border of the sphincter, because this is the trach which is running in the ischiorectal fossa. It is not of very significance. Then I palpate the trach over the external sphincter. With the time you can palpate the internal external sphincter separately. If the fistula is present over the external sphincter, it means it is going below the external sphincter, means it is intersphincteric fistula. Then I do the PR and palpate for the internal opening and again locate its opening in o'clock position and how much distance it is away from the anal verge. Then I used to do the dye test, for which I insert a well lubricated gauge piece inside the anal canal and push the betadine mixed with hydrogen peroxide from the external opening. If my gauge piece comes stained, means it is a positive dye test, otherwise it is negative. Then I do the proctoscopy and try to visualize the internal opening, again in relation to its o'clock position and how much distance it is away from the anal verge and how much below it is from the anorectal ring. And with the time we can palpate it. You see, if trach is not palpable, internal opening not palpable means dye test is negative. I pull it and see the internal opening can be pulling out. And my finger is pushing the external sphincter left outside, means it is simple intersphincteric fistula. I will do the coring. After examination, I do the dye test on the table also. It not only gives us the idea of opening inside the anal canal, if there is any external secondary tract is there, you can identify with this. For example, in this case, you see that there is one secondary opening at the base of the penis. I used to do the proctoscopy by this cut proctoscope, so I can visualize the dye and as well as internal opening. As far as investigation, fistulogram is of no use because it does not show any sphincter complex. Then I used to do if we do endoanal sonography, it is difficult to assess the external sphincter particularly, and infection cannot be distinguished from the fibrosis, and there is failure to identify the secondary ramification. So best is the MRI, which gives almost 90 to 94% result. It gives the extension in horizontal direction as well as in vertical direction. And as far as treatment, best treatment is fistulotomy, and which is very simple. Just insert the probe inside the cavity and just cut it. My job is over. Sometime I used to do Solomon's modifications, means T-shape cutting of the external opening to make it broad and to prevent the primary healing. Another option is do the fistulectomy. Fistulectomy offers us to remove the disease completely, means eradicate the infection. And after fistulotomy and fistulectomy, we can do the saucerization, which I learned from Dr. Ladda sir, sitting here. It reduces the wound size and promote the early healing. I do mucosal advancement flap in some cases, particularly when patient insists for the laser. Along with laser, I do the mucosal advancement flap also. If there is only internal opening, it is a special condition, means trach is going upward. I open from inside and curate the trach. If the opening is lower only, no external opening, then I cut the internal sphincter up to the outer border. With the experience of Fisher, we know that a sphincter can be safely cut below the dentate line. And another, with the prevention of fistula, if there is only abscess, first we do the proctoscopy. If pus is coming from the inside, I open the abscess from inside. If it is low, I open it from inside to outside, and if it is high or transsphincteric, I put the seton from this along with abscess drainage. If there is intersphincteric abscess, means there is no extra abscess is running into the intersphincteric space, then I do the intersphincteric drainage of the abscess. In this way, I am preventing the fistula formation in advance. Thank you very much.
Thank you, sir. The topic is open for discussion. Any questions from the audience? I think it is in the last.
Thank you.
May I call upon Dr. Dinesh Shah to talk on the supralevator fistula.
Thank you, organizers. Dr. Kushal Mittal, Dr. Parvez, Dr. Niranjan, who was given this opportunity to talk about the supralevator fistula. Though it is a difficult topic which has given to me because recurrence rate is much more higher, difficult to treat, and we have to avoid the sphincter damage. So you can see that there is a supralevator area here. This is the levator ani, continuation of this external sphincter. So the fistula or abscess which occurs here is known as supralevator fistula. How is it formed? The importance of the formation lies in the procedure to be planned for its treatment. So we have discussed about all the classifications, and here the past classification came before 1961. So there is no space for this supralevator fistula. St. James University, the MRI depends upon it. It says that is a grade 5th fistula. But you know, all these both type parks and this classification doesn't tell about the management. But our colleague Dr. Garg has given his classification. He says that there are two types of fistula, low or high. Low means having the 1/3 of external sphincter is involved, and high more than it. So the all fistula which are having low fistula can be treated by simple fistulectomy, or the upper fistula we have to do the sphincter preservation. You can see this is the intersphincteric fistula, and there is extension of this fistula in supralevator space. And here this is the formation of secondary internal opening here, you can see. So there is the second opening of also here. This is the transsphincteric fistula having the extension in supralevator space. So it is important how to diagnose, as our previous speaker has told about all these procedures, that we have to first of all, the digital rectal examination is very much in each and every fistula case, by which we can examine the internal opening, or in supralevator abscess we can feel the bulge. We have the MRI, we have the test, but MRI is the very important tools in the present era. So we have to diagnose the type of fistula. So the management, what to do, it depends upon your etiology. But in all these cases, the important thing is to removal of the primary source of infection. So if we remove this complex, so that we can reduce the recurrence in all these fistulas. Here you can see there is no gold standard for supralevator fistula. Here we can do the internal fistulectomy, we can do the interfistulotomy, along with waft, we may do the laser, we may put the drain placement here, or the transrectal opening of posterior intersphincteric space, and we may do a drain also. So here we may go the internal fistulectomy and waft, we may leave the intersphincteric space open for the drainage, and if there is rectal opening is present, we have to close the rectal opening and note the anal opening. Because in rectal area there is low pressure area. So we may also go for the fistulectomy, we may go for the PSPR, waft. So many procedure depends upon your etiology and depends upon the surgeons how he is comfort to do the procedure. I have some experience. This is the recurrent fistula, having this treated by Char Sutra for last 6 months, but still he was having this problem. The fistula tract was not cured. So you see, this is the internal opening here, and this is the suprarectal opening. This is the external opening. So the cetone was present in between them. So we did the fistulectomy and the fistulotomy, but external sphincter was remaining intact, and this is the internal opening which was closed. So this is the image after 30 days, and then this is after 45 days. One another interesting case came to us with having Y-shape, reverse Y-shape fistula. This is the external opening. It was approximately 8 to 8.5 centimeter away from the dentate line, from the anal birth. Patient was taken in prone position. And when we did the fistulactomy, you can see this is the tract. And this is the, you can see this is the anal part and this is the supralevator part. So what we did, we remove all the tract here. This is reverse Y-shape, you can see this is the supralevator part. So in this case, we have to not working यार ये कर्सर काम ही नहीं कर रहा है दो यार उतनी देर वो टाइम हो जाएगा मेरा पूरा ओके so you can see this is the supralevator space and we have supralevator part. This is a reverse Y shaped tract, we have removed all. So here this is the important part, we have to take care of it, otherwise you may have the incontinence here. So the success fistula surgeons who can maintain fine balance between incontinence and the recurrence. So the post-op follow-up is very much important because in each fistula surgery you have to check out the dressings, you have to keep the wound clean, and antibiotics usually these are not necessary in all these, and improper follow-up can contribute to the recurrence. Thank you.
Thank you, sir. The next is Dr. Niranjan Agarwal. He is talking on the horseshoe fistula. Dr. Niranjan.
वीडियो एक फास्ट करने के लिए बताएंगे मार्क करिए हाँ वीडियो नहीं नहीं ये वाला है पॉइंटर है ठीक है
Good afternoon once again. Friends, horseshoe fistula, as you know, are fistulas with multiple external openings which are joined by subcutaneous communication in either a U-shaped manner or you may call it as a horseshoe manner. Infection invariably arises in the posterior midlines and spread to either side with arms directed anteriorly. This is the normal algorithm which in horseshoe fistula occurs, but sometime you may get the opposite configuration where the internal opening is at 12 o'clock in the midline and then the arms are pointing downward. They can be both intersphincteric, they can be both transsphincteric also. They can present as an acute abscess or a fistula. They are classified as complex because there are multiple openings as well as multiple tracts. They cross sphincters on either side and surgery on them would leave a large external wound, difficult to heal with disability attached to it and a very high recurrence and incontinence rates. So what are the options available? Most foremost is the de-roofing if it is an abscess or elimination of the internal opening which is the cause and then draining out the two side tracts. Drainage of the post-anal space and curettage again in an abscess, and now we have the removal of the tract with primary sphincter repair or using a kind of a hybrid procedure with laser. Alone laser does not work and satin is another possibility. So I'll show you what I do for this kind of fistula. The first and foremost, whenever you see an horseshoe fistula in your OPD, you try to do an MRI, which is a gold standard in such kind of complex fistula. And why should MRI be done? Because it not only shows you the site of the internal opening in most of the cases, at least it will show that the tract is pointing towards that. And then all the tracts in relation to the sphincters are well delineated, the collections are well delineated, the morphology of the sphincters is well delineated. If it has been operated previously, then what all has gone. And it has shown in literature that it has got the highest concordance with the clinical and the surgical findings. If you do an MRI and operate, it has shown that the further recurrences are reduced by around 75%. So in an abscess, as I said, drain the post-anal space completely, curate out both the cavity thoroughly. You can put in a drain on both the side or you can put in a set-on and come out. Similarly, in this patient, you can see there were two side of horseshoe arms over there, but the main culprit is in the center midline, which is drained completely and both the side tracts drained after that. This is a minimal invasive procedure for laser hybrid procedure. What we did is do a low fistulotomy there, which is tackle the primary pathology and remove the primary pathology over there, and the side tract, which are just the extension of the infection, you widen the external opening and curate out thoroughly, and followed by laser ablations of the tract. And that will leave a very small wound to drain, and this is what the end result was, and this patient healed in around 1.5 months' time. Another patient's horseshoe fistula, you can't see the opening in the hair, but when you feel there is an induration, when you do an MRI, you find that this is a tract. Apart from that, there is another tract going into the suprasphincteric space. Here you feel it. मला थोडा फास्ट फॉरवर्ड करायला सांगा ना. फास्ट फॉरवर्ड कसं करायचं ते ह्याच्यात होत नाही आहे. So what we do is complete excision, dividing the sphincter on one side, and not dividing the sphincter but removing the tract from the other side by coring. So this is the internal opening. You can see we have removed the pathology on one side entirely, and the other side the sphincter is preserved. You do not damage the sphincter at both sides. So this is the other side where you feel the induration, and you start dissecting the tract. You reach the sphincter complex and you make a hole in the sphincter complex and deliver the tract out from there. You do not divide the sphincter complex on this side. So that hole can be closed at the end of the surgery, and this is how it ultimately works. And you deliver on one side, remove it, and do the primary sphincter repair on the side where you have divided the sphincter, and close the hole in the sphincter which you have created while coring out the tract on the other side. So mere sight of a horseshoe fistula should not scare you. Only thing is, just be aware of how much you can divide and what all you should preserve, and if you have divided, how to repair. That is the message trying to give over here. This is closure of the hole which was created. That is the repair of the sphincter. This is the diagrammatic representation. You can see another horseshoe tract with multiple tracts up and down both. And in the clinical picture, there is a recurrent fistula, external opening, there is another opening down there. And this is what we did, completely removed the whole tract below the pulvoractalis and did a laser ablation of the tract above. Similarly, this patient, horseshoe fistula on the other side extending to both supralevator space. This is the clinically what it looks like. This is what we did, remove the tract on one side till the opposite side, in between the sphincters, and the supralevator portions were curated and ablated with a laser, and finally repair the sphincter, and this is what the picture looks like. So in a supralevator, you have an option of either doing a lift, waft, you can do a filac, you can do an advancement flap, and if you find nothing works in your patients, then you can do a fistulectomy with PSR, which has got a very high healing rate. So to conclude, it's a complex fistula with sphincter involvement on both sides, eliminates the primary focus, that is the anal gland, which is the most important thing, and the tracts, which are the extension of the infection. Adequately drain both the side, preserve the sphincter, and that should improve the result. Thank you for your patience hearing.
Thank you, Dr. Agarwal, sir, for a very crisp and precise presentation. Now, may I call upon Dr. Kiran Shah, sir, a senior proctologist from Mumbai, to talk on distant internal opening.
Good afternoon, chairpersons and the delegates. At the outside, let me thank the organizers for giving me opportunity to present this topic of today's. Next, may I enter करने का? Sir, next yeah. अच्छा वही okay. Now the topic of my discussion is about the distant external opening. Now you can see in this slide there are two, one on the left and one on the right. On the left side is showing that the external opening is on the right and the left of the anal verge, and the another fistula where you can see on the other side where the external opening is more than 2 to 3 inches from the anal verge. Such are the cases where we can call it they have a distant external opening. Now, how to manage these cases? There are various options that are available. You can do either coring, you can do excision with primary sphincter repair, you can do it a lift or a slough fistulectomy, you can do a waft fistulectomy, or distal laser proximal excision and ligation fistulectomy. It all depends upon all the surgeons, whichever procedure is convenient for them, he or she can do it and perform and give a best results. But I have a good experience about the coring fistulectomy. So today I'm going to talk to you about the coring fistulectomy. These are the ideal cases which I showed you in my earlier slides. Now, first of all, in the fistula surgery, what should be our objectives or the aims? The objective of surgical management of anal fistula is to eliminate the disease, prevent the recurrence, and preserve sphincter function as the most. Conventional classification treatment depends upon the level of the internal opening and the extent of the involvement of the external sphincter encompassed by the fistulous tract. If the opening is below the dentate line or the dentate line, we call it the low, and if it's above, we call it as the high. Now, coring fistulectomy involves the excision of the fistula tract from the external to the internal opening without sphincter cutting, which is very important. Yeah, earlier also I told you about this indication, but most important thing that it should be a chronic fibrous tract. In the acute cases, if the tract is not well formed, it's difficult to do coring procedure. Preparation, preoperative investigations, MRI, informed consent, preoperative fitness, preoperative antibiotics, that's a routine thing. Anesthesia, I prefer either spinal or epidural. In this, if the anterior fistula is there, I do it in the lithotomy position. But if the posterior or further, I would like to prefer it, do it in a prone position or a jackknife position. Now, what is the technique which I'll do it? First of all, I inject the methylene blue with a few drops of hydrogen peroxide. This is through the external opening. I take a scalp pen along with it. The dye is injected very slowly, and you can see the pus coming out from the internal opening. I inject local infiltration with saline adrenaline all around. Then elliptical incision is taken around the external opening. Deepen it, and the tract is dissected, circumference all around the course, heading it towards the internal opening. The external sphincter is cut, from the tract is removed from the external sphincter, going down, the incision taken along the internal opening, and then the whole tract is completely excised. Afterwards, then the tract is excised, the internal opening is closed with the 3-0 Vicryl sutures, where we fix the mucosa with the internal sphincter and the part of the external sphincter. And the external wound after the surgery is washed, and then a pack is pressed. This is a picture which at the same time I'm showing you what I'm doing it. The patient is in the jackknife position. There are two external openings, we can see it. Now, this is the right posterior transsphincteric fistula in NO. I've injected the methylene blue dye from the external openings. The two openings are there, and the dye has come out from the internal one. Now the incision is taken, as I told you, elliptical or an incision which surrounds both the external opening. The incision is different down, and you can see the internal part of the tract now. The pointer I will show you with the mark pointer. This is the pointer. Pointer के लिए किधर दबाने का? हाँ, ये वाला side. Okay. इधर है दबाने का ये ना. Now here in this tract, this was the external opening where I have just dissected, and then afterwards through the internal, I go and dissect out the remaining portion of it. Sorry. Oh, sorry. Then actually I remove both the complete tract right from the internal to the external. The whole tract is excised. This is the external wound. Here you can see it post-operatively after the 4 weeks. And this is the heel fistula in ANO. The patient is discharged with as usual antibiotics and everything. The procedure is technically simple. This is the advantage. Damage, defect, and the functional impairment is absolutely minimal. Less of tissue loss. The incidence of post-operative infection is very less, and ultimately incontinence is very minimal. But the disadvantage is that the delayed healing sometimes occurs and the recurrence as usual, which you know in all fistulas which can occur. There are certain publications, but I come down the conclusion of this thing. In conclusion, coring fistulectomy is a safe, effective procedure for distant external opening complex rectal fistula, provides a good functional results with minimal recurrence and less incontinence. Thank you very much.
Thank you, sir. Next, Professor Ashok Latha. He is talking on the multiple external opening. Sir.
श्री स्लाइड चाहिए, ये पॉइंटर है, वाइट मेरे पास पॉइंटर है और ये हाँ स्लाइड. Mr. Chairman, the organizers, I thank you for asking me to come here and talk. I really appreciate the wisdom of the organizers that for a fistula, they created so many talks with a fair bit of overlap. My previous speaker has talked a lot about the distant openings, but Niranjan asked me to talk on multiple external openings. Interesting, so there would be a bit of overlap. I would only talk not too many slides of description. I have many slides, but not descriptive. All these cases have been done under septa block. They're all my cases, and no videos would make a change. So multiple external openings. Unfortunately, the literature speaks very little about multiple openings and how should they be classified. If you look into various classifications, they don't talk of multiple openings. They would only say how the tract is going. So once you have multiple openings, it becomes a complex fistula by itself. So whether you have multiple external openings with a single internal opening or you have multiple infected tracts with multiple internal openings too. I believe there is somebody following me who would be talking about multiple internal openings. So let us come to many external openings like here, but they all have a single internal opening. Anterior multiple fistula opening only at one spot. Posterior fistula, you have seen these pictures many a time, opening at 6 o'clock position. Like here, you put the probes. I'm not going to go into the details of investigating and all that. They are all standard. I am the person who does trans-sphincteric or transperineal sonography. My MRI rate is less than 10%. We rely on the transperineal sonography because we have got a very dedicated person who has a lot of experience. So these are all managed on a transperineal sonography. You have multiple tracts on one side of the anal canal, which are simple, like the previous speaker said, that you can do a coring out fistulectomy, which I do as well. Again, there's an external opening here, external opening there, but perhaps same internal opening. 3 openings on one side with only one internal opening. One opening here, one opening there, again one internal opening. Like here, it goes, meets there, and there is the tract further into anal canal. 2 openings, again, simple opening, and they are all dealt with fistulectomy. So multiple infect tracts with multiple internal openings. Young fella, 12 years old, with 3 fistula opening separately into the anal canal. 3 different internal openings as well. External opening on either side with 2 different internal openings. 1, 2, 3, all opening differently into the anal canal. Now these are reasonably complex fistulas. Same here. So as I said, they are always complex fistula, and management hence is challenging. Now I'm going to be talking about ceton, and my ceton application is not draining, not cutting, but it is strangulating ceton because I don't change it. I apply it and then I cut the sphincter between 1 week to 3 weeks, depending on the bulk of the sphincter that I cut using a cutting ceton, a strangulating ceton. So it is challenging. How I do it and why. Fistulotomy with marsupialization. If the fistula are both going into the same direction, you do a fistulotomy and a good marsupialization. The tract is still there. Fistulotomy with a strangulating seton. 2 fistula on the posterior side, posterior horseshoe. We've done a fistulotomy and 2 strangulating seton. By strangulating seton, I mean I use a number 1 nylon and really tie it so tight that it strangulates the sphincter. This is the finished product. This is after we have removed both the seton by cutting the sphincter on day 10. And this is the end result. An absolutely clean, linear scars and a good sphincter, no incontinence. So I'd like to talk on the art of strangulating seton. Don't for God's sake put a seton on the skin, and that is where the pain occurs. Seton is there to cut the sphincter. So don't put it on the skin. This is bad seton. These are good seton. You put them. On day 10, you cut them using a knife, because you should be able to get a complete ring. That shows that you cut the sphincter. And you go and do a sonography, say after a month, and you'd find 2 linear cuts bridged by fibrosis and holding the sphincter together. So I feel the incontinence is more of a myth than a reality. I do it almost every day. Fistulectomy with coring out, all the 3, cored them out. Various, I don't want to go into the details of these. These are all fistulectomies. We remove them, close them. You can combine fistulectomy and fistulotomy, which Dr. Niranjan have also shown. We do a fistulectomy on one side and a fistulotomy on the other side, and the results are as good. So I wish to thank you very much. My concluding slide only says that even if when you have multiple opening, it's always a complex fistula. You should be able to deal with that with any good fistula technique that you wish to do. As minimum a damage to sphincter as you can. The results are going to be good. Thank you very much.
Thank you, sir. May I call upon Dr. Ajit Kukrija, multiple internal openings. He is talking on multiple internal openings.
There was a folder.
Yes, right. इसमें लीजिए pointer है.
ये pointer है.
Yes, right.
A very good afternoon. I bring greetings from Ratandeep and Meringo Sims Hospital. A word of gratitude for the organizers, my friend Pradeep Sharma and Kamal Gupta for allowing me to use their images and videos. I'll be speaking on multiple internal openings. How do I manage? Throughout the day, most of the things that I wanted to cover have been covered. As Professor Ladha said, okay, there has been a lot of overlapping. So I would just summarize what has been talked in the morning and brief you with what you might listen in the coming lectures. As you all know, fistula has a very long history and has been nagging the patient and the treating surgeon both for years and years together, and yet a foolproof treatment, a gold standard to be defined. The diverse anatomy and proximity of the fistula proximity to the sphincters require accurate preoperative diagnosis to avoid recurrence and fecal incontinence. Now, most of the times, preoperative diagnosis can be reached through clinical examination and ultrasound or clinical examination and MRI. But yet, on-table, unexpected findings can be encountered which can make the surgical decisions difficult. As Professor Ladha said, the simple and complex fistula, multiple internal openings also should be taken under the complex fistula when it comes to managing the fistula. Usually, when we want to learn how to manage a fistula, it all starts from history taking to clinical examination, investigations, medical and surgical treatment. The following slides will cover one by one the situations where multiple internal openings can be found in a patient of fistula in ano. How would a patient come to you when you would suspect there are multiple internal openings? If there is a history of previous surgery, altered bowel habits, symptoms, signs of irritable bowel disease, you have a colonoscopy report or a MRI suggestive of inflammatory bowel disease. These are the situations when you would doubt there would be multiple internal openings. These are the risk factors with multiple internal opening as I enumerated in the previous slide: trauma to the anal area, infections, previously drained abscesses, Crohn's disease, or radiation to the anal area. This is the first situation where you would find multiple internal openings, the synchronous fistulae. Usually synchronous fistula is a fistula that has two different tracts, a separate internal opening and a separate external opening. What needs to be differentiated here is a branching fistula. And most of the times treating synchronous fistula is not a difficult problem. I'll show you in a video that follows. But if there are any doubts about the integrity of the anal canal or the anatomy, it should be managed in two phases. This is an image showing two openings, one anteriorly and one posteriorly, managed by two different procedures. The anterior one is managed by coring and laser ablation of the tract, and the distal one with a fistulotomy. As Professor Ladha also said, you can perform a fistulotomy and a fistulectomy simultaneously in one patient. The tract is cored out with a fixation. This video is courtesy Dr. Kamal Gupta. The posterior one, a fistulotomy is done. Another situation where you would find multiple opening would be iatrogenic fistula. The red flag here is the internal opening away from the regular situation of the dentate line. Managing, you can use any procedure that you are good at. These are few images of Crohn's abscesses managed by Seaton, images courtesy Dr. Pradeep Sharma. I'll summarize a management of Crohn's fistulae with multiple internal opening, from diagnosing to medical and surgical management. This is one slide which gives you everything. Another situation where you would find multiple openings would be tuberculous fistulae in ano. Tuberculous fistula usually seldomly diagnosed preoperatively. What should give you a red flag is multiple fistula, recurrent fistulae, or presence of concomitant pulmonary tuberculosis or inguinal lymphadenopathy. One point that I would like to say, I'll take just a minute, Chairman, sir. The detection of tuberculous the bacilli is more precise with PCR when you compare it with histopathology and gene expert. And again, PCR has higher detection rates in pus than in tissue. This is another situation where you would find multiple internal openings. In malignancy, mucinous adenocarcinoma, the only thing that you need to differentiate is if it is a fistula arising in malignancy or a malignancy arising in fistula. Treat accordingly. Summary of all the situations that can be handled in this one. This unfortunately,
so the slide is blanked out because
sorry.
of the time issue, sir. If you can just sum up with two lines.
A big thank you to all of you for giving me this opportunity to be present with you. And any questions?
So we will be taking the questions after all the speakers are done with.
Thank you.
We will be calling you on the stage again, sir. Thank you so much for your talk. A very different presentation, I must say. May I call upon Dr. Pradeep Sharma, sir, and he will be talking on incontinent recurrent patient.
ये तो नहीं चल रहा है, नहीं चल रहा, ओके चल। Chairman sir, good afternoon ladies and gentlemen. I'm going to talk on recurrence and incontinence. Since the morning we have had multiple presentation, and most of these presentation were hovering around two drastic complications of fistula surgery. That is, one is recurrence and second is incontinence. Incontinence much worse than recurrence. So in some patients, they may not only be having a recurrence or an incontinence, but sometimes even both. So whenever you see one complication, try to look for the other also. Now before I start my deliberation, let me clear some definition. What is meant by persistent anal fistula? When there is failure of healing for at least 6 months after surgery, it's called as persistent anal fistula. Recurrent fistula means a fistula which occurs within 1 year of surgery, and a de novo fistula means any fistula that occurs after complete healing after a period of 1 year. Anywhere from 7% to 50% of fistulas recur depending on how complex they are. What are the risk factors? Because we know that prevention is much better than cure. So we have to look at what are the risk factors for the recurrence or for the incontinence and take adequate precaution to avoid that. So just like any other simple classification, we have a classification over here: pre-op, intra-op, post-op. So what are the pre-op factors? If you lack in understanding of the anatomy, we have seen since morning how to understand the anatomy of the tract, how to know whether it's simple or complex fistula. Intraoperative factors, then we have inadequate post-operative care, or what are post-operative factors, and associated comorbidities. So let us see them one by one. So for pre-operative factors, we have to know where is the external opening, where is the internal opening. But then fistula never behave like geometry, that you cannot connect the internal opening and the external opening, and that it's not a straight line. It is a line which is defined by the resistance which is going to be given by the tissue to the infective process. So even for the given same external internal opening, you might have a totally different fistula in two patients. And this also is governed by the Goodsall's rule, Park's classification, which we have seen.
If your fistula is complex fistula, there is a high rate of recurrence, nearly 40% of them would recur. So all the fistulas that are extrasphincteric, intrasphincteric with high IO or extend into the pelvis, intersphincteric without external opening or external opening far away from the anal canal, horseshoe fistula, they are all very likely to recur. So you have to take all the utmost precaution to prevent a recurrence. Per rectal examination is very, very important, so is endoscopy. Now, failure to identify the internal opening. We have seen in the morning how to identify internal opening, but that's not possible in all the patients. We have seen various techniques of it, and in spite of all those techniques present, sometimes we do fail to locate the internal opening. And if you fail to locate the internal opening, there is a chance of recurrence of up to 30%. Okay, so locating that is very, very important, and that makes imaging of a fistula, supposedly a complex fistula, much more pertinent. And there is I have an unwritten rule or an unwritten surgical dictum is that I consider every fistula as supposedly complex unless until proved to be otherwise. Then there are intraoperative factors, try to locate the internal opening, try to locate the tract, all known methods which we have already seen. If you fail to tackle the tract, there is 20% chance of recurrence, but if you fail to tackle the crypt, which is the most important source of the sepsis, there is 80% chance of recurrence. This is something which we have to keep in mind. Missed secondary ramifications also lead to recurrence, and that is why preoperative imaging in the form of an transanal or transrectal, transperineal ultrasound or a MRI is very, very important. Appropriate surgical technique, if not used, can also lead to recurrence. Like if you see a lift surgery today, you find it very appealing. Don't try to apply lift to each and every fistula, because not every fistula is suitable for the lift technique. So you have to choose an appropriate surgical technique for the appropriate fistula. Remember, first surgery is the best surgery for fistula, and recurrence by itself is a risk factor by 2 to 3 times. Okay. Cosmesis is secondary to recurrence. Don't worry about cosmesis, worry about recurrence, because this is a covered part of the body. Postoperative factor is again very important, postoperative care, because perineal wound, mucosal wounds, they heal off much faster than the depth, and if you do not saucerize the wound adequately, and if there is a surface healing which occurs much faster than the healing in the depth, that can lead to recurrence. Good pain relief is very important, because unless until you give good pain relief, the patient will not allow you to clean, or patient will not clean that area very well. So good hygiene, washing, adequate drainage. Cetons, if they fall out early, should be replaced. So my dictum is that open wounds can be left to the patient and the family to be taken care of, but closed wounds should be taken care by the operating surgeon or one of his team. Comorbidities like diabetes, tuberculosis, CKD, etc., they also lead to recurrence. So these are all the risk factors mentioned. Coming just a few things about incontinence. Now, incontinence for a complex fistula can occur up to in 73%, more common with lay open fistulas. So lay open fistulotomy should not be done or should be avoided in complex fistulas, anterior fistula in female. And you have to keep in mind that sometimes these patients might be having a preoperative subclinical incontinence which may precipitate after a surgery, and especially if the patient is an old age patient. How to avoid incontinence? Already said by previous speaker, like various coring out procedures, sphincter saving procedures, stage set-on, primary reconstruction. Another thing is course of incontinence. Just 2 more slides. If a patient has incontinence after surgery, the incontinence may decrease with time if you give them some conservative line of treatment like Faraday stimulation or Kegel's exercises, because sphincters are known to recover from the surgical trauma, and over a period of time we know that fibrous tissue contracts, so the 2 ends of the sphincter may come together and might reduce the incontinence. But again, keep in mind that it will worsen as the age of the patient advances. So if once the patient crosses 5th decade and 6th decade, it may increase. Various investigation, I won't go in detail because of lack of time. What are the options for incontinence, high fiber diet, Kegel exercise, sacral nerve stimulation, bulking agent, anti-motility agent, anti-secretory agent, transanal irrigations and peristain plugs, graciloplasties, sphincteroplasties, MACE procedures, trauma. So all these options are there. So in conclusion, I would like to say that prevention of incontinence recurrence is very important, and it's always better than cure. Every fistula is supposed to be a potential assault on the sphincter, and every fistula should be assumed to be complex unless until proved to be otherwise. A good roadmap, like we use a GPS while traveling, a good roadmap in the form of MRI fistulography or ultrasound is essential.
We are running short of time, and there is no slides on this because they have
yeah, so that's why I'm just saying, just this is my last slide. And the Hippocrates oath says that the motto of surgery is primum non nocere, do no damage. So we have to keep that in mind. Ceton can be a bailout procedure, and if at all you are told to choose between the two, a recurrence is better than incontinence, because incontinence really affects the quality of life. Thank you very much.
Thank you, sir. I am sure it is an excellent deliberations from the senior faculties, and there will be a lot of questions. And I may request all the speakers to be in the dais so that they can ask the questions. And
we will need to have at least 5 or 8 minutes of question answer sessions, because none of the speakers had any chance to answer any questions. Do we have permission from the core organizing team, please? Yes. So 8 people, 8 minutes. I have 8 questions.
Next stop.
Can I request all the speakers to be on the dais, please? Chalo. Let us call it a day. Thank you, all the speakers. Yeah. Thank you.
Thank you, chairpersons. Excellent session. Before we start the next session, we'll take a 5 minutes to felicitate 2 very important people who are here present amongst us, and they need to be recognized. I request Dr. Subramaniam from Tirupati to please come up, and I request Niranjan and Dr. Parvesh Sheikh to felicitate them with a shawl and a shrifal. Thank you, sir. Now I request our own Dr. Samir Rege, who is the Honorary Secretary of the Maharashtra State ASI, to please come up on the dais. The young and dynamic, ever running, ever present, very hardworking person. He deserves all the best wishes that we can give him. Thank you, sir. Back to Ashwini.
Thank you. We'd like to go to the next session, which is on specific fistulae, and I'd like to call Dr. Rajendra Ganeriwal, Dr. Santosh Somani, and Dr. Rajesh Shukla, who are the chairpersons for the session.
Good afternoon all. This is a session on specific fistulas. May I invite Dr. Ketan Parekh to speak on management of fistula in children.
Pointer. This was slides?
May I start, Chairperson?
Please, sir.
Good afternoon, everybody. And at the outset, thanks a lot for having called me an outsider from your faculty for presenting my thoughts on fistula in children. So for the purpose of today's talk, we will be, of course, talking on a variety of anal fistulae. And being a pediatric surgeon, my main thing is still going to be the congenital anal fistulae also. When we are looking at the congenital anal fistulae, basically this comes under the ambit of anorectal malformations. And in most cases, there is a closed anal opening. So we have what we call a low variety fistulae, which are anocutaneous. You can see this. So these are right from the anus coming onto the skin. Then you have the next variety, which is intermediate variety, which actually is transsphincteric. It is transsphincteric, and usually they open into the bulb of the urethra. And then you have the next variety, what we call the high variety, and these are supralevator, what you would call it supralevator. And usually these are coming directly either into the prostatic urethra or into the bladder. Of course, as I said, in all these cases, there's a closed anal opening. This is just a small thing that, see, here we are seeing a closed anal opening and anocutaneous fistula, which is a very, very small opening over here. Over here, this entire fistulous tract is opening onto the scrotum. So these are both low varieties of fistulae. As compared to that, when we are looking at female patients, once again, you have the anocutaneous fistula. You have fistula opening into the vulva or fistula opening into the vestibule. These are the low varieties of fistulae. The next variety, as I said, the intermediate variety is that which is transsphincteric, and that is usually opening into the vestibule or may be opening into the lower part of the vagina. And then the third variety or the high variety is the rectovaginal, which is usually opening into the vagina somewhere here. This is what you will see clinically in these patients. Once again, as I said, a closed anal opening, an anocutaneous fistula. This is almost a vulval fistula. And here you have the fistula just at the vestibule here. And that is a vestibular fistula. Now, how are we going to manage these patients? If they are the low varieties, you obviously have to create a new anus because there is no anal opening. So you do an anoplasty at the location of the sphincter, and that is located by using a muscle stimulator. And the rest of the fistula tract is excised. I mean, you know how to do it, so I don't have to tell about that. The intermediate and the higher varieties will each require a colostomy, unless there's usually a large fistula which is opening and there is no obstruction, then you can wait for the colostomy. Otherwise, they will require a colostomy at birth. The intermediate variety, The intermediate variety is handled by a procedure called posterior sagittal anorectoplasty. I will just be talking about it very soon just now. And of course, followed by a closure of colostomy. As compared to that, a high variety or the supralevator ones, where the entire rectum is opening only into the bladder or onto the prostatic urethra, we do a lap-assisted anorectoplasty nowadays, as compared to we doing an open anorectoplasty earlier, transabdominal, but now we do a lap-assisted anorectoplasty. So this is what I was talking about, the posterior sagittal anorectoplasty. Put the patient in this particular position, and there's a midline incision which is taken. You go through the all the structures in the midline, open the sphincter in the midline, and then expose and then when you see this, you can see this particular thing, that how well you can see the rectum and the fistula over here. And that is a time when you can core out the fistula, you can disconnect the fistula well. You close the muscle in front of the rectum. You close the entire muscle in front of the rectum, mobilize the rectum behind and bring it to its expected position, and then bring it down. So this is what posterior sagittal anorectoplasty means. You reconstruct the sphincter, and it gives excellent results, especially in the intermediate varieties. And overall, now the long-term results are reasonably good. As compared to that, when we are looking at the high variety, this is the colon or just opening into the bladder itself, and we disconnect here and then we do the same procedure, bringing it down. The infective or the fistula in ano, I don't have to tell you much about it because this is what you people you are going to teach us, but it's relatively very much less common condition in children, mainly seen below the age of 1 year for some reason, possibly because of androgens. It's far more common in males. And there has also been a suggestion that there is some congenital crypts variations. 10 to 20% of the children with a perianal abscess are likely to develop a fistula, but it is known that if antibiotics have been given, the chances are much less. Multiple fistula also have been seen in some of these patients. And surgery, of course, is below 1 year, usually, or at least in infants, it's just a fistulotomy or a deroofing. But in case you see some of the worse varieties, then you will have to treat it like a fistulectomy, the way you are used to doing it in older patients. Then comes the traumatic fistula. And this is also known, while especially because in children, when you are doing a urethral procedure, the urethra is so delicate that we have seen situations where I can't show you the slide, where it has gone through into the rectum and a fistula has been created. And again, these will have to be tackled with colostomy and this thing. Again, road traffic accidents creating a recto-vaginal fistula or a recto-urethral fistula are also known. So these are also to be tackled in the same way. We do a colostomy first, and then we do a posterior sagittal anorectoplasty and repair it. Thank you very much.
Excellent, sir. Which investigation you are using to diagnose the children with fistula? Whether a MRI or rectal?
So at birth, we do what we call an invertogram, and we identify what is the level of the opening of the colon or the rectum, and on that basis we do it. We rarely resort to MRI, very, very rarely. Usually it's a dye study which we would do, because usually there is some communication with the bladder or the vagina, and we can do a dye study and do it.
Yeah. As you are a senior most pediatric surgeon, what are the incidences of this fistula in pediatric?
So incidence of?
Incidence of fistula.
Fistula in ano, you mean, that classical.
Yeah.
It's not common. It is definitely not common. But as I said, we do see them in small children and infants. And usually a fistulotomy works. In fact, usually even we try a little bit of a conservative treatment in some of the patients, and just conservative treatment also works occasionally. But otherwise, a fistulotomy is good enough in these patients. Thank you very much.
Sir.
Thank you.
I call upon next speaker, Dr. S. Rajapardhan. Rajapandheni.
Good evening, everybody. First of all, I thank Dr. Parvesh and Niranjan for inviting me for this wonderful scientific feast. I think so far we have been, from morning to evening, we have been seen. So now my topic is rectovaginal fistula. Mostly I'm going to concentrate on high rectovaginal fistula of trans-abdominal management. So these are the topics I'm going to cover because of lack of time. So please, now only you have to start 7 o'clock. Already 5 minutes you have gone. Start from the beginning. Then I have to put the last slide. So the definition is the epithelial line communication between the rectum and vagina. But usually I'm not going to talk about the anovaginal fistula. So there are types. What are the main etiology? You can see the obstetric trauma. and the IBD, particularly Crohn's disease in the female, more than 15% of the female with IBD will have a rectovaginal fistula, which is very difficult to treat. Another thing is anorectal suppurative disease. These are the two common etiology. Third is any pelvic surgery, probably for rectal surgery or pouch surgery or hysterectomies. And those who have already have neoadjuvant chemoradiotherapy. These are most of the common indication for etiology for the rectovaginal fistula, particularly mostly high and intermediate rectovaginal fistulas. Less common causes are the fecal impaction, which Rahate has told, shown in the morning. And main classification you should know by seeing the rectovaginal fistula, you have whether it is a high, intermediate or low. So low can be tackled with various procedures, whether it is a simple or complex. Yeah. Simple means very low fistula, very small, less than 5 mm. And if it is complex, large fistula like more than 2 centimeter, and it is high or in intermediate with associated factors like IBD or radiation therapy or radiation proctitis. Of course, symptoms, signs, I am not going to, everybody knows how to diagnose rectovaginal fistula. It's very, very easy. Actually, a gynecologic examination lithotomy will clearly show. You can do a vaginogram or MRI to know the size and length of the fistula and associated abnormalities. What is the surrounding tissues, how it is there, what are the very single track or multiple track. And of course, you have to do a sigmoid to make sure there is no any inflammatory bowel disease. And you have to do endorectal ultrasound to know whether the sphincter is normal or there is any defect in the sphincter, so that will tell your treatment management aspect. So the main thing is you have to, there should not be any infection. If there is any infection, they have to relieve the first infection by putting a ceton or IND, then diversion.
Sir, can you
then you wait.
Remain closer to the mic, sir. You are not audible to the audience.
Okay. So simple fistula due to obstetric trauma, you wait for at least 3 months so that the surrounding tissue will become normal, so that whatever you do, it will take before going for anything. And the failed repair, if it is recurrent, you just wait for another few months with a diversion. So what are the various management modalities? You have non-surgical and surgical. Of course, non-surgical we are not going to talk. Those who are with the IBD, particularly Crohn's disease, we have infliximab. And of course, stem cell therapy is there. Coming to the surgical aspect, the local repair, I think from morning they have been talk about the advancement plan. So you can have a various approach. One is the transanal approach, which is common. Then transvaginal approach for most of the gynecologists and the colorectal surgeons follow because it is easy to approach. And transperineal approach, if there is a sphincter damage, you go for a sphincteroplasty. So endorectal's advancement flap, it is similar to transvaginal or transanal approach. I think morning Dr. Rahate clearly shown, I am not going to detail in that. The transvaginal approach, same. And the sphincteroplasty, you can do a overlap sphincteroplasty or end-to-end sphincteroplasty if there is a sphincter damage along with the low anal fistula. And the tissue interposition, if there is a very large, low or intermediate, if there is a loss of tissue, then you may have to have intermediate flap, that is a Marshall flap or Grace-Lewis flap. So now coming to the management of the high rectovaginal fistula, usually trans-abdominal approach. So mostly trans-abdominal approach, nowadays we do laparoscopic approach. We have various technique is available depending upon the condition of the patient. If there is a post-surgery or post-operative injury, you can go for a resection, fistulectomy and resection anastomosis, or sometimes you may have with a malignancy or radiotherapy, you have the colon anastomosis or APR, or even excenteration. So just I am going to show one case history of a 43-year lady who underwent lab-assisted hysterectomy 1 year before, and she was developed a rectovaginal fistula. This is the vaginogram showing that, and MRI also shows the same thing. Is a high rectovaginal fistula, and this is the port position for that patient. This is the video clip. Yeah. So most of the time there will be like a frozen pelvis. So I have. Okay. So main thing is you have to do addusolysis, you have to identify the rectal stump, and you have to post hysterectomy, you have to identify the vault. The perineal surgeon or the gynecologist will help keeping a finger with the gauze piece inside the vaginal wall so that you can easily identify the separation of the tissues is very important. You have to delineate the first rectum, then the wall, then you have to delineate the fistulous tract. So that delineation is very important. So identifying the anatomy in the pelvis, the frozen pelvis is very important. You should not make more damage to the rectum because you want to preserve the rectum. Now you can see I am making an incision over the vault near the fistula tract. See, open the vault at the fistula tract, you can see the separate opening of the vaginal opening as well as the rectal opening separately. Then circumferentially you dissect without jeopardizing the blood supply to the rectum. That is important. So because we are not going to dissect, transect the rectum. So instead of that, only the fistula part we are going to delineate. So you can see the fistulous opening, very big fistulous openings there. Then you have to delineate the rectal opening. Okay. Okay, thank you. I think you can't see anything.
Yes.
Sorry?
The screen has gone blank, sir, because the time is over.
No, I started actually 3 minutes. Okay. Okay.
You can start, sir, please.
I'll so far go. Now you can see the separate opening in the. Okay. So now we have delineated the vault, the vaginal opening. So I'm just suturing the vault with the 20 PDS. So we can use V-lock also for suturing the vault. So once you suture the vault, then come to the rectal part. The diseased part of the rectum should be excised. That is the granulation tissue. Sorry?
Are you finished?
So you use interrupted 20 PDS because it will be very thick. Then after interrupted sutures, you just divert it. Okay, thank you.
Excellent presentation, sir. It's a very difficult topic to show through the laparoscopy surgery.
Yes.
How
Not,
to manage with laparoscopy.
3 minutes is not enough for rectovaginal fistula management.
Yes. Okay, thank you.
Can I ask a question? Yes, please. Yes. Saline with adrenal for what? For low anal fistula?
Low anal fistula. When you do anovaginal fistula or low rectovaginal fistula, for better identification, do you recommend the hydrodissection in form of 100 ml saline with adrenaline or like that?
No.
Is there any advantage of that?
I don't think so. Probably very thin, there is no absence of perineal body.
Yeah, that in those cases.
There is
yes,
no,
sir.
yeah. In that case, for to delineation of the muscle, lateral muscle, along with the external sphincter and the liberator, you can dissect, you can use saline irrigation, yes.
Okay.
Saline to dissect it,
Yes,
to between the skin and subcutaneous and the muscle. But
Right.
usually there will not be any skin, just there will be space.
Any limit that up to which you will do it from perineal region?
Yeah, that by
distance.
investigation, by examination, that is very important. So how the patient is presenting you.
Yes, sir.
The patient is once you go, examination itself full of motion is there, full of vagina, then you have to tackle the patient first diversion because otherwise it will not heal at all.
Okay.
So that will be horrible. It's very distressing for the patient. Even just cleaning and keeping every time will be there. Whatever you do, The another thing, important thing I have learned over the period is, so it is easy to tackle if the sphincter complex is normal, we tackle transvaginally, but invariably it will give way. Unless it is not diverted. If it's diverted, it will take. Otherwise, 100% it will give way, then you go for a second time. Second time you will be more cautious. So you will divert, then you do. Because the less intraluminal pressure is less if you go transvaginally. So instead of that, you put the patient in the prone position, you do transrectally, you do the same thing how you do transvaginally, then the result will be good without even diversion.
Yes, sir.
But I feel only for the low, I would say it's anovaginal fistula without diversion. If it is intermediate and high rectovaginal fistula, always you go for a trans-abdominal laparoscopic with the diversion.
Yes. Last question, because it is also my winter. Just a minute. So how deep do you go when you go from dissection, from lower down?
From lower down.
Lower down.
So
is there any landmark up to which you will go?
No landmark. I think morning Dr. Raheta clearly shows that is a flap you have to raise. Vascularized flap should be there. Once you close it, you should see the blood supply should be good. If it is very thin, then it will give way. Or sometimes there may be a hematoma formation, lateral got infected, it will give way.
Yes. Thank you.
Yes, thank you.
Thank you very much, sir. The next speaker is Dr. Prajesh Bhuta, and he'll be talking on Crohn's fistula.
Thank you very much, Dr. Niranjan, Dr. Parvez, for giving me a chance to speak today. So I'll be speaking on Crohn's fistula, which is quite a complex problem for the patient and sometimes very difficult to diagnose because they are not easy.
Sir, there is a suggestion from the audience.
Yeah.
Speaker, sir.
Yeah, bol.
There is a suggestion from the audience. They want to see the videos, means whatever things that are more important. Certain things are going on repeating. So if you can skip those things and put stress on the things that are going to be helpful to the audience.
This is what I want to talk is helpful to the audience, but there is no videos. Because Crohn's, I think videos are the least important. I think when and what to do is more important in Crohn's rather than actually seeing a video. So what is there is evidence based and what we should follow and not just some technique. Please. So perianal Crohn's, it's a disease in itself. If you look at the latest classification, actually you can separate Crohn's disease into perianal and the rest of Crohn's. So it's classified actually as a separate disease because the treatment is completely different. So I'm straight away going to go on to treatment of perianal Crohn's, which many times present to you with an abscess or as an infective source. And the most common thing what we do for everyone and the safest thing is to drain it and put a Ceton without thinking much, because most of these patients do not have a proper diagnosis made or they might not be under a proper treatment. And so the safest thing for anyone in peripheral setup as a general surgeon is to just drain the sepsis, as there is no muscle division and it gives you a chance for proper medical treatment. There is a problem with Ceton also because it may not give you complete relief. Quality of life may not be that good. There is reepithelialization. If you leave the Ceton for too long, then it forms like a tract which cannot close on its own. So, even if you give biologicals, it will still not close. So that timing of when to remove the Ceton with biologicals is important. And Ceton cannot take care of accompanying problems like strictures, etc. in Crohn's disease. So what do you do? As soon as you get a patient with Crohn's, first thing you have to make out is whether it's a complex fistula, whether it has associated problems like anal strictures, whether there is a rectovaginal fistula, and whether there is a pouch along with the patient which has already been made through which the fistula is coming. So all these are different type of fistulas which need to be ascertained before any type of treatment. And the most important thing for this patient is counseling. Because don't expect to cure the patient completely in Crohn's, that is not going to happen. You are trying to improve the quality of life of a patient and not cure a fistula as compared to your other fistulas which you are completely trying to eradicate. So first is counseling. Second is control of disease, which is to involve a medical person, for a gastroenterologist, for actual medical treatment for the Crohn's, which has to go simultaneously with the type of surgery we do. And if the patient is well controlled, we do something called as a sandwich therapy. One of the commonest procedures which we use is lift procedure, which is intersphincteric, which I'm sure we have discussed before, so I don't want to go into technical details, but the advantage is that there is no muscle cutting and it is relatively safe for a Crohn's patient despite a more than 50% higher recurrence rate. There is a big recurrence rate, but the advantage is that you have not done any harm to the patient. The next one which we use is an endoanal advancement flap. So we actually cut off this opening, bring the muscle down and suture the flap of muscle back. So again, advantage is that you have not cut a muscle, you are just pulling it down and suturing it. Again, success rate 50 to 60%, there is a 40% to more failure rate with this as well. So all these, although are treatments, none of them are absolutely gold standards or anything. Muscle flaps, somehow for rectovaginal or very complex fistulas, in Crohn's patients, muscle flaps have been shown to have the best success rates, where we not only put like a partition between the anal canal and the other organs, but add vascularity as well. So the commonest ones we use are gracilis muscle. So we take a muscle from the leg, you invert the entire muscle and put it between the rectum and the vagina. As the last speaker said, the breakage rate of rectovaginal fistulas is extremely high. So they not only need a partition between the two, they also need blood supply. This is what is called as an interposition gracilis graft. This is not a thing where we are creating a sphincter. A sphincter is where the tendon is turned over the muscle, where we are trying to create an artificial sphincter. That is completely different. Here you are putting a muscle in between just for blood supply and to create a partition between the rectum and vagina. Sometimes there is gross loss of skin because of multiple tracts. Then we have to not only use, we have to use a pedicle graft where we actually take a flap of the skin along with the gracilis and insert it there, and we fix the whole fistula according to that. You get strictures, you might need an anal advancement flap along with dilatation with the fistula, which will end up something like this. So you actually move the entire skin inside, remove the stricture and treat the fistula at the same time. So you require this procedure where there is a stricture along with a fistula in this patient. So the timing of surgery is very important, low risk, high risk, within 8 weeks of surgery and within 4 weeks. This is when you give biologicals. No proper treatment of Crohn's is done without the use of biological. Patient has to be on biological when you actually treat this patient. And I would like to mainly conclude by this one slide, which is the most important, how you divide with active rectal involvement and with no active rectal involvement of the disease. The treatment changes if the disease is actually active and if it is not. If it is not active, you have much more things which we can do for the patients. While if it is very active disease, sometimes you have to end up with a defunctioning stoma, along with that biologicals, and sometimes even a proctectomy. So to control the disease in Crohn's is most important. Quality of life of the patient is most important. Diversion can be considered in certain patients with Crohn's till you get a proper definitive treatment for the patients. There are newer modalities available now like stem cell grafts which are being used, but still in the experimental stage. And I would like to conclude that it's a complete decision making by gastroenterologists and surgeons together which will give you the best outcome for Crohn's. Thank you. Any questions? Oh, Pradeep.
Many of these patients of Crohn's are also on steroid along
Yeah.
with the biological. So do use of steroid have any problem with the wound healing?
Yeah,
in this?
generally when they go to biologicals, the best control they achieve is when they get off steroids. So these are the persons we generally take for surgery. We generally avoid patients with steroid. That means they are not being maintained. That's why when you are using steroid, if they go to biologicals, then ideally they should be getting off steroids and being on a combination of only biologicals or biologicals with azathioprine. Azathioprine to us is more acceptable than steroids.
Right. And second thing, if you are using biological, how many injections or how many courses you will?
Yeah, that's what I said. Within 4 weeks and 8 weeks, those are actually the time frame with a well-controlled and a not well-controlled person. So if they are not well-controlled, then we would go up to 8 weeks of biological before we attempt any surgery. Well, earliest is 4 and you leave just a 2-week gap and you restart biological again. That's it's called as a sandwich therapy. So your patient will be off only 1 or 2 doses of biologicals around your surgery time. Otherwise, the biologicals will be going on continuously.
Right. Yeah. Thank you.
Okay.
Excellent information regarding Crohn's disease. Next speaker is very eminent personality, Dr. Samir Rege. He will speak on tuberculous fistula.
Good evening, everyone. I have been given a topic which most surgeons don't relate to. The role of surgeons is only to confirm diagnosis. Possibly, it will be only chemotherapeutic agents would treat it. Extrapulmonary forms about 5% of tuberculosis. Perianal is most rare. It accounts to about 0.7%. It is either associated with abdominal organs, either because of direct extension or because of spread by lymphatics. The mechanisms being either hematogenous spread from the active pulmonary region, which has a reactivation at the perianal region later. Ingestion of bacilli in the sputum from active pulmonary focus. There can be direct spread from the adjacent organs or from the lymphatic spread from the infected local tissues. Presentations are usually either suppurations or fistulae. Patients can present with anal pain, fever, ulcer, cough. Anal strictures. Patients can even present with hemorrhagal thrombosis, and obviously many patients can have discharges as purulent. When would you suspect somebody having a tubercle abscess? Patients having minimal fever, minimal pain, coccyx involvement. If the external opening has bluish edges, you try and treat them and they come and recurrent again and again, and they are complex. So they have multiple openings, they have multiple discharges, and you cannot locate the internal opening at times. So they can have recurrent fistulae which are with multiple openings, constitutive symptoms as rise of temperature, anorexia, weight loss. Because they can have inguinal nodes, not possibly because of only tuberculosis, but superadded infections. Colonoscopy, X-ray chest and TB PCR culture is preferable to have confirmation, where histopathology is a must before you start on any antitubercular treatment. And for confirmation of diagnosis, you would require surgery. Surgical treatment is never offered to treat a tubercle abscess. Now, so if you are suspecting any patient with tubercle abscess, it's preferable you confirm with a gene expert with TB PCR, a tissue or TB PCR, and it's always preferable if you have a histopathology. Now, sensitivity of TB PCR from the pus is maximum, so if you can get the genome from there, it's more or less confirmatory. Now, usually for confirmation of diagnosis, you require, most probably you would not suspect with one fistula presenting, so a surgeon would try and do a fistulectomy. Now, most important when you do fistulectomy, always send the specimen at least for a histopathology to confirm it. So, because it may not be a tuberculosis, but until unless you send it for histopathology, you will never get a confirmation about it. If a patient comes recurrent, you have sent but not attend the histopathology, you can still do a revision fistulectomy under the local anesthesia, send it for histopathology. confirm the diagnosis and have patient on antituberculous treatment. These are some pictures where you can, again, I cannot show any videos because there are no videos for it. Now, most commonly when the patient with multiple discharging pus with constitutional symptoms, confirmation with of diagnosis and following, they are put on AKT. Usually they may have sometimes remnant tract. You can reconfirm whether the pathology persists, so do a repeat biopsy after completion of AKT. And if they persist without any kind of tuberculous infection, you can do a fistulectomy. Confirmation, if you are going to subject any patient after for recurrent fistulae for surgical, it's preferable to have a MRI which would show possibly some pictures like this. And the medical treatment would be antitubercular treatment. Now, most commonly the intensive phase would go for 5 to 7 months and a continuation phase which can extend for 15 to 24 months. So they may go for a long time, which is recommended for all extrapulmonary tuberculous manifestations, especially for perineal disease. Thank you.
One question.
Yes, sir.
Is there any role of empirical anticox where repeated this fistula?
Sir, right now we are in the world of evidence-based medicine. Previously, when we were residents, we possibly used to give empirical treatment. Nowadays, there is no role of empirical treatment because patients get subjected to this medical line of treatment and they develop some sort of side effect. And then later on it turns out to be Crohn's or something else, it's going to be disaster. Yes, so it's preferable always to have either histopathology or a PCR to confirm the diagnosis.
Okay, thank you, sir. Any questions from the audience?
Yes.
Yeah, just one comment, Samir.
Yes.
If I suspect a patient has tuberculous fistula, if a patient is cachectic, has multiple openings and bluish discoloration, etc., I will probably not go ahead with fistulectomy at that particular stage. I would probably do a biopsy, thorough scraping, send it for pathology, wait for the histopathological report and then decide about the further treatment. Because I think it would be little damaging doing a fistulectomy, attempting a heroic fistulectomy in a patient who has tuberculous fistula.
Your point is well taken, but this is only for multiple fistulas. When a fistula presents with a single opening, possibly a surgeon would do a fistulectomy, and the point I wanted to stress upon is please send for histopathology because it may turn out to be any pathology, so it's better to confirm and then only treat the basic pathology what we are dealing with. Thank you.
Thank you, Samir. Our next speaker is Dr. Asif Mehraj. He'll be talking on managing fistula in HIV patient.
First of all, thanks to Dr. Parvez and Dr. Niranjan sir for giving me the opportunity to speak here. So I've been given a topic which there is no direct surgical implication as such, but we see these patients routinely in our practice. So I'll be talking about how we manage these patients of HIV and AIDS, those who have fistula. So once we look at the overall incidence of HIV all over the world, it's almost 39 million patients are still having AIDS or HIV. And in India, it's the number is around 2.5 million. So as all of us know, HIV, it's an RNA retrovirus and it has a predilection for infecting the T lymphocytes of our body. And it's transmitted usually by the body fluids like blood, the semen and the saliva. And for a disease to manifest like what we call as AIDS, it takes around 5 to 10 years from the time it infects a person. So the problem with AIDS is like the decrease in the cellular immunity of our body, and it leads to various opportunistic infections in the form of malignancies like Kaposi sarcoma and lymphomas that can involve the perineum and that may present as a differential diagnosis to fistula. And there can be some other opportunistic infections like pneumocystis carinii and other infections. And these patients usually develop abscesses, and those perianal abscesses, and those abscesses can later on develop onto fistulas. So HIV staging, I'll not go into the detail, but yes, they are categorized as stage 0 to 4, and stage 3 onwards, it's dependent on the CD4 count. So once the CD4 count goes less than 200, we categorize them as AIDS. So once we look at the HIV and surgical part, so since the beginning of antiretroviral therapy, the surgical outcomes have improved. All the surgeries, not to talk about perianal surgeries only. But there are still patients who have advanced disease, the morbidity and mortality is high. And if we look at the overall, once a patient of HIV comes to us as a surgeon, so most of the times they present with anorectal pathologies. They're followed by other presentations. And among the anorectal pathologies, the most common, though there is some debate in the literature, so the most common is anal condylomas or the anal ulcers. And anal fistulas constitute roughly around 3 to 20% of the cases. So in AIDS patients, they have some proctological manifestations, and these proctological manifestations can be common to all the populations at large, like all the patients, all the normal population has. So hemorrhoids, fistulas, pruritus, and other things. But there are certain diseases that are specific to AIDS and which are specific to some high-risk behaviors, like anoreceptive intercourse in homosexual males. So they have higher incidence of sexually transmitted disease and proctitis, and there are high incidence of ulcerations as well. Then there are some illnesses that are particularly associated with AIDS, like anal ulcerations, opportunistic infections, and sarcomas. So it was a very difficult time to prepare this talk. Once I searched in the PubMed, there were only 51 studies, and they were not related to fistulas and AIDS directly. And we can also see here the incidence of publications are decreasing related to the subject. So there were a few case series. There was a Korean study wherein they have studied 20 fistulas, and 16 of them were intersphincteric fistulas, and 2 transsphincteric fistulas, and 4 transsphincteric fistulas. And the crux is that do minimum. Just fistulotomy for simple fistulas, and if there is a complex patient, a complex fistula, or a patient has advanced disease, do minimum possible. So in this series, they found that all the patients were discharged within 2 days, and there was no delayed wound healing, except for 2 patients, those who had a squamous cell carcinoma associated and hepatitis C infection concurrently. Another patient was managed by fibrin glue. There were only case reports. So from whatever literature, the handful of literature that we have regarding the fistula, what we can conclude is that the anatomy of anal fistulas in HIV patients is normal, is like any other fistulas. However, patients who have advanced disease, they have delayed wound healing, and minimum possible should be done. However, in patients who have otherwise normal counts and present to us as HIV only, they can undergo normal routine treatment. So CD4, HIV, viral loads, all these things need to be ascertained before. And one thing which is very important for us, once we take any patient for AIDS patient for surgery, we don't need to stop their ART. So we need to continue them on antiretroviral therapy. So there is no need for stopping any treatment. However, there are some drug interactions which we need to consider more for anesthesia colleagues, but still opioids and antibiotics, they have some minor interactions that we need to consider. So I'm just running through my slides. So just one last slide. So the risk of transmission, we are very afraid of getting HIV from our patients, but the risk is very, very low. It's almost 0.03% only. And the reverse risk, again, patients nowadays, they can ask, what is the status of my surgeon who is operating on me? What's his HIV status? So it's not compulsory. The risk is very, very, very low, and evidence says you don't need to get tested to prove to your patient that I am HIV negative. Even in some countries, like in West, most of the Western countries, it's not a routine to test for HIV before surgery. So to conclude, my take-home message will be, do minimum in patients who have only HIV infection, like early stages, do normal procedure. Patients who have advanced disease should undergo least sphincter saving procedures as well. And since there are no studies, there is a need for conducting a prospective study on this subject so that we have good evidence to favor our management protocols. Thank you very much.
Thank you, sir, for a nice lecture. This concludes the session. I hand over to the organizers for further session.
Thank you, chairpersons and speakers. We now go to the next session, which is on post-operative care. And I'd like to invite the chairpersons, Dr. Kishore Adhyantaya, Dr. Naresh Rao, and Dr. Govind Kodwani to do the honors, please.
हाँ चल जाएगा.
Hello. Greetings from the chairperson's desk. Friends, as you know, if any heroic surgery is done, मंजिल तब तक नहीं मिलती जब तक उसका मेंटेनेंस पोस्ट ऑप केयर प्रॉपर ना हो. और the post op care requires lot of efforts, patient awareness, and team efforts from the hospital staff also. That requires lot of मेहनत. और जैसे कि आप जानते हैं, मेहनत के बिना तक तो ताज नहीं मिलते, मेहनत के बिना तक तो ताज नहीं मिलते, ढूंढ ही लेते हैं मंजिल अपनी अंधेरों में भी, क्योंकि जुगनू किसी रोशनी के मोहताज नहीं होते. तो इस अंधेरे में भी एक जुगनू सी चमक लेकर आई वुड लाइक टू प्रेजेंट डॉक्टर नीतेश झंवर. नीतेश, all is yours.
Good evening. Proud privilege to be here. And since morning, we have seen various ways of doing fistulas, but we have not talked about what to do after you have done a wonderful job. Please understand, if you don't see your patients properly in post-operative period, then it is going to be a disaster, no matter however good surgery you have done. And at the outset, I would like to thank Niranjan sir, Parvesh sir, and Dr. Roy Patankar sir for keeping this program and put everything together about fistula. And that can, the fistula is one of the disease which is kind of God's way of humbling the surgeons. Because when you start doing fistula, then you know however good or great your surgeon you are, you may still end up in problem at some time. Now, so we are moving from this image of misunderstandings to some clarity, and definitely once you decide which procedure is best for your patient, please understand what kind of a post-op care your patient needs. The third question which is asked in your OPD is how much time it is going to take for the wound to heal. And this is one of the most important one, because your patient is having some different measure rather than what you are thinking. Patient wants early recovery, you are thinking in terms of weeks. Again, he has met some superheroes who have promised that, I don't need to see you in post-operative period, or there is no wound, so why you have to come back to me. But please understand, when we talk about fistula care, it is one of the strongest pillar in terms of giving you a recurrence-free healing after a fistula. And I don't want to overemphasize the fact, and this should come to you even before you start taking of these patients for surgery, The first and foremost thing is begin with the end in mind. Now we are operating in a high volume center, somebody else is going to take care of the wound, so you can't leave it on your assistant that, he will take care and I'll see after 4 weeks. You have to see keep the post-operative thing in mind. So if you are doing a fissulotomy, do a proper marsupialization. If you are making a big, opening or this thing in the ischiorectal fossa, then better to leave a drain. We saw Dr. Niranjan Agarwal sir showing in the morning that he has kept a corrugated drain. Here what I have done is I put in a Foley's, so that if you have made a cavity which is deep, then your assistant is going to find it very difficult to clean it, and patient will feel the same. So it is better to leave something inside where you can have a proper cleaning. Stool is one of the biggest enemy, and that does not need any kind of further emphasization on this. Just understand a little bit of wound healing. I'm looking at the watch, so I'll just keep it short. You have to look at two things. One is the inflammatory phase here, and other one is the proliferation. Now, this particular wound is in close proximity with anus, and there you don't have a proper blood supply. The stool is continuously or almost on a daily basis is soiling the wound, and that is why the inflammatory phase is prolonged. Rather than 6 days, it may last longer. The proliferation phase again will take time because these wounds are not properly perfused. So these are the various factors. We have discussed about this. I will not go in the detail. This is what we do in our center. We have a dedicated person who is taking care of the post-op wounds. So you can see on the left-hand side, we have kept a water jet, and there is a specialized proctoscope which goes inside easily without giving any kind of anesthesia. Please understand, on your right side, you are seeing a patient, how he is doing it at home by using a bidet. But the problem is that he won't be able to open the anal opening in the way your assistant or you can do it in your OPDs. Now, we keep it like a vaccination chart. In first week, you come on alternate days. Second week, you come every 2 days. And from third week onwards, we will decide whether you have to come once a week or twice a week. So this is one thing which should be followed. And these patients will require this kind of hand holding. You can't just leave them alone after doing the procedure, because when they do it at home, then this is the procedure they are following. They sit in a hot sets bath. Irrigation and cleaning is required, and then they can apply any of these ointments which you prefer in your practice, and they can put a sanitary napkin or this kind of adult diaper or whatever. But this is the routine they have to follow almost every day. But in between, again, they will need your supervision. You can't just leave them alone on their fate. Please ask questions about these things. If your patient has got a pain, fever, bleeding or excessive discharge which is coming in, if the patient reports this, then please see to this that you see this patient yourself as operating surgeon and not your assistant who is doing the dressing. Look for these local signs of induration, tenderness and skin discoloration. If you find any of these things, then don't hesitate in even going in again and doing a procedure. Debride, do it under local anesthesia or general anesthesia, whatever. They have to be put on antibiotics, and the supervised dressing is one of the things which is important. If the wound is not healing for a very long time, then look for the rare causes of fistula like Crohn's or tuberculosis. Don't hesitate in doing a repeat biopsy or taking a second opinion on another biopsy as well. Now, there are few things which are very simple that can be treated in OPD. This is how the TCA application is being done to take care of the hypergranulation, which will affect the proliferation phase of the wound healing. Say after 3 weeks, you start seeing these wounds and then they stop healing. You can stimulate that. If there is a deep cavity, you can put in some kind of a alginate dressing inside, and that will provide a discharge-free wound. So the patient is dry most of the time, because by the end of 2 or 3 weeks, they start going to work, and every time if something is oozing out is not very comfortable for the patient. We need to understand that. Many times you feel that the wound has healed, but still there is some discharge which is coming from inside. And you saw, beautiful sphincteroplasty being done in the morning. But when we are taking these PDS sutures, they may not dissolve early, and they lose their color also over a period of time. So if you don't see properly inside, you won't be able to know that which particular stitch is troubling and which needs to be removed. This leads to something like a rectal pocket syndrome, where the stool particles may get entrapped, and they will cause some smoldering infection which will keep on causing some discharge, and you will label it as a non-healing or a recurrent fistula. Please do something like this, and then your job is done. To promote healing, there are some commercially available products which are available. We saw Chivtesa talking about collagen in the morning. You have hemoglobin spray. We also have the Amcoplast granule or Oxum superoxide to increase this. And the last thing, There have been some reports about using a negative pressure therapy or a vac dressing in these fistulas. They can not only heal the wound, they can also take care of the fistula. There are fistulas which were studied, cryptoglandular as well as Crohn's, and they have seen promising results. But these papers are as old as 2018 and 19. I don't know the current status, and I really don't have any experience of using this, but probably they may be promising in future. So you need to understand that whenever you are thinking about fistula healing, the time should be around 4 to 6 weeks. Begin with the end in mind, which I told you in the beginning. Hypergranulation is one of the things when you have to be a little cautious and take care by scooping or the chemical cauterization, which I show. And depending on where your patient stays, you just give advice what particular type of cleaning method they should resort to, and do repeat procedures if it is required. Like Rajiv Sharma sir said, that if you are doing a conservative procedure, then post-op care is even more important, because then there is not a large wound which a patient's relative can take care of. Thank you so much for your patient hearing. Thank you. Any questions? I think so.
Thank you, Nitish. We will move on to the next speaker, and that is Dr. Satish Dharap. He is going to speak on post-operative pain.
Good afternoon, all of you. At the outset, let me thank Dr. Parvez, Dr. Niranjan, Dr. Roy, and team Fistulacon 23 for giving me this opportunity. I'll be speaking on post-operative pain, and no doubt all of us have to face patients in the post-operative period who complain us about pain. Okay. Right. Oh, it is a highly subjective sensation, but this area of anal canal is extremely sensitive. Most of our patients get operated on ambulatory basis, and therefore, if they have too much post-operative pain, they have to be readmitted. But most important thing to remember is inappropriate pain may herald complication. So pain is defined as unpleasant sensory and emotional experience associated with actual or potential tissue damage. Actually, acute pain is protective in nature, and it's always there after any injury, but it is expected to resolve with healing. So roughly the time period is said to be about 3 months. So any post-operative pain should completely get resolved with maximum 3 months. After that, it turns out to be a chronic pain. And why it is important is that that means your acute pain or tissue damage or nerve sensitization has actually caused central sensitization. And therefore, sometimes you get hyperalgesia, spontaneous pains, or allodynia. So even with a breeze of air, patient may get severe pain. Pain following anorectal surgery is a cause for delayed discharge, readmissions. It's more common after hemorrhoidectomy, and chronic pain ranges from almost 2% to 30%. What are the causes? It could be residual disease itself, newly developing or persistent abscesses, newly developing or persistent fissure, particularly when you use your proctoscope, sometimes you can injure the anal mucosa, and there can be associated sphincter spasm. With your handling, the hemorrhoid may get thrombosed, and there could be, of course, infection. So how do you control this post-operative pain? The steps which have been described, you start right before surgery, what is called as preemptive analgesia. You have to follow proper surgical techniques, use of local infiltration and nerve block, SIDS path, topical applications, stool softener, and systemic therapy. So there has been one randomized control study about preemptive analgesia. That is, you start preoperative oral paracetamol and gabapentin followed by intravenous ketamine and dexamethasone before the incision. It showed good results, but the sample size was small, so it is not a standard practice. Obviously, as a surgeon, your surgical technique has to be meticulous. You can adopt certain policies, like if you have done a fistulotomy, maybe marsupialization, or if you have done a fistulectomy, maybe primary closure or at least partial closure of fistula so that raw area reduces. You can add sphincterotomy so spasm can be taken care of. You can use energy devices like ultrasonic scissors or laser to reduce the tissue damage and therefore pain. Or you can use minimally invasive approach. But it is not always possible and there is no clear benefit. Local blocks have been widely used and they have been effective. Lignocaine or bupivacaine along with epinephrine. I think most of those who do surgery under local anesthesia routinely use this. Perianal skin is infiltrated in a circumferential manner, after which submucosal injection of anesthetic is made circumferentially. Total volume is about 20 to 40 ml and a pudental nerve block may also be used. Local methylene blue has also been found to be effective, and I think Dr. Roy has publication on it. 2 ml of 1% methylene blue with 10 ml of 0.25% bupivacaine. It is injected subcutaneously and it is known to reduce need for analgesic for 4 days. Topical applications like glyceryl trinitrate, diltiazem, along with local anesthetic, it controls pain and relieves spasm. 7% sucralfate reduces pain and hastens healing. 10% metronidazole has also been used, but it is off-label use. SIDS path, all of us prescribe it. It actually gives a lot of satisfaction to the patient and it maintains local hygiene. But however, studies have shown that it doesn't actually cause significant pain relief. Stool softener reduce pain by preventing stretching of the anal sphincter, and therefore high fiber diet and laxatives are always prescribed. What is the systemic therapy? This is a WHO ladder for pain relief. So step 1 is use of non-opioids with or without adjuvant. If that doesn't control pain, you add weak opioid like tramadol, and then you need a strong opioid like buprenorphine or something like fentanyl if the pain is very severe. You can use adjuvants or co-analgesics like amitriptyline, nortriptyline, duloxetine and venlafaxine, which are serotonin norepinephrine reuptake inhibitors, or some anticonvulsants like gabapentin and pregabalin. But all these add to constipation and therefore stool softeners have to be given. Opioid have advantages, but they have disadvantages like sedation, respiratory depression, nausea, vomiting and habit formation. A new opioid which is called, is available, tapentadol. The novel route is nasal form, nasal spray form. So it has to be used in the form of like an inhaler, and patient has to inhale the spray. It has to actually be sprayed onto the lateral wall, and it is said that within 6 minutes it is absorbed by the olfactory nerves, and within 6 minutes it reaches circulation and gives immediate pain relief. So since this route is novel, it is known to cause reduced nausea, vomiting and other complications. So as compared to tramadol, it is a better analgesic. It has improved side effect profile, short half-life, no effect on serotonin reuptake mechanism. It has less side effects. So to summarize, post-operative pain after anal surgery has to be multimodality. As surgeons, we must follow meticulous surgical techniques. Various techniques I have described, but the take-home message is, if the pain is inappropriate, please look for the cause and treat the cause. Thank you very much.
Thank you, sir. We will not be taking any questions now. I'll call the next speaker.
Thank you.
Dr. Rajan Relika, who will speak on post-operative laxatives.
कुठलं आहे इथून जाईल ना Good evening, friends. At the outset, I would like to thank Team Fistulacon for giving me this opportunity. And thanks to Dr. Niranjan for prescribing tablet Barbolax, acting only for 7 minutes. So my talk is on post-operative laxatives. Now, post-operative laxatives are important or rather crucial in the post-operative period for the early wound healing and the early recovery. Our main aim is to prevent constipation because it has some hazards like hard stools, straining, pain, bleeding, impaction, and most importantly, stress on the suture line of the sphincter repair. So laxatives should be used judiciously to take care of the smooth and regular bowel motion. Now, only laxatives are not useful. We have to advise some lifestyle modifications, adequate fluid intake of 2 to 3 liters in a day, 25 to 30 grams of protein per day, fibers per day. Then avoidance of spices. Now, capsaicin present in the spices stimulate TRP1 receptors which are present all along the GI tract, right from the mouth to anal canal, and they are responsible for the pain and burning sensation. Sometimes this undigested capsaicin is directly delivered to the anal canal, and especially in the presence of open wounds, how burning pain will be there. Now, laxatives are classified mainly into 4 groups based on their mechanism of action. So we have got bulk laxatives like psyllium husk, osmotic laxatives like organic sugars. They are not absorbed from the GI tract like lactulose, lactitol or polyethylene glycol, and inorganic salts like magnesium. We have lubricant laxatives like liquid paraffin and stimulant which directly stimulate the colon, bisacodyl, sodium picosulfate and senna. Now, it is difficult to discuss each laxative individually, but I would like to make some salient points. Starting with the bulk laxative, psyllium fiber or the isabgol is the most commonly used. It is a soluble fiber, it is a prebiotic, easily available and useful in fiber deficient diet. Another practical use of isabgol husk is if there is any incontinence or postoperative diarrhea, this is useful as a bulking agent. Then comes the next commonly used laxative is a lactulose or lactitol. They are unabsorbed sugars. They have dual mode of action, osmotic as well as prebiotic, and they can be prescribed in diabetics. In fact, they are helpful in glycemic control to some extent. Flatulence and bloating are common side effects with this. Another interesting fact is that even if you stop lactitol, they have some carryover effect after the stoppage. Polyethylene glycol, again a safe laxative, can be co-prescribed with the stimulant laxative for constipation, also useful for preoperative bowel preparation, and most important use is a disimpaction of the impacted stools. Magnesium salts, be careful in prescribing in elderly patients, especially in renal impairment cases because of the risk of hypermagnesia. We have got commonly used lubricants like liquid paraffin, ensure the smooth bowel motion and prevent tension on the suture line. Stimulants, direct action on the colon, short time, they act within 6 to 12 hours and intended for short-term use, and a main use preoperatively for bowel emptying and postoperatively as a rescue laxatives if there is a constipation for 2 to 3 days. The last resort is either suppositories or enema. Now, with this information in our hand, there is a difficult to choose which laxative should be chosen under the given circumstances, because each laxative has got a potential side effect of diarrhea, and if not used in time, it can it can cause constipation. So diarrhea can be troublesome because of the frequent toilet visits, soiling of the dressing, change of dressing, and pain. And constipation can lead to impaction and tension on our suture line. So, how to decide? Are there any guidelines? No, there are no guidelines in the literature about the choice of laxative. But the two factors are important. One is surgeon, another one is patient. Surgeon will decide according to his procedure, whether it is a simple procedure or complex procedure involving the division of the sphincter or with the sphincter repair, and his personal preferences based on his experience. The patient factor you have to take into account: age, whether he is an elderly patient, he may be having subclinical incontinence, comorbidities, bowel habits, diet, then whether he is intolerant to any particular laxative, does he have any personal choice, or incontinence post-operatively. So, if it is a simple procedure, low fistulotomy, fistulectomy or fistulotomy, you can choose ordinary laxatives like lactulose. If there is a sphincter repair, better to go for stimulant laxative to avoid stress on the suture line. Pre-existing constipation, treat with osmotic laxative. Fiber deficient, prescribe fibers and use stimulant laxative as a rescue laxatives. Diarrhea can be controlled with bulking agents like isabgol husk. Fecal impaction is another disastrous complication. If you wait too much and spurious diarrhea, there is delayed diagnosis because of that. Furthermore, you give anti-motility drugs. So, here early diagnosis is important, and polyethylene glycol can be used for disinfection. So friends, there are no guidelines, but what I suggest you, follow the pain principle. P for the procedure based, E on your experience, and the need based, N for need. What is the procedure done and what is the post-operative setting. Dose and frequency should be adjusted to prevent either constipation or diarrhea, and fecal impaction should be avoided, and judicious use should be used so that post-operative recovery is smooth without any pain and early healing. Thank you very much for your patient hearing.
Thank you, Dr. Satish. As we are running little late of time, so no questions will be carrying. Thank you so much.
We now move on to the first oration of the Colorectal Foundation Trust.
I'd like to invite the chairpersons, Dr. Sanjay Jain, Dr. Pratap Varute, and Dr. Roy Patankar.
Dr. Rajesh Yadav, please escort sir, and Dr. Roy Patankar, please escort Dr. Varute. Protocols. Dr. Niranjan Agarwal, please escort the orator to the chair. And now invite Dr. Niranjan Agarwal to read out the citation. ले भैया, थोड़ा सा अलग दिखे पढ़ना तो तेरा फोटो भी दिखेगा, छुप जाता है ना तो।
So, good evening, friends. Again, it is my proud privilege to read the citation for the presidential oration for none other than my own teacher, mentor, friend, brother, whatever you may call it. He has played all the roles in my life, Dr. Parvez Sheikh. So, Colorectal Foundation Trust, Mumbai, Fistulacon 2023, August 1928, the Leela, Mumbai, presidential oration. It reads, Dr. Parvez Abdur Rauf Sheikh graduated MBBS in 1985 from the JLN Medical College, Belgaum, and MS General Surgery in 1989 from the LTMG Medical College, Mumbai. He is a fellow of ACRSI. On starting his surgical practice, trained under his mentor Guru Dr. P.N. Joshi, who taught him art and science of fistula surgery, he has mastered the technique of fistulectomy with primary sphincter repair. His name is now synonymous with anal fistula and is well known for his high success rate when dealing with such fistulas both nationally as well as internationally. He has served as Treasurer, Secretary, President of ACRSI for almost a decade. During his tenure, he popularized the ACRSI nationally and brought ACRSI to the international forum. He initiated the practice guidelines, national and international traveling fellowship, and also joined the Journal of ACRSI. He was instrumental in organizing the Asia Pacific Federation of Coloproctology Conference in 2009, as well as the ISCRS International Conference in 2016 in India under the aegis of ACRSI. At present, he is the Vice Chairman of FACRSI Board and the editor of ACRSI Textbook of Colorectal Surgery. Associate Secretary, Treasurer, Honorary Secretary of the International College of Surgeons, Indian Sections, Governing Council Member of ASI, Vice President of the Euro-Asian Technological Associations, and Associate Secretary of International Society of University Colon and Rectal Surgeons are some of his prominent contributions. A teacher par excellence for many young surgeons, he has lectured and conducted multiple workshops across the country and abroad, and published many teaching videos and articles on proctology. Presently attached to Sefi Hospital, where he is a teacher for DNB and fellowship program in colorectal surgery under the MUHS. It is indeed a moment of great privilege and proud for the executives of the Colorectal Foundation Trust Mumbai to present to you Dr. Parvez Sheikh, our own president, to deliver the first presidential oration of Colorectal Foundation Trust at the prestigious conference Fistulacon 2023. Signed by myself, Dr. Niranjan Agarwal, Secretary of the Colorectal Foundation Trust, Dr. Kishore Adyantaya, Treasurer of the Colorectal Foundation Trust, and Dr. Shekhar Shuradkar, Dr. M.M. Begani, and Dr. M.G. Naryani, the other trustees of Colorectal Foundation Trust. Friend, Dr. Parvez Sheikh.
Thank you for the honor. It was indeed an humbling moment for me. I would like to thank all of you all for coming all the way here for this conference. It's really an honor and a privilege for us. So I'm beginning my talk of prevention and management of the continence, or rather incontinence and recurrence in anal fistula. Both these, incontinence and recurrence, are a dreaded complication, and most surgeons are afraid, or rather afraid to treat fistulas because of these two complications. As you know, recurrence and incontinence, it's like you have to maintain a balance. If you do any procedure, like a sphincter saving procedure, where you have very less continence, you're not cutting the sphincter, but you'll have more recurrence. And if you cut the sphincter, you have very low recurrence, but you can have a high degree of incontinence. So, what are the options available to us? The options about what surgery to do for fistula would actually depend on the type of fistula, which is high, low, supraelevator, transsphincteric, intersphincteric. Whether there is any distortion of the anatomy because of a previous surgery, which will make, say, example, you want to do a lift procedure, but because of a distortion, you cannot do a lift procedure, so it will depend on that. If there are any specific diseases like inflammatory bowel disease, if you have an inflammatory bowel disease, then you will not like to cut the sphincter, but rather use a ceton and then rely on medical treatment. And of course, lastly, and the most important is the experience of the surgeon. If a surgeon is comfortable with a particular procedure or has a good result with a particular procedure, then he or she will prefer to do that procedure. You know that fistulas have got fixed patterns of spread. They only spread this way. So you have the high intersphincteric, the high transsphincteric, the low transsphincteric, and the low intersphincteric. That is the only way it spreads. All the other spreads, you can go up here, supraelevator and all, but these are the basic spreads. If one knows the pathogenesis and how the spread takes place, one can prevent both recurrence and incontinence from taking place.
We all agree internationally that if it's a low fistula, it is the most or the best option is to just lay it open. Because we are well below the dentate line, there is hardly any risk of incontinence. The recurrence is very less. So fistulotomy is an ideal procedure, and this is accepted by all societies across the world that this is the best option. Of course, you have to make sure that the patient's sphincter has not been compromised in an earlier surgery, like an obstetric injury or something. So you would just lay it open, scoop it, and send it. So in this situation, both incontinence and recurrence are very less, and this is the ideal situation. The problem comes when you are doing a high fistula, the high transsphincteric and the high intersphincteric fistula. Both these fistulas are the ones where you have so many options available, and it's we don't have a gold standard in fistula surgery. Unlike, for example, gallbladder, we know that lap chole is a gold standard now. In fistula, we don't have a gold standard. So we have all these options available. Now you see that what is important to know is that the high intersphincteric does not cross the external sphincter. So whatever procedure you do, you should do it in the intersphincteric space and not cut the external sphincter or not go through the external sphincter. So long as you are in the intersphincteric space, you are safe. Also the anorectal ring, the high transsphincteric fistula is actually below the anorectal ring. So if you're cutting this, you're not really causing incontinence. You can have minor incontinence, but so long as the anorectal ring is intact, you are pretty safe. So what are the options, especially for this transsphincteric fistulas? You have the sphincter saving procedures like the lift, and you have lift with waft, you can use it with laser, or you can combine, now people are combining waft with laser. Draining setons are there, advancement flap we heard the plug, we heard now also stem cell is coming up in a big way, still experimental. So these are all the sphincter saving procedures. Among all this, I personally feel that the lift is a very good procedure, and all the other sphincter saving procedures are to be compared with the results of lift. The two systemic reviews which are published for lift showed success rate between 70 to 75%. So that is what the success rate of lift is. Of course, in individual hands, it can go up to 80% also. And people who are not so experienced, the results can be little less also. Lift also has limitations. For example, excessive scarring, fibrosis, inability to identify the internal opening. If you don't know where the internal opening is, you will not know where to take the incision. If there is no external opening, you will need to create one to curate the tract from externally. And it is not a very good technique for a high intersphincteric tract. It's good for a transsphincteric tract. People have also tried to, as I said, combine lift with waft. And this particular paper which was published showed that combining two procedures really did not increase the healing rate. The healing rate or the success rate was same as a lift. But it can, especially if you're using a laser, it can help in promoting the surgery as such. I'm not going to talk about laser because that's an entirely different thing. We already heard about it. What about a high fistula? Doing a sphincter cutting procedure in a high fistula. So we have heard about so many techniques since morning. We have heard about sphincter saving. They're all good, but you should know the limitations. The recurrence rates anywhere between 60 to 80%. Success rate, anywhere between 60 to 80%. But very low incontinence. Whereas a high fistula, if you're doing a sphincter cutting like a fistulotomy or a fistulectomy, you have very good success rate. This paper which was published, it was a systematic review of this procedure where you did a fistulectomy and a primary sphincter repair. And this systematic review showed the overall success rate was 93%, which is highest for any other procedure, more than 90%. And I think all of us who do fistulectomy with or without sphincter repair agree that the success rates are very high. And very importantly, the anorectal manometry parameters remain unchanged. So our fear of causing incontinence after cutting the sphincter, but if you suture it, the results are very good. You have a good success rate, you have a low incontinence, and the quality of life, which is the basic parameter, improved significantly. So the incontinence which was there minor was basically a very minor incontinence. Especially if you were to do a posterior fistula, you can have what is called as a keyhole deformity, and it causes post-defecation soiling. But it was really not, it was not really incontinence, and it can be easily solved by asking the patient to wash properly and keep the area clean. So they concluded the success rates were very high and the risk of postoperative fecal incontinence was low. So it would seem like an ideal technique, but again, there is no gold standard in fistula surgery. You see this lady, she has bilateral transsphincteric with a high intersphincteric. Now in this patient, I have basically excised the entire disease, and at the end, this is how it looks like. You can see that is the mucosa, that is the internal sphincter, that is the partially divided external sphincter, and that is the high intersphincteric space. So I have removed the intersphincteric tracts, bilateral tracts from there, and on the other side, I have just scored out the fistula without cutting the sphincter. So this is the result at the end. So even if you have a high intersphincteric tracts with transsphincteric, you can do this surgery. And you can see this result post-operatively, after reconstructing or whether suturing the sphincters. See, it is still quite tight. So you have a tight sphincter, and you can see, so it doesn't mean that if you're doing a fistulectomy with sphincter repair, you have to give an ugly scar. You can still give good cosmetic scar. This is after 3 weeks, and this is after 2 months. This was a young girl who was going to get married, and she was very happy, and subsequently she did get married. So this would seem like a very coming close to an ideal surgery, actually. You know that sphincter saving procedures have a success rate between 50 to 75. Sphincter cutting, of course, success rates are more than 90%. But if you do a sphincter cutting with a primary repair, you can still have the high success rate with a very low incontinence. So how do you balance that? You have to, you heard Dr. Pradeep Sharma talking in the morning, and you assess the extent and type of fistula clinically and radiologically. So when you are doing this, before you do the surgery, you have in your mind, you should know, okay, what surgery you are going to do. Sit down with the patient and discuss. I tell every patient of mine, I'm going to do this procedure. The accepted incontinence and recurrence rates are this internationally. What is my results? What are in my hands, what is the recurrence, what is the incontinence, and what to expect? And only after the patient is satisfied, we go ahead with that. You know that sphincter saving procedure, if you do, it heals faster. The morbidity is very less, other than the recurrence, of course. But a sphincter saving procedure, sphincter cutting procedure has a more morbidity, but a very low recurrence and a larger healing time also. But if you combine the both, as I said, it is a good procedure. Remember that the anorectal ring is very important. This anorectal ring is formed by the uppermost part of the external sphincter, internal sphincter, and the puborectalis muscle. All these three together form the anorectal ring. And that ring should never be divided. If you don't want to land up with incontinence, when you're doing the surgery, keep on palpating the anorectal ring, making sure that the anorectal ring is intact. The moment you feel that you're near the anorectal ring, you should stop there. If you know your anatomy well, if you know the pathogenesis well, I am able to do all surgeries without dividing the anorectal ring. And if by mistake you have divided the anorectal ring and you can't feel it anymore, please primarily suture it. Take PDA sutures and suture it. You will still manage to salvage the situation and have a good result. So what to do if the patient already comes to you with incontinence and existing fistula? So my surgery of choice is, if it's incontinence following division of a sphincter in an earlier surgery, say for example, even a cutting sit-on can cause incontinence, or somebody has divided the sphincter earlier, and patient has a fistula, I would go ahead and do a fistulectomy, expose the wound, mobilize the wound, and suture the sphincter primarily, thereby improving the continence. So not only you're doing a fistulectomy, but you're also improving the continence. If the sphincter has been damaged, say an anal dilatation was done, then of course it's very difficult to do. Then try to do a sphincter saving procedure, and you need to treat the incontinence like any other incontinence you need to treat. Sometimes you may also need to do a gracilis wraparound if things don't improve. So anal dilatation actually is a very large. Many people start the surgery by doing anal dilatation. Especially in fistula surgery, you should not do anal dilatation because you're already worried about incontinence. And doing anal dilatation at the beginning of the surgery is just going to increase that choice. You can see this young lady, somebody has done an anterior fistulotomy without suturing the sphincter. And you can see this, just if you stretch the skin, you can see the anal mucosa. So it's a wide open, this actually is for my surgery yesterday. And this is at the end of surgery. You can see that the anus is fairly tight. We have reconstructed the sphincter and just got the sphincter together. And now you see the anus is not open anymore. And so if you have a situation like this, you can do it at the same sitting. And you can actually improve the, so we are worried about incontinence, but if your patient has incontinence, you can actually do a fistulectomy, repair the sphincter and improve the continence. And I do this for many patients of mine. Even if the patient doesn't have incontinence, but if I feel if the sphincter is a bit lax, I try to tighten it in my next surgery. What are the causes of recurrence? Most important cause and the most what you call highest incidence or rather maximum causes because of a failure to identify the internal opening. For example, you have done an abscess. You have just drained the abscess, but you have not done the fistula. You don't know where the internal opening. Or you do a fistula surgery, you start dissecting and then you don't know where the internal opening is, or you fail to recognize the internal opening and you stop the surgery. It's very important that before the surgery, you should at least have an idea about where the internal opening is. Do an MRI. If you're not very sure, do an MRI. But the internal opening should be identified. It's always present. And we should, that the anal gland complex is below that. So try to excise that. And failure to identify the internal opening and failure to excise the anal gland complex can cause this recurrence. That's the number one cause for recurrence. Failure to tackle the higher tracts. And that's one of the common things I see. When the fistula is going high, especially the high intersphincteric, most of the surgeons stop there because it's going above the anorectal ring. You're scared of causing incontinence. So you would scoop something and leave it and pray and hope that the patient would heal up. Sometimes they do heal up, but they would not. So this is the second most important cause. We heard about the wound care today, very nicely told that Nitish told that improper wound care. You need to regularly follow up these patients, make sure that the wounds are healing from inside outwards. If the skin closes before the wound heals, and you may need to, it will be a sort of a recurrence where you need to open up the second time and just curate the wound. And the misdiagnosis like tuberculosis, Crohn's. So every tissue you excise has to go for a histopathology. It's very important. And also medico-legally important that anything you excise needs to go for a histology. I've seen patients where a simple small fistula, normal, not even multiple openings, I think just simple, that the report came out to be tuberculosis with caseation. I was surprised. The other day I did a case, normal fistula, everything was okay. The biopsy came out to be malignancy. Squamous cell carcinoma was seen in a small area, which was shocking to me because it was a low fistula. Luckily I had excised the whole thing, but so we don't know. So histopathology is very important. And what do you do for a recurrence? If you have a recurrence, the first thing you should know what caused the recurrence, and you should know what type of fistula this is. You do a proper imaging, proper examination, and as I said, have a roadmap ready in your mind. You should know what you're going to do. When I do my surgeries, I know exactly this is the fistula, this is what I'm going to do. I don't waste time, don't do unnecessary steps. But you need to know the anatomy and the pathogenesis well. If you know that, and of course your experience, you can do that. Discuss, as I said, discuss with the patient the likely results with your surgery. Do not hesitate to take help of an experienced colleague. Don't be shy or hesitant. We can either refer or you can call the senior surgeon, maybe do the surgery together. It's always better. And what surgery can you do? If you have done a sphincter saving procedure, you can do the same thing. Again, you can try to do it. But if you think if you have done once or twice or thrice, then I think it's to move on to a sphincter cutting procedure where the recurrence rate will be low. And if you have a patient like this with the external opening near the penis, or external opening at the thigh or calf, or a patient with a high intersphincteric supralevator fistula going up to the preperitoneal space, these cases, I would suggest that if you do not have much experience, you can straight away call an experienced colleague and do it. Don't try to manage together if you have never seen a case like this. That is a sure way of decreasing your recurrence rate. Because fistula, even in the best of hands, there's no surgeon who does not have a recurrence. Every surgeon has a recurrence, including me. So do not hesitate to call your colleague and to maybe do it together, especially in cases like this. So at the end, to conclude, each fistula is unique, and the management depends on many factors. What type of fistula it is, high, low, whether there are any associated abscesses, whether it's a recurrent fistula. If it's a recurrent fistula, you know that you need to do an MRI first, see how it is, and as I explained, be very frank and honest with your patient about the likely results. Whether patient has got an associated incontinence, and most important, experience of the treating surgeon. You know, Dr. Arun Rojana Sakul used to do lift. He says, if it recurs, I do a lift again, and if it recurs again, I'll do a lift still again. That's because he has that experience and the confidence in doing a lift. So it also depends on which procedure you're confident at doing. Ultimately, that will decide, besides the type of fistula, that will decide what option you will do. No single technique is perfect, as I said. We don't have a gold standard. Remember, recurrences is acceptable even by the patient, but incontinence is not acceptable. So please don't cause incontinence. If there's a choice between recurrence and incontinence, recurrence is a better option than doing incontinence, because this gross incontinence may not be acceptable. And I always tell in my lectures that we should protect our ass first and then the patient's ass. If the patient is going to sue you with the recurrence, you'll be in deep trouble, as much trouble as a patient has. Remember that when you do a fistulectomy or a sphincter cutting procedure, you can do it in every fistula. Okay, that's possible. Sphincter saving procedures, you have to choose. If you want to do a filac or you want to do a WAFT, you have to choose the right procedure. In very difficult, hard fibrosis and complex, it may not be possible to do that. But the successful surgeon is one who knows how to balance between recurrence and incontinence. And remember that improving the quality of life is the ultimate goal. Improving the quality of life of the patient, and of course your own life also, by seeing that the patient doesn't sue you, is the ultimate goal. Thank you very much.
Dr. Parvez, as always, has summed up the whole concept of this conference in his oration wonderfully well. I request Niranjan to please come up and join everybody else. Dr. Sanjay Jain, please felicitate Parvez with a shawl. Dr. Varute with the memento. Dr. Rai Patankar with the Shrifal, and Niranjan with the citation. लेके जा सामने, ले जा, ले जा, ले जा, ले जा, ले जा, एक-एक ले लो. Thank you, sirs. Now we move on to the next session. I'll call Dr. Hemant Patil to take over the proceedings. Thank you. Okay.
Yeah. Thank you, sir. We'll quickly move on to the next session. It's a panel discussion. Everybody wants success in life. So the panel discussion is reaching the pinnacle of surgical success. To moderate the session, I will call upon that man who is called as a powerhouse of energy, and he is the idol not only of me but many of in the audience. So none other than here is Dr. Roy Patankar, who will moderate the session. Thank you, sir. The panelist The panelist for the session is Dr. Palanavelu sir, Dr. Shivakant Mishra sir, Dr. Avinash Supe sir, Dr. Abhay Darvi sir, Dr. Shivkumar Uttare sir, and Dr. Ravi Wankhedkar. I welcome you all.
Good evening, ladies and gentlemen. This is going to be a very interactive, freewheeling discussion, and I expect all the panelists to be honest, to give upfront answers, speak non-politically from the bottom of your heart, preferably 99% the truth. So we'll start with Dr. Palanavelu, who many of us regard as a role model, and in laparoscopic surgery we have learned a lot of what we have known in laparoscopic surgery from sir. Sir, if I were to ask you to sum it in 2 minutes, what do you think is the key to your success as a laparoscopic surgeon?
Roy, thanks for making me the opener. This is something. And if I say the success, it is the need of the people is most important than looked at. If you look at when I was in the village, I looked at there is no medical personnel, medical treatment even for me or my family. So I decided to become a doctor to work for the people. Then subsequently when I became a MS, then MCH, then looked at the people, what are the problems they are suffering for which I have to do something more. So when I was doing MS, I thought the cancers are the plenty and esophagus and liver not attended properly, patient going. So I should become a GI surgeon for taking cancer. No MCH oncology, no MCH gastroenterology, so I had to train. So the cause of the public is most important, for which we have to become a doctor. If I become a doctor to earn money, wanted to be, then it's a different story. Then subsequently, that farmers and agriculture, where I am come from the class, so I have to make them to work faster, leaving the hospital. Otherwise, they are the masters, they are the workers, like my family. So
sir, if I may interrupt, this is why you did minimal access.
Yeah.
What do you think has been the contribution? Why do you have you become so successful? Not why you did minimal access surgery. Why do you think you are Dr. Palanavelu, the most successful minimal access surgeon?
It is a commitment. I want to give the best to the people. So we have to keep with the science. Whatever the existing, whatever the coming in, we have to foresee that. And prevention is more important, and then after calamity, or whatever that natural. See, we have to keep with advancement to give the best to the people, and the patient should become less morbid, higher quality. Since morning you are all discussing with the quality, that kind of things, we always keep an open mind to learn. So continuous learning is the way that you can offer the people the best quality.
Thank you, sir.
So that means.
Sir, I know you have had a very difficult early part of life, from plantation in Malaysia to coming back to MCH. I have interviewed you during COVID times, so I've read your autobiography. I know a lot about you, sir, which many people in the audience don't know. What do you think have been your failures in life? Honest answer.
Honest, you mean asking a professional failure or anything?
Anything, sir.
Yeah, I know failure, no? So, when you are coming from a background, you are nothing. We are climbing the step 1, 2, 3 like. I don't look at immediately Himalayas, I have to go and climb up. No. What I can, I moved a step by step. So when I'm moving a step by step, what I can, so I know failure. That's why I'm telling it's not just casually mentioning. Some of my colleagues who started laparoscopy said, I've done the gastrectomy first in Asia, I've done the esophagectomy, I've done the complex. They were coming from the top of the hill, but I am climbing from the top of the bottom of this hill, slowly, appendix, gallbladder. Like what I learn, I do the best. Next step, I learn what I can without compromising the quality of this. So I think, if you look at money, yes, many times I failed, because I never looked at money, how much it is. But professionally, if I can't do, I will not do that procedure. If I don't know the procedure, I will not do it whatever my other colleagues done or not. But I can do better, I will do it. It may be first in the world or maybe. That's why Complication surgery, yes, I will say many, but professionally today, I am the happiest person. And when he said autobiography, I just wanted to show this. It is going to be released next month in the name of Guts. Guts in the sense, it is the abdomen. Look at, it's also guts to do it. What I can, I will do it. And always never looked at beyond what I can't achieve it. I do what I can. That's why today I no failure in my life. And whatever I decide, want to teach, I teach you. Wanted to make it a charity, whatever I can. That's why within my purview, I did no failure.
Thank you, sir.
Yeah.
Abhay, Dr. Abhay Dalvi has been professor of surgery, he's been a mentor to me in surgery. He was lecturer when I was houseman, he's groomed me in ASI. Abhay, what has been your worst failure in life? Personally, professionally, surgically, honest answer.
Personal failure.
Personal, professional, you can tell us.
See,
there could be more than
I have
one.
been teacher, postgraduate teacher for many years. I have lost count of how many PGs. One thing I can tell you is I'm very proud that each of my PGs has passed MS exam at the first attempt. But that does not mean I'm successful. My failure is possibly not to train my people adequately surgically, because part of my leadership as a unit head, I had to learn laparoscopic surgery myself and could not train my people as well. Later on, when I got confident of doing laparoscopic cholecystectomy for that matter, then people have seen Dr. Samir Rege evolving. So partly failure was not to adequately train my people in open surgery because I was learning laparoscopy. But otherwise, overall, I think I am happy.
Abhay, have you ever cut a CBD in your life?
Cutter?
Have you ever divided a common bile duct in your life?
Yes, in open cholecystectomy.
I have done it, so I'm asking.
No, I'm telling you.
And how have you told the patient's relatives that?
Actually, I managed to, I'll tell you, it was even before laparoscopic surgery started. This was a sailor who had come with a huge scar on the abdomen, necrosectomy done somewhere in France, and cholecystectomy had to be done. I was young, maybe hot-blooded, wanted to finish that cholecystectomy fast and loop the bile duct, and I cut it. As soon as I cut the bile duct, I knew that I have made a mess. There was no T-tube, nothing was available, but I had not lost a segment of bile duct. I called for help. So, I don't know, many of you all may not know, but I called Nilesh doctor, who was an established hepatobiliary surgeon. So, he just put in a stent, took 3 or 4 sutures. We went out and told that this is what has happened, and patient may develop stricture, very unlikely because it was a clean cut, and stent will have to be removed later. I met that patient about 6 years later. I believe, who's that Lilavati surgeon?
Hitesh Mehta.
Hitesh removed the stent, and patient has not developed a stricture. But
Great.
yes, I have cut a common thread.
Thank you. I
Only
think
once.
there are only 2 kinds of surgeons in this world, those who have divided a CBD and those who will divide a CBD. So let's be honest, we'll all be there.
Right.
Yes, sir. Sir, maybe I can ask you the same.
Roy,
Yes, sir.
I can, if you was asking failure, because I never always want to be happy, I didn't mention the failure, but one important failure is the most, I think youngsters need to know. I'm failed in MCH, you know. That is very important, no?
Yeah.
But not because of me. That's why I never took it casual. There was some politics happened, and there was a misunderstanding between my teacher and me, gave me depression. I was undergoing treatment for 10 days in a neuro, all going through, finally neuro treated me. Hey, Palani, it is a depression, go ahead, take antidepressant, you'll be okay. It was all right. But that problem made me, and that year I did not do MCH, I failed. And something in this is a life I took it, but I never considered this a failure. That after that I became a strong, okay, I need not bother about anybody, let me do my conscious what I can. That made next year, next another 6 months pass. That's why I put a hand, you know, pointing finger top. That is a motto, that is to my conscience, I work with the truth. And when you work for the truth, then you can achieve anything. That's why I put it a cover photograph.
So it's an important message for the youngsters at the back. It's not how you fall, but how you get up that's important. A question for Supe sir. Sir, have you had an intraoperative death during a major surgery?
Yes, of course.
And how you handle that? How you told the patient?
See,
or the relative outside, not the patient. Patient is dead.
No, I understand that. So first thing you would like to put patient, not intraoperative death, but patient has deteriorated badly. We may not have declared it onto the table and taken him into an ICU. So you get that window of about few minutes or half an hour, 1 hour. So I think we have tried to always go and explain the patient, yes, this is something which has happened and patient is critical and we are trying to revive it, but we are not sure, we will try our best. I think this kind of things, like I remember we had even death for a very simple surgery, patient has gone into cardiac thing and died. But such a patient, you have to at least make all efforts, show that all the relatives there that you are concerned about it, and you have to take the patient to ICU and also then explain and then declare the death. So I have done that once. I think it has definitely happened, and patients dying, I think post-operatively suddenly, I think everybody has really faced.
So you worked in KM as head of GI surgery, then director of Hinduja Hospital, now you are at Zen and other places. How have you seen surgery evolving in the last 10 years after you left KM?
Sure. I think KM has been always on the top, a very high front, but it has its own problems also. Because of many surgeons, everybody trying differently, there has been always, I probably separate out much early, so I have my own niche department which does a work, but it has only one limit. It could have gone much higher. I was looking for a department where I would have a very successful liver transplant program, which I started, but I could not. I became dean, so I could not sustain that program. But it is still doing good complex work, but it could have done much better. On the other side, I think Abhay would talk much better on that, but I think the department has a tremendous potential, but probably we could have to put a lot of effort to do that.
So what would you say has been a failure in professional life for you, sir? I know you wanted to be Vice Chancellor of MUHS.
Yes.
You were interviewed, we all felt you become VC. I'm asking personal questions.
That was not the only failure. Later on I got so many offers of Vice Chancellor, but
Sure.
I did not take them. But
At that time when you were rejected, what were your feelings, sir? Although you are the best CV, clearly.
I felt bad, that's all. Because see, sometimes when you are, it's not failure, but politically you are not correct. Maybe let us put it that way. For posts like VCs and other things, you require political correction or connections, which I never had. So basically we are all academicians working for patients. So my patients were probably not, though I had many ministers and all patients, they did not help me to become Vice Chancellor.
I'll come to Mishra sir now.
अदृश्य शक्ती ह्यांच्याबरोबर नव्हती.
Then I'll ask him another question. Supe sir, do you believe in fate?
I told you, I think very clearly, I believe there are three kinds of people. One, who are having a blind faith, andha shraddha. There are some people who are ashraddha. They don't believe in anything at all. I am a sashraddha. I believe in some faith. I believe in my parents. I believe in my colleagues. I believe in good people. But I don't do blind faith. So I am in between, number 3.
Great. Mishra sir, you've really steered ASI back on. First of all, I must compliment him for bringing FNB colorectal. As Treasurer Secretary, we have tried for 10 years, but we were shot down by a person in MCI in those days, and it used to come to the final stage to get shot down. And he's one man who made an open saying, I'll get you it done, and he actually got FNB colorectal done in 6 months. I admire you for that, sir.
Thank you.
So you walk the talk. So you have brought ASI back on even keel. You spent 2 or 3 years spending a lot of time, money, energy, fighting cases. I know you went to New in Haryana. Many cases were filed against you in many courts. If you look back upon those 2 or 3 years, what lessons have you learned?
Thank you very much for inviting me. I think it was a big learning experience for me, and I think all the audience must know that I was never a part of ASI. Of course, I was a member of ASI, but I never attended any SECon till 2006. Partly because a decade I was out of the country, and once I came back, I was interested in only minimal access surgery, and I was attending all those workshops, conferences related to minimal access surgery, including Dr. Palarvelli's workshops every year. Then coming to SECON, in 2006, I was made secretary of the UP chapter by one of my guru and teacher. And then I attended first SECON in 2006 at Varanasi. And 2016, I became president of that organization in only 1 decade. And the reason was that once we are all busy professionals sitting over here, and we are not politicians, and we are either joining the association for betterment of knowledge, camaraderie, and so on and so forth. So once I started attending the SECONs, and I saw overall scenario. Of course, there were great leaders, but questioning the leader, if you are right, it is the perfect. In fact, you can question even your father, your teacher, if you have got certain issues, and you must satisfy yourself whether this thing can be done or repeated by all. So that was one thing, and that made me and brought to that stage, and that historical time, you can say, which changed the overall perception and history of ASI, was that I realized that once I am here, wasting my time or spending my time, I must contribute positively to the organization. There's nothing doing. And I was pretty sure and convinced about my approach, and that is how I could win over so many plethora of legal cases, legal battles, and also over all those politics. So I'm very happy that it has given the ASI that very renewed or rejuvenated form, and everything is now academics, friendship, camaraderie. So this was a great lesson for me, and it has changed my life also in a big way.
Sir, you mentioned friendship, camaraderie, but a lot of people in this audience believe that ASI also equates a lot of politics. Do you think ASI needs a course correction?
No, I think in every organization, is such a huge organization, is one of the largest, or would say second largest in the world, and they're all good, talented people who are the members. They are not just that kind of illiterate people. So everybody has got their own viewpoint, and they want to prove that. So I don't see there is now any kind of that thing which needs to be addressed or changed. So many things were there, and people have understood. And differences will be there, and they should be, I think, discussed, they should be sought, and naturally, the leaders must be questioned if they are doing anything wrong. So there is nothing wrong in having differences in the house.
Sir, you're saying something.
I think, see, in a large organization, there are bound to be differences, what you call as politics. What we should all remember is that we are working for a goal. I think we are working for, say, surgery, HPB, IHG, or fistula, whatever it is there. If we are able to deliver and bring better and better procedures, and we are able to improve the skills of people around here and you, along with good camaraderie and improving the patients, I think it's fair enough. I mean, politics will remain as it is, but it should not come into the growth of an organization.
Yes, sir.
Just one important point, I think everybody must know, is a death of a patient while operating. And that is something nobody wants. And that too, either on the OT table, or immediate post-operative, or within 24 hours for an elective case, which was not having any comorbidity. Everything was perfect. And that scenario, I think everybody must know how to handle that kind of situation. That will occur. One example I just want to share with all of you, about 10-12 years back, I am a hardcore general surgeon. I do everything right from all minimal access surgery, bariatric surgery, colorectal surgery, urology as well. And I'm very comfortable using retroperitoscopy and ureterolithotomy I did for a young patient, a very young patient, fit 28 years old man. And my list was over, and as per my habit, I will take a post-operative round. Patient was comfortable. and the attendants were outside the ICU and they said, Sahab, we want patient to be shifted in the AC room because it is little more hot outside. And as patient was totally comfortable, I advised them, patient was shifted, moving himself on the stretcher and went back. In the morning, patient asked for some diet or something, liquid diet, got up. Sister gave one injection, supposed to be ondansetron, IV, and as per sister's version, the patient had convulsions immediately and patient collapsed. And I was called, my house is about, say, 2-3 minutes drive, but the duty doctors and anesthetists, intensivists were there. They attended, and as you have to show that some patient was already dead, the tube was put and patient was shifted to ICU. Now, young patient has done, and all mother and other people are waiting. They are outside. Don't run away. If there is any such eventuality, that will make your case very worse. So face everything. And I said we have tried to save him. Something has gone wrong. I have taken that sample injection and this syringe, everything for I would say medical legal examination. And I have already informed the police and everybody, everything was done. And you will not believe, 4 hours I was sitting there with all this and nobody uttered a single word, everything, the fire, police came, everybody came. So the lesson is that whatever, if complications occur, please don't hide, don't run away. You have to face ultimately, and you should have that sympathy, empathy, everything for the patient. It is important lesson, and I think things could be managed very amicably. And I have been involved in various such incidences for our community and in the other hospitals. And if you treat or communicate well, so communication is the key. That non-technical skills should also be very, very good. Thank you.
I'm going to put this question to Dr. Uttare. Dr. Uttare is eminently suitable to answer this. He was president of the Maharashtra Medical Council, and he has been providing advice to many surgeons and doctors alike. 2 questions for you, Dr. Uttare. Suppose some young surgeon calls you and says that 12 hours after a ureteral lithotomy, injection was given, patient has died. How do I handle it? How would you answer him? What advice would you give him?
See, we have to basically, very practical aspect. We seniors, when we sit over here, we talk about deaths happening when we were juniors, we were young. That age was completely different. Let me be very, very frank. Today, the situation is completely different. And to some extent, I sympathize with my younger colleagues also, because they are in a different era. Hello?
Yeah, it's working, working, sir.
They are in a different era from what we were. So if a death has occurred, I agree with sir when he says that do not run away. That is the first mistake that we do. The problem comes is that we become so anxious, we are so scared that we walk off from that particular area and try to protect ourselves that way. Now here is where, and that is what we have been trying to do as an association, even in all my talks I tell them, here in these situations is where your colleagues are going to be your best support system, not your family, not your non-medical friends. It is your medical colleagues who are going to be there. And I always say that in that particular area, and this is a time where I think this is definitely the ideal time where all of us have to unite together to fight for each other. Fighting alone is, in today's era, is extremely difficult. So suppose if in my hand there is a death which has happened, even before I declare the death, if I can phone Abhay, and incidentally Abhay has been from first standard my classmate, so I can always call him. So calling Abhay to that area, I mean to that, during that situation over there, plus not only he, but 3-4 other areas. I'll give you a classical example. It has already happened in this. But of course, this has happened with a general practitioner friend of mine, where, as usual, an injection was given, patient collapsed. And nobody can do anything in those circumstances. He immediately called 4-5 friends of his. By that time,
Of course, the relatives came to know, huge mob outside. Luckily for him, some of the people in that mob who were quite aggressive, one of the friend doctors who came over there, he was their doctor. And slowly he could, bring the situation to at least not normal, but at least cool down the passions. See, everything that happens, and especially today, assaults which are happening is because of the passion that those relatives undergo. So here, that's why I tell them, gone are the days when we feel that our colleague who is practicing in our area is a competitor. Let him be your colleague in all sense, not only in the medical aspects, but even beyond medical. So form that group in your area. And please get into the, we have also, as far as IMA is concerned, we have prepared apps also, area-wise apps. SOS apps where we just, because there is no time to do anything, you can just put your alarm on that app, which goes to your at least 50, 60 colleagues, out of which at least 5, 6 turn up over there. And let me tell you, when even today, whatever happens, doctors are respected in society. Whatever you read, whatever is going on WhatsApp or anything. And when those people see that there are so many doctors who are standing over there and vouching for what has happened, I may not be able to explain to him completely why the patient died, but Abhay will definitely be able to explain, because that tension is not there in Abhay. Abhay has a clean and open mind to talk about it. So get together, and UTT is the best thing, which unfortunately maybe it is happening slowly, but not happening to the extent that we really want it to happen in our community.
Follow-up question, Dr. Uttari. Body was sent for post-mortem. Next day morning, you get a phone call from the coroner. Sahib, mere ko aake jara milna, aapse baat karna hai. How do you handle that?
Yeah, this happens very, very commonly. And this is where, again, I would say your association in that area. Now, I'm not talking about individual doctors. I'm talking about an association being behind you, supporting you, makes a huge difference. I'm practicing in Mahim. This commonly used to happen at one time in Dharavi, where there were such incidences which were happening off and on, where the doctors used to be individually called for whatever reason, and extortion used to take place. That is when our association decided that we will support all our doctors. See, maybe that doctor, something he must have done wrong, but that doesn't mean that he has to undergo all this. There are actual legal procedures which can happen against that doctor. But assault, number one, extortion, number two, especially by the local people, that is absolutely a no-no as far as the association is concerned. And here, if that, instead of he going alone to that person.
Dr. Uttari, a surgeon in my area, Chembur, has got a phone call and said, you come and meet me, otherwise after a lap cold death, I'm going to write the CBD was divided, portal vein is divided, hepatic artery is divided. And my word is final, because that's going to be in the PM report. The government hospital committee will take that into account. How would you face that?
Absolutely difficult position, I can agree to that, because let me tell you, the thing is that,
and this is a true story,
you don't come to know what report he writes, unfortunately.
No, his aide is threatening you.
No, he is threatening. No, the report, the final report written by him, obviously, you don't come to know as a doctor. This does happen, and for this you require a very, very strong legal backing also, which I think many of the organizations are doing, having medical legal, and this is what we were trying to do when now almost 10 years I've been in the council. I remember 10 years before, there used to be not even one medical legal lecture ever in a year in any organizations. But today I find in almost every organization, there is at least one or two medical legal this. So the problem is that those lectures teach us how to handle this thing. But then what you are talking about, where our own colleague over there gives a false report against you just because he is in a position of, to give that such a wrong report. I think that is a little difficult even for me to answer.
Or you need a political backup, like Subhe sir said.
Yeah.
And actually tell you, after this particular surgeon from Chembur met the coroner, a report of dengue-induced death was given, although it was a post-lap coli death on day 4. I won't give you a name. We'll move on, I think. I'll come to Dr. Wankhedkar. Now, Dr. Wankhedkar has been a very senior office bearer of IMA. He's treasurer of the World Medical Association. And his CV intriguingly says he's also a hands-on farmer. So I think he's an appropriate person to say, how do you de-stress yourself? You're a professor of surgery in Dhule Medical College and you have active practice. How do you de-stress yourself? You have a bad patient, you have a sick patient, you have post-op death. What is your way of de-stressing yourself?
Thank you, Roy Patankar, sir.
Not sir, sir. I'm junior to you.
You yourself gave this answer. Really, surgery, I've been practicing and teaching for last 35 years. And in a very small place. I am probably the only one of the esteemed panelists working in a very small town. A lot of stresses are there, not only surgical stresses, practice stresses, but as Supesh sir said, other people influencing our practice, non-medical people, especially local politicians. De-stress, farming, best thing. Farming means connecting with nature. I had the opportunity to develop a 35-acre barren land into agroforest. I have planted and grown more than 10,000 trees on that my. And let me tell you, like most of the successful doctors, I don't claim any income tax benefit on my farming income.
That's an important point. So your priorities are clear. Why you're doing this?
It is really very, very pleasurable, distressing to see that you plant a small sapling and then after 8-10 years, you eat those same fruits. See, farming is much better to have a sportsman's spirit other than sports also. I did not include, I am also the president of Basketball Association, I was also the state level player. In farming, we, especially living in urban areas or doctors, we have a very square life. In our hospital, even if 2 ampules go away or something goes away from the house, we are very worried. But in farming, everything is open. That is one thing. Second, cooperation with the neighboring farmer is of utmost importance. Third is, you develop a habit to take in failures. That is what I mean sportsman. We sow. The rains are unpredictable, the seeds are unpredictable, and of course, the cost which we get. I will tell you, I am doing farming for last 25 years now. It is a one-way ticket to put in money. But still every season that I can afford it, but all our 99% farmers are very hopeful. Farming makes you hopeful. That yes, maybe the next season I will get a good produce and my produce will get good cost.
So unfortunately in surgery you can't say my next Lapcol will do well. And you can't say the anesthetist was bad and the generic drugs I'm using were bad.
Very true. Again I was telling about practicing in small places. When they come to decide upon a surgery, at least 10 people will come and decide upon an amount. Usually that it is a package, everything included. And during the day of discharge, another 10 politicians will call you and say the same thing, that doctor, please take this so much amount in, we will get next patient who you can charge him more.
So how do you handle that?
Yeah.
Sahib, amchas manus hai, zara sambhalun gya. How do you manage that?
I don't manage it. Very conveniently, last 35 years, I have asked my wife to handle all the economics.
So I think Palli sir can say the same thing.
But she has developed a technique. When a politician calls, she says, okay, I will decrease 1,000 rupees, but you give 1,000 rupees. Everyone who calls, she asks 1,000 rupees. So then they don't call.
So the problem with city is, within the next 1 month, you will get 5 different RTI applications and complaints against you. Yes. You probably can do it in Dhule, but not in Mumbai. Sir?
I think the farming is something gives you a lot of knowledge, gaining confidence and up and down. It is, he says the climate season wise, your agriculture getting affected up and down. Not only that, even you grow well, if you want to sell your own vegetables or whatever, It is not in your hand. I remember many of the weekly market will be there. I used to carry vegetables, and that time if the buyer is not coming, even a 20 rupees basket, we have to sell 2 rupees, 3 rupees.
Even today, same thing happens.
Yeah, it is.
Except
it is
tomatoes.
Many days. So
Except tomatoes.
Everything,
tomatoes
see,
only now. Those
I
days,
will tell
tomatoes
you.
also problem, no?
I will tell you, Roy sir.
And I wanted to give you a relaxation, whatever you want to. This type of problems, you want to society not affect you. One is farming tension free, that is different, but everybody cannot do farming. It is, you may not have farm because my land which was available, land also gone to my brother. So I'm a landless man now. But every one of you, when you practice, 10% or 20% your life keep the society front end of you.
Yes.
How you can help the society? Keep camps, do it. And the Rotary Club, Lions Club, there are varieties. You call them, have a camp, free camp, be part of the society, create an image that you are for the people doing it. You cannot be free everything, but you have to charge. But same time, people should know, this is not a practitioner, he is also service provider. Every profession, police, everybody looks at doctors as a practitioner, not like service providers. We have to create an impression ourselves, do frequent camp, after which people comes, do free. What is going to help you? Even a private, you do it. Government service, no problem, put in a government hospital, had it done. By creating good image with the society, if any problem comes, their anchor will be much less. You will be always will be part of society. That is very, very important. One need not do world level quality of work. I'm the best. Even that best will not be respected unless until you go with the people.
So there's a counter view to this, sir. When you work with these politicians and do camps, they get all the publicity, and when you're in trouble, they won't stand by you.
Very
Even
true.
the politician takes it up.
Can I just add to what
Yes,
sir
sir.
has said?
No,
Yes, sir.
Sorry.
You call MLA, MP, whatever ministers locally, be with them, run a camp. Even those people also will be coming down and also provide support to you in case a problem is there. You do some free camps on their name. Don't hesitate doing it. Let them get a name, but they're close associated with this. People look at this guy is close to ministers, this guy is to MPs, and somewhere they will not just suddenly jump on you and make.
I
Yes,
just
sir.
wanted to add to what sir said, and Roy sir, I agree with you. Camps, okay, sir has said, but politicians in current scenario working in the association till the topmost level, they are of most useless people. And I say it with utter responsibility. Whenever incidents of violence occur, that MLA we have taken 10 camps, will not come to the help of my colleague, but he will phone the police inspector कि ये मेरा आदमी है, जरा देख लेना, छोड़ देना इसको. But what sir is saying is to connect with the society. Doctors traditionally, naturally are natural community leaders. And we need to connect with the society. You can do any sort of social activity. Sitting in ivory towers, gone are those days.
Mishra, sir.
No, just I think you have asked a very pertinent question about de-stressing. See, everyone, I think today's world, and I think it changes scenario doing the practice, they have got stress. And I can give you few tips, 2-3 tips, just to de-stress. And it is not from Google or anything. First thing, you need to remember in your life that you are not indispensable. You are not the only surgeon in the world that you have to perform every day, too much and all. So learn to say no and also take care of yourself. Pamper yourself. Take care of yourself. Nobody in the world will take care of yourself. Your health, your personality, your happiness, this is important. Even your family loves you, but responsibility to keep yourself happy and satisfied, and that lies on you. And also, I think we don't know this art of expressing gratitude. We love to criticize repeatedly, so learn to say thanks, even to your all surrounding. Your OT technician, to nurse, to driver, to cook. If you learn that, I'm telling you, you'll be happy. And make one-day program. From the beginning, in the morning, don't think about yesterday, that has gone. Tomorrow, you never know. Today, you just plan your day well, what you have to do and keep for yourself, for your health, for your exercise, for your happiness. And as our learned colleagues have said, that connecting to the society, everybody lives for himself, herself, or the family. But those who don't live for the society, nobody cares for them. And never retire yourself. Whether you have crossed that age 75 or so, keep contributing. Once you retire, once you become useless, even your family members will not respect you. So keep doing, keep yourself occupied. That is very important. And enjoy the wealth you have created. Don't leave it. Of course, it will be there for your next generation. But learn, people, all of us, we know how to earn more and more, and we are in competition. It's stress. Oh, somebody is doing 10 surgery or 20 surgery, and I have got 50 bedded, now I have to make 500 bedded, like that. Life, this rat, you have to be happy with what you have today. And I'm really very happy to be a surgeon. And that is, I'm going to talk about that later on. But believe me, even in the next life, I would like to be just like S.K. Mishra.
And
I
Shiva
don't
sir,
want anything else.
Shiva sir walks the talk. I can promise you he has done 1 hour of yoga today morning in Leela. Is that correct, sir? Yes. So we'll change topics, sir. I think we've discussed de-stressing long enough. Utture sir, this new NMC guidelines, this meeting is not going to be possible next year. No stalls outside. How are we going to handle it?
Yes, I think the new guidelines, let me be very frank, I was part and parcel of the National Medical Commission till last year.
We know who to blame then.
We discussed all these points. There were a lot of objections which I personally also raised. And let me tell you, if you had seen the original draft, I think, forget the next generation, we would have given up medicine. They were that bad. So a lot of things we could change, but there are a few things, at least 3 or 4 things which require to be rethought by the National Medical Commission, or at least tweak some of the words. See, what you have to understand today, the position of the people in the National Medical Commission also, majority of them are full-timers over there who are nominated by the government. People like us were part-time. We went through the state councils or as, university VCs. But we were part-time who we used to only attend the meetings. Whereas today, unlike in the past, you have those members who are sitting over there from 9 to 5 who are paid by the National Medical Commission and they are employees. Not only that, their whole position depends on what the government wants to do with them in future. They're only 4 years. They can do another 4 years depending on their senior sitting in the ministry. A lot of these things have come in because of the pure pressure from the government. Let me tell you, just give you an example. They came out with the generics problem, which all of us are fighting today. Not that we are against generics, and that is what has been my statement in even in the newspapers and all. We are not under generics, but our concern is that our FDA is not that strong as you see in the US or the UK, and therefore we are against the generics.
So one straight question. On Monday morning, are you going to write Dufalac or Lactulose?
Let me tell you, in some aspects I am a rebel. I will continue doing what I am doing as long as my mind tells me what I am doing is the right for my patient.
Fair enough. Thank you, sir. That is an honest answer. That's honest answer.
Let the NMC, and these are the same words.
I appreciate your honesty, sir.
These are the same words which I spoke even to those people who are sitting over there in powers. And they also told me, Doctor Sahab, why are you bothered? Abhi tak kiske against kuch complaint hua hai kya? I said, that is not the case. Once you put it down in black and white as a code of ethics,
level 1 and level 2 offense.
We are supposed to be. Generics was there, if you remember, in MCI Code of Ethics 2002. Okay. It was there in 2002, but there was no punishment over there. Today they have put the level 1, level 2. That means you are going to be punished. You are liable to be punished over there. So is India ready for generics? That is what we have to think about. And that is what I told them. You sit with the stakeholders. You sit with the stakeholders, discuss how to bring generics. We are also interested in bringing generics. So sit with the stakeholders. And if you see another point, all of you all must have noticed, suddenly in the Supreme Court, someone has gone with a PIL.
Yes.
And the Supreme Court has accepted it after rejecting it the first time.
And
Where they have
asked the
accepted
government,
it, and now they are going to ask the government why generics has not been brought. So, you know, this is a well thought plan.
Minefield.
And we are very aware.
Just to add what Shiv has said, most of you might not be knowing, I was the national president of IMA when we opposed the implementation of National Medical Commission. I did a Bharat Yatra, we had a big meeting of 25,000 doctors in Indraprastha Stadium and all that. Try to understand 2-3 things. National Medical Commission does not have our representatives. Previously in MCI, with all its shortcomings, at least it was a democratic body where RMPs, all doctors used to elect one, all universities, which were separate universities, there were people going there and we could approach. Today, they are not nominated, they are selected by the government. I mean, government can nominate Supe sir, but still he will have some independence. But if I select Shiv as a member, totally dependent on the government, it is controlled by bureaucrats. Absolutely no idea of what is happening at the ground level. Third thing, sir, let me just, in my flow, please.
Okay.
Sorry.
No problem.
Thirdly, if you'll see, this is a purely, what you say, लोकांना खुश करायचा निर्णय.
Appeasement of the electorate.
Appeasement for the people without, it is most irrational, quixotic, impractical decision that you will implement generic medicine. Fourth main factor is the pressure and the huge influence the pharma industry has. I'll just give you 2 short examples. Many of you don't know. In March, 31st March, government allowed a 10% increase across the board non-controlled price drugs for all the drugs, while the inflation is hardly 5% claimed. Second, 15 days back, they modified the Drugs and Cosmetic Acts. Previously, there was imprisonment if substandard drugs or spurious drugs were produced by pharma industry. They have changed it to a compoundable offense. So if I manufacture a bad cough syrup, previously I used to be jailed, now I pay a fine and I get scot-free. Third most important thing is this ethical code is compulsory for us, right? What about the pharma industry? The giver has also to be controlled. In all the Western or the developed world, it is compulsory also to the pharma industry not to give any sort of gifts, inducements to the medical professionals. 2 years back in USA, Merck was fined $1.2 billion for giving inducement to doctors. So, but still today, they are saying the pharma industry will follow a voluntary code of ethics. They are kept out of punishment for manufacturing spurious drugs, while it is compulsory for us and we are supposed to have penalties also.
So we'll move to Shiva sir, he's been waiting
Just
for some
I
time.
think we are discussing so much about generic and branded and who is controlling all those things, I don't know. When somebody asks me, even whether the minister or something, see, it is under power of the government to stop all the brands. Yeah. They should stop all multinationals throughout and make. I have worked in Iran. There was only generic capsule, chloramphenicol, cough syrup, that's it. So who stops them? And if doctors are not going to write brands, who is going to prescribe those brands? Why this? See, government on one hand, see open economy, multinationals, they are all welcome. And doctors, they will write generic because of pressure that popular sentiments being brought. So it is totally, I think, confused this step.
So you are very close. You are very close to the government, the HM and the bureaucrat, Shiva sir. Shiva sir, you are very close to the health minister and the government.
So I speak same language in front of the health minister or health secretary, and have been vocal even in the central council. I was very vocal about so many things, diseases, being taken by, and Ravi is very right that it is totally controlled by bureaucracy, even not by politicians. It's all bureaucracy. And for IMS, Indian Medical Services, there was agenda which comes and goes. They don't want to discuss, because if the doctors are managing the affairs of the medicine, which was 1976, it was brought. Now they are keeping aside, because medicine world or healthcare industry is big money spinning item for all of them. So that is what, these are populistic. I think generic and etc. They are populistic. They do it, and as rightly said, if you have got problem, whosoever may be politician, they will side by the crowd, not by your side. So these are the things we have to learn to deal with such people. And I'm telling you, I'm very, I think I endorse that till I feel that I am not doing anything wrong, nobody can punish. Nobody can even point finger on you. So that is how you should.
One sentence.
Okay.
One sentence. That is why we always say one drug, one nation, one drug, one price. That should be the policy of government. You stop at the source.
Thank you, sir. So, Uttare sir, there is a dichotomy between the way the NMC looks at an individual doctor and the way it looks at a Fortis or a Max or a global hospital. Could you tell us, as a ex-MMC president, should we all form LLPs and start advertising through that? Nothing, the government can't stop a LLP or a private limited company from saying that Dr. Uttare is the best surgeon in India.
Yeah, I think what you are saying is absolutely right, and that is another thing. You're the best. No.
You have doubts?
And this is what means. Just because you asked me that question, let me tell you, to get a level playing field for individual RMPs, I had a special presentation of what is called as an ethical advertisements, which should be allowed to every person. The presentation was done in NMC, it was accepted in NMC, it went higher up beyond that and then came back. Even in this new notification, if you see, there are some changes which they have already made. And if you see that section number, I don't remember, but in that section now for the first time, along with individual RMPs, corporate hospitals, clinics, all this has been mentioned over there, that they will also be coming as far as this advertisement is concerned under NMC. But I have my doubts, because legally, even today, when I was the president in Maharashtra Medical Council, I had taken action against some institution like that for
Pathology Laboratory Group. I'm not taking the name.
For same thing. They went to court, and unfortunately the High Court gave a stay order saying that as a council you do not have any rights on such.
So there is a precedent, Cherian versus State of Kerala.
Yeah.
You cannot penalize a director of a private limited company for malfeasance of a director. So if I am a surgeon who's a director of my hospital, I can advertise and do what I like, and the MMC can't touch me. So if I ask you straight questions, can you tell individual surgeons here what are the loopholes in the NMC that we can exploit?
See, sitting over
this
there.
Is not being recorded, sir. No.
I don't mind at all, because I think even today, if you ask anybody in NMC, the one person whom they say was very vocal and talking against also was me over there. But if you read that properly, at least we have been able to put in one clause, and that was put when I was part and parcel of that committee over there, that today you will be able, even as an individual, to advertise, but only to the limited extent of what your qualifications are, what type of treatment you give, what type of patients you admit in your institutions as even individual doctors, and how much your charges are going to be. That has been allowed as per the new notification which has come. So at least this is the first step that we have gone forward. Maybe people who come into NMC after me also may try to push for all these things, and we may be...
So as per the new guidelines, can we form private limited companies or LLPs and continue advertising, and we'll be only responsible to the Advertising Standard Council of India and not NMC?
This is the paradox of ethics, where professional ethics versus business ethics. You have asked a very good question. Unofficially, those who see these new guidelines, you can be penalized even if you advertise on your website or social media. In Tamil Nadu, Medical Council did penalize 3 of the doctors for having website. Best what Roy sir has asked, form a LLP, form a private limited company and have big holdings. Nothing is going to happen. These NMC people don't have the infrastructure. Even in the generic, who is going to punish? There is a great ambiguity. The chemist is going to punish us. The FDA is going to punish us. Who is going to
See,
take
in the
action?
act, there is some controversy about the word shall versus should. Can you just enlighten me? No, it's shall and should, not must. Is that a legal
This is just a hair
loophole?
splitting.
Is that a legal loophole?
This is again something which is absolutely wrong that has been done. Let me be very frank. When you form a code of ethics, that has to be followed. How can you say some points in that code of ethics are must? That means it is mandatory. Some are should or shall. That means it is an advisory given by us which should be done by you. I think this is something very stupid that has been put forward and which we have already opposed as far as NMC is concerned.
So how would you look at Pristine, given this now coming in? I'm taking by name these aggregators. There are 3 or 4 aggregators in the market, and this affects anorectal surgery the most. 100% guarantee, no pain, cashless insurance, free consultation. These are on Facebook all the time. If you are an MMC today, what would be your stand, sir?
We have taken action in the past, not on Pristine, but as I told you, on other institutions for the same thing. Unfortunately, a stay order was given and the court told us that you do not have a right. Because I'll tell you, our laws and acts have been written decades ago. And as far as MMC is concerned, it has been specifically written, we can take action against only those who are registered with us.
So what you're saying is form independent companies and continue advertising.
Continue doing whatever you want. Nobody can touch you as of today till a new law comes.
Perfect. Thank you. That's what I wanted to hear.
But it all is state to state council, you know. You are good-hearted, fine. There are some states, you know.
Yes.
I think this concerned, I like to bring a small information, right? Yesterday, a couple of days back, I was talking, we had a long discussion with Narayanamurthy Infosys. And he was identifying lot of problems in our Indian society comparing with international. He has been man, traveled widely. And he says there are cultural, you know, differences in India. Nothing is like a shell or should. No, lot of things is there. So if we want to come up, it will take thousands of years in India. Something is going wrong. But what we can do according to his wish, I also suggested, he agreed also. Anything of this, if National Maharashtra Council President sitting it, he becomes a small in front of bureaucrats of India. And Indian bureaucracy still learn from a British guys. They know the minus and the last small lacuna, making it up, sitting down. I don't know how many of you know that Establishment Act was passed a couple of years before. Not discussion held at all. It is a Carolite nursery and a dental group of people made influence with the minister, and ministers called the secretary and went in. Half an hour the meeting is over and nothing was discussed. IMA president was sitting there, part of the council. He was not asked to give an opinion. And finally everybody signed and went off. Our IMA president, why he signed it? Should have left it, no? No, I was not asked, I have not given opinion, so I cannot sign. But he is also, most of the office bearers, you know, why should get a bad name, good, no? He signed.
Sir, you have 2 IMA office bearers up there, I'm warning you.
I'm telling you, no? But we must...
I'm just adding a mindset. We are talking about mindset. Bureaucracy is sitting in the Central Council meeting, and all health ministers, all health secretaries, and the union minister, union secretary, everyone. And they are depicting the agenda, saying now we are going to increase the seats, PG seats, undergraduate seats, and now under one professor there will be 4 students and more work and all. So I said, you are loading the doctor or the teacher with lot of work. What about remuneration? This was my direct question to the health secretary. Her spontaneous answer was, how can a doctor get more salary than a secretary? And my spontaneous response was, everybody, it is there in the minutes, that this is British mindset. You have to change your mindset. Otherwise, you will not get good doctors and people will move away from medicine. So that is important. Mindset is totally refractory.
So
Yet
we'll change tack.
2 type of mindset must be there in this. when they want to raise the seats, it is not compulsory that institution to start. If the central government making an establishment act, it is not that must to implement by states. Health, education, and there are departments, state and the central has got a lot of things. When the establishment act came to Tamil Nadu, and luckily doctor was the health secretary commissioner at that time, and our group of people could explain to her, doctor, this is what. She also felt, but I can't do it. I have to talk to Chief Minister. Chief Minister also nice that time. If we talked to Chief Minister, said, as long till the committee come and say, Tamil Nadu group what he appoint that time. Till it comes, this establishment not been implemented. Now 4 years gone.
CA you're talking about, Clinical Establishment Act.
Yes. Similarly, I'm telling, similarly, number of seats, MCH, DM, all courses was set double by National Board at that time. Madras Medical College implemented, Stanley Medical College did not implement. And he says, if you ask remuneration, they will say jealous. But don't ask remuneration. Only 4 people can teach, beyond we can't, and you have to appoint next and another 2, 3 faculty. Then they do not have, they cannot implement it. So not all colleges or private institutions, if the National Board says, you can have 3, can have, I can increase if I want. If I can't, I say that I don't have faculty, only this.
So we'll change tax. So we have only 3 minutes left. I want to ask.
Last just point. The main important, what I was going to emphasize, all those people, whether DGHS, Niti Aayog, NMC, they're all government nominee, government appointed. So they don't, even they want, they cannot. Even health ministers who are doctor, they don't speak the language of the doctor. And that is why they all congratulated me in that meeting. Sir, you please keep on coming. We are government servant. We cannot say what you can say. So this is the fact of our health care scenario.
So we'll change taxes. We stop, sir. We have 3 minutes. I need to ask something to Dr. Supe. Dr. Supe, you're author of Tokyo Guidelines. You know, you have more than 100 peer-reviewed, probably 200 peer-reviewed. Do you think publications and presentations are relevant to the new surgeon?
Of course.
Mike.
Whatever you say, old methods of improving your image. See, publications doesn't mean that you are only writing a paper and getting published in a predatory journal. If I'm working on that topic and I'm doing myself, I'm improving myself. And I think I'm doing something, I'm reflecting myself. So I'm grading myself much higher. I think it's not that when I publish a case, if it's a true publication of, say, I have done, say, 100 fistulas, complex, my skill set is much better than anybody else. And I think people will realize this, people will send you, your skills will grow more, you reflect yourself more. So I think publications are extremely important, whatever you are doing as young generation, please do write. Now today you are much easier to write. You know, I think I'm sure me and Palni must have struggled to type a paper with your own typewriter.
And now you have ChatGPT.
You have ChatGPT, yes. But use your brain in addition to ChatGPT. That's my advice.
Sir, we have exactly 2 minutes. I'm going to ask all of you one last question.
Right, before you come to the last part, because we forgot one part which you started with in the last discussion, is about having such meetings in the future. I think we went into generics. Let me tell you again, that words that were used over there, directly or indirectly, which take. Very bad words are used over there, which should not be there. And I'm in discussion. Next week, I'm incidentally going to NMC and going to, for this same thing. Let me tell you, if they insist on keeping those words as it is, let us have the guts as organizations to stop all CMEs. Why, I'll tell you. On the one side, they have said that 30 CME hours will be compulsory for you to do it. Now, who is going to bear it? And this is another proposal I had given to NMC. I said, you have enough of money. You start doing CMEs. Why do you depend on the organizations to do CMEs? If you are going to make it compulsory and at the same time tell the organizations not to raise money for the conferences, then you start doing CMEs everywhere. Because you are making it compulsory for our members. So let us have the guts to stop it. They cannot do anything.
Thank you, sir. Last question to all panelists. We'll start with Shiva, sir. If I were to ask you in 2 sentences for the young surgeons of the audience, how to achieve success in life, not necessarily surgical career, how to achieve success in life, given your experiences?
I think most important is your passion, your commitment, and I would say it is for your life. improve your likability. What is that? Honesty, sincerity, not your dress sense, but you are not conniving, you are not manipulating, you are straight, you are honest to your patient, you are doing whatever, and be safe. And don't try to have that hubris that yes, I can do it 10 minutes or 15 minutes. Stop it. Don't look at the watch. Do the best you can and always be safe. I think these are few things which will, and keep on training, keep on attending conferences, workshops, and self-training, and improve your communication skills.
Thank you, sir. Dalvi sir, you've been unusually quiet. Last sentence of motivation for the youngsters.
See, I'll tell, for the youngsters as well as the senior surgeons, what I have learned in my life is very simple. One should keep on educating and look ahead. But when you take 10 steps ahead, look back. Because it is the back that is going to tell you what support you had and whether these people are learning the same way that you have learned in life. That actually to me is success in life. And I'm very happy that when I look back, I see so many of my students who are doing well now at a relatively younger age, doing much better surgery than what I can do. And they are now learning even robotic surgery. I am exceedingly happy. Thank you.
Thank you. We need to close here. Thank you for the wonderful time with the panelists. Big round of applause. Thank you. Can we have a photograph?
Before moving to the last session, we would like to felicitate two of the esteemed panelists, Dr. Palani Velu sir first and Dr. Supe sir then. I'll request Dr. Niranjan Agarwal sir to put a shawl, Dr. Parveshek sir to put a shawl on, bouquet, a memento by Dr. Niranjan Agarwal sir. We want everyone to felicitate Dr. Avinash Supe sir also. Memento, shawl, bouquet and shriffle. With this, we'll move on to the final session of the day. It's very interesting for everyone. Thank you, sir. It's a interesting clinical case scenarios. To moderate the session, I'll call upon Dr. Shekhar Suradkar sir and Dr. Kushal Mittal sir.
Friends, please be seated. After this session on interesting cases, we'll have a wonderful orchestra by our own doctors from Mumbai. They call the Sargam Medicos. Our gynecologist friends from Mumbai city, they will sing and they will entertain you. There will be a banquet dinner night after this. So please wait, don't go away. And something more interesting on fistula is going to come up now.
There is one announcement, please. As anybody has got the car keys, they can just submit in the backstage. So panelists for the session. The panelists for the session is Dr. Jaspal sir, Dr. Chivte sir, Dr. Shijoy Patnaik sir, Dr. K. Balu sir, Dr. Jayalal sir and Dr. Kanagwel sir. Everybody please come on the dais to chair the sessions. Over to Dr. Kushal Mittal sir and Dr. Shekhar Suradkar sir.
वो काम नहीं करता ना, ये पॉइंटर है. ये पॉइंटर है ना मेरे पास ये. चलो. ये पॉइंटर. और ये स्लाइड.
ये तू काय आमचा फोटो घेत नाही. घे फोटो घे सर आमचा घे काहीतरी.
सेट है. ये नेक्स्ट होगा. ये तुम लोग आगे क्यों नहीं करते हो?
थैंक यू काहीतरी तर घे. क्या हो रहा है?
लेडी भी है. नहीं शेखर को माइक चालू करो. जो सेकंड है क्या क्या
काना के बोले ना, काना के बोले
इधर से सेकंड सर.
श्रीजो है ना, श्रीजो पटनायक.
हेलो डॉक्टर निरंजन.
Dr. Chiude, sir, please come on the desk.
Yeah,
Your name is there.
Here, chair is here. No. You.
I think one chair here. No, it's okay.
Dr. Parthasarathi.
Dr. Parthasarathi?
No. Okay. I think I got all your attention. So, on the panel with me is Dr. Shekhar Suradkar, past president ACRSI. Then we have Dr. Jaspal Telia. Dr. सर ये सुबह से ही ऐसे लाइट है. लाइट कम हो सकता है ये वाला.
Sit here, sir.
Okay, we'll tell them. Okay, starting from left side, we have Dr. Chute, past president of ISCP. Then Dr. Jaspal Telia, he is from Vijayapur, Karnataka. Then Dr. Srijoy Patnaik from Bhubaneswar. And then Dr. Jayalal from Kanyakumari. And Dr. Kanagawal from Chennai. And Dr. Balu from Coimbatore. So we have pan-India coverage. And I think we have covered almost everything today. But still, there are some interesting cases, and let's go into it. So these were our panelists. Now, Dr. Shekhar, we start with our moderator, Dr. Shekhar. Tell me, you can read that.
See, friends, as our previous speakers, many of them have said, they consider all the cases of fistula in ano as a complex one until proved otherwise. And would be presenting many such cases which on first impression appears to be very simple, but turns out to be very complicated. So we are going to present you some such cases which would perplex even the most experienced surgeon. Now my first case was a 50-year-old man. He was presented with swelling on the posterior aspect of the thigh, and he had history of fever. There was no history of diabetes or hypertension, and history was painful defecation. He had only swelling in the posterior aspect of the thigh. Can I have the picture? This was the post-operative picture, and when I did the examination of the per annum, there was boginess on the lateral aspect of the anus. He had a transphincteric abscess which was spreaded up to the lower third of the thigh. I had given step ladder wise incision in the first case, and later on I did a definitive surgery. So my question to esteemed panelist, how to manage this case? Dr. Chute is the most senior surgeon sitting amongst here. Sir, a case presenting like this.
When you are seeing boginess right from the anus down, diagnosis is nearly clear. One thing you should see also, doing clinical examination, whether how much inside anus this fistula is going. Outside what you are seeing, it is visible. But whether it is inside, because otherwise recurrence will occur. So once you know that, how much it is extending inside, you know what is limitation of your surgery. You can make a small hole in the thigh and upper side, so you can tackle fistula going to the anal canal as well as fistula going to the tract by curating only. So making all these incisions is good because you have not cut all over. Making small incision is always good, but this can be also done without much problem.
So would you advise any investigation like MRI, something like this?
See, of course, MRI is always, useful for all people, but clinical examination is something like 80% of MRI. I always believe all people should have clinical examination and they should learn how you should do clinical examination for the fistula. I am not saying it is very different, but if you are examining as for a fistula, always put one finger inside, put another finger outside and see what cord-like structures are seeing. If external opening is there, whether it is where it is going as a cord to the anal canal. That is one aspect. So you are knowing extent of the external fistula till anal canal. Then once your hand is inside, palpate the whole dentate line. This dentate line will show you any induration is there or not, any tender point is not there is not. So all this will give all answers to you. Plus, you must learn how to examine puborectalis muscle. Once you learn puborectalis muscle, you will know whether this fistula goes above the puborectalis or below. So all those aspects will be clear. That's why I always say clinical examination of the fistula particularly is nearly 80% of your MRI.
Professor Dumbre has joined us. He is the very senior surgeon from Pune.
So going along with this, as it has spread to the thigh, many a times, like Dr. Arshad is there to talk about it, and I was there also, you have patients who have abdominal abscesses, lower abdominal abscesses, and if they are lower abdominal abscesses, please do not go and do a lower exploratory laparotomy. Perhaps you should look at the anal canal, and if you find something there, and then you should go on forward. Similarly, how the fistula tract can go up. Coming to the second case, Dr. Shekhar.
Yes. This was the case of recurrent fistula in ano. Professor Kanagavil, how would you approach this case? Complex horseshoe fistula.
Check. Right. I have something more than a conventional fistula here. So, first of all, I'd like to look into the history of the records, what has been done earlier. That will give me a fair idea. There is a previous biopsy report. I'll be very keen in looking about it. That is from the medical record review. Then, of course, the history will be very carefully need to be elicited regarding his bowel movements onwards, background of medical treatment, what he is on, especially drugs which could cause constipation. These are all my routine questions for any.
What exactly are you looking for in history? Just 1 or 2 points.
My point is I would like to exclude IBD,
yes,
inflammatory bowel disease.
What else?
That will be the most important thing. And possibly I will also look about his sexual behavior.
Okay.
These are the 2 things I would like to more carefully ask for. Then apart from that, a good, fairly well-lit clinical examination.
Okay, done. Next.
And then my choice will be to go for an MRI.
Yes.
Before going for based on MRI, I will also include a possible colonoscopy for this patient before embarking into any.
Okay.
Now coming back to the surgical management, we do not have any gold standard. Suppose you have to do some open surgery, open fistulectomy. What steps would you take and how will you approach?
Dr. Jailal.
Opening is at.
Before this, we must keep such type of fistula always in mind. When multiple fistulas are there, systematic diseases should be kept in mind.
Yeah.
Like IBS, tuberculosis.
Yeah. Here I just want a young generation to know what steps of the surgery will you do how to approach open fistulectomy. How to approach in this case?
Dr. Jailal.
Yeah, definitely I will look for the internal opening. If I could see that opening at the 6 o'clock, the posterior aspect,
yes.
I understand it should be the post-anal space is the most culprit area. That's the primary side. So I will approach the post-anal space. And from there, if depending upon the methylene blue and hydrogen peroxide, if the openings could be identified, either I could do the fistulactomy, or even through the just surrounding. If it is a well-matured tract, I can go through that and excise it.
You will make an opening in post-anal space, in intersphincter space,
yes,
right?
Yes.
From there, you will make a fistulotomy open up the space. And then you approach both the sides.
Both the sides.
Right. Anyone, Dr. Srijoy?
It looks like to me a complex fistula horseshoe type. And I think there is a scar also on the one side.
Yeah,
It seems
right
that
side,
he
right
has been
side there's a
operated.
scar, yeah.
It's a recurrent one. And the posterior aspect, I think we have to do a fistulotomy first, identify the internal opening, according to treat the patients. And the anterior aspect, I think we have to do also a similar sort of fistulotomy.
I want to ask you one thing. In that case, supposing this is a Crohn's disease, so we'll have to first clear out whether it's a Crohn's disease or not. Because if we operate, it will recur again and it will be in a bad way. So we'll have to first find it out whether it's a Crohn's disease or not. And accordingly, we'll have to decide whether to operate or not.
So as Kanakvel told us, we have to do a colonoscopy if required, a biopsy, then accordingly.
Yeah. Actually, my question was very simple. How to approach such cases in just for the benefit of younger surgeons. Our third case.
Okay.
This was the case of recurrent fistula and ano. Although the external opening looks very near to the anal verge, but this was an iatrogenic opening made, which was going superiorly in the supralevator space. So, sir, Dr. Balu, how will you approach this case? This was not a simple case. It was a high intersphincteric space opened from ischiorectal fossa.
The opening now does not look like what we'll typically get in an intersphincteric abscess per se. Probably it has become transsphincteric now, looking at the external opening. So definitely an MRI is mandatory in this patient because I don't know what has happened previously and why an intersphincteric will open here. I'll do an MRI, and rule out an extrasphincteric, transsphincteric tract, map out the tract, and then decide if it is predominantly intersphincteric. I will approach it from the inside, do a long intraanal fistulotomy, if it is an intersphincteric long, through the intersphincteric space. And this external part I will core out and then repair the external, put a couple of stitches if there is no sepsis in the...
The track was going straight supralevatorally.
Check. And the rest of the above part I will cure it and leave it.
No, this was a case long, very old case of mine before the MRI was gold
28
standard.
years back.
Very long case.
Okay.
So,
Okay, let's go to the next one.
Next, yeah. So this was the case of mine who had a recurrent horseshoe fistula with you can see the multiple openings. I did lift with the multiple set-on placement, and patient unfortunately came back with recurrence. And next time when he came, I did which is that test?
TB PCR.
नहीं
TB Gold.
वो कौन था रे? TB PCR.
Okay, he did TB PCR. It was positive for
And it
tuberculosis.
came positive for mycobacterium tuberculosis. I started anti-tuberculosis treatment, and within 1 month, the next picture, please. The patient healed completely. So for the young generation, keep always, in India, about 10% patients, they suffer from tuberculosis. So always send the specimen for histopathology.
Mike.
All recurrent fistulas, we must get histology diagnosis what it was earlier. Same mistake we should not do, keep on doing it and it comes tuberculosis. It is better. Whatever if they have not done, that is different. But you can do one small thing, you can curate some material or pus, you can send for CPR tuberculosis examination. If you get that thing, your one operation will be saved and you will not have any problem otherwise.
The message we wanted to tell you by this is that when you have multiple openings like this and they are bluish, naturally you're going to think about tuberculosis. Get a confirmed diagnosis. Don't be in a hurry to operate. You put the patient on anti-tubercular drugs. Wait for...
No, you should prove it first.
No, I said biopsy, after biopsy.
Yeah, prove it first.
But sir, I said after biopsy.
Correct.
Biopsy proven, only you start AKT and you wait for 6 months and see how it is. Most of it will be healed, maybe 1 or 2 tracts may be left behind. You continue the AKT and you take care of that particular tract. So you will have like so many openings, and in the end you will end up with only one fistulotomy. You may just need to do, rest heals up. So don't be in a hurry to operate these patients. Start first, get a diagnosis. Shekhar. Yes, yes. एक माइक फ्लोर में भी दे दो.
If the patient has been operated previously and you can procure the old slide, a PCR can be done on the old slides also. Of course, the sensitivity will be little low than a fresh specimen. What I mean to say that not every time a fresh specimen is required for PCR.
Okay. So that means those which have been fixed can be also
yeah,
done.
if a patient can get a old paraffin block, a PCR can be done on the old block
Thank you.
also.
I didn't know that. Okay.
Again, this was the case of a retroviral positive patient. He had a tuberculosis chest lesion present, and he presented with classical, you can see her shiny skin, multiple openings with, you can't see the serum coming out of that, but it turned out to be tuberculosis. I sent a scraping for histopathology examination and it came positive. So in retroviral patients, these type of fistulas are to be treated with anticox treatment after diagnosis. Anyone? So
Yes,
one has to keep in mind.
After confirming, we have to treat it with the anti-tubercular agent along with antiretroviral agents.
Yeah, that goes concurrently.
The policies remain, the HIV protocol says you go by two governing things. One is the viral load, the second one is the CD4 count. Because that only gives either you go for HART or a conventional ART. Because here the time interval gap has to be there where CD4 count goes up of 500 before starting ATT. Because
you need
that is more important. Because ATT less than CD4 of 200 does not work.
Okay.
Because ATT is driven on interleukins, the TNF, these are the factors principally ATT work on. The mycolic acid envelope, the inflammatory reaction is the one ATT works on. Later, it has to get into the mycobacteria to start working. Unless there is an inflammatory reaction which is evoked by the body, no drug can go near to the bacilli only.
Okay.
So CD4 count has to be first escalated to 500 plus, then you start ATT. That is going to be a very tricky situation because mortality is very high when you first start ATT without looking for the CD4 count.
Okay.
So people handling HIV, please be liberal about two things. One is serum complement level, other one is the CD4 level. Please be aware of this before starting ATT.
Okay, the message is loud and clear, and even I didn't know that. Thank you. Thank you for telling that. Then Dr. Chiote's case, complex fistula nano. Sir. No, you have to talk about why this case, why you wanted to show this case.
This patient was young means 31 years old lady. She was a dancer and she had a big abscess on one side and multiple fistula, rather at anterior aspect. That fistula has got multiple tracks, going anteriorly, going to through intersphincteric and going through directly to the posterior aspect. And through the posterior, again, they have anterior and posterior aspect, all abscess were there. So this case, somebody suggested that nearly half buttock should be go with abscess and everything. So she was dancer, she said, no, I don't want to cut anything at all. So we did endoscopic, incision drainage of abscess was done with only small incision, about 1 centimeter at the lowermost portion where it can drain well. And then all the whole fistulas, we treated with endoscopic and curated everything. And after curating, we packed a collagen around it. And she had good results. I think you can show that video if you want. Yeah, this was the picture. What you can see that total abscess was there. It was extending one fistula up to supraelevator region. Second thing going to the anteriorly across the midline, then posteriorly going anterior and posterior aspect of the fistula. So all these fistula we have treated plus abscess. This is what we used, I think, hysteroscope for this. Usually I don't use waft because it has got small caliber, only 1 millimeter, telescope is there. So we use about 4 millimeter telescope, and these are all the instruments what we require. What we are using as a curettes, I seen it earlier, they are scoops. They don't curate very well. So you have to get this type of curette where they are very sharp and they can curate everything. See that. What earlier I seen people were curating was just nothing but scoop. Scoop is not very sharp. Scoop is for putting something from here to there. And just blind curate. And here you can get sharp curated. And you use this Hagar's dilator to dilate external opening of the fistula, not total tract. So this is what we did it, and through this scope we have seen inside. Yeah.
Yeah, actually, for the benefit of this audience, I would like to tell that Dr. Chiute has introduced this cystoscopic examination of the fistulous tract and curating this fistulous tract long before the VAPT came in. Am I right, Dr. Chiute?
Yeah. We started in 2003, and I presented my paper in Ahmedabad.
Yes, sir, because you didn't present your paper on time, that's why the VAPT that Dr. Minro got all the accolades.
No. Minro has started in 2011.
11, yeah. Because you couldn't present earlier.
He presented his paper published paper in 2010. It came to India in 2011. I started doing endoscopy work in 2003.
You presented in many of basic and our accuracy.
In Ahmedabad, I presented in 2006, and many of our, senior colleagues.
So the real credit should be given to you.
Credit is not. It is useful to the people, That is the thing. If they use, they will see inside what it is.
Sir, coming to the case.
Yeah.
This is what you had done. So I am just showing you.
This you can see that scopes are being. I cannot show all the fistula inside. All 4 or 5 fistulas are there. So you are seeing anterior, posterior, intersphincteric. Why I say intersphincteric? From above it goes up to the posterior border of the anus. So that is the intersphincteric. Then going posteriorly down. So all these pictures are shown. Next.
Sir, can I ask a question to Professor Shivati, sir? Sir, in your experience and in global data, by adding this fistuloscopic inspection, are we gaining any significant advantage? If yes, what are the areas this scopy gives advantage? Eventually, as an outcome, does it reduce recurrence?
Basically, we are not treating fistula as a treatment is not given as a radical treatment. It is epithelial infection. It is a benign disease. So we should give justice to the patients. When disease is benign, why radical treatment of excision of fistula should be done? That is one. And what can happen during excision are the thing all surgeons know. That's why all surgeons cannot be Parvez. This is the basic factor because I am not that type of daring surgeon. I excise everything. Then I decided why I should not go scrap out epithelium which is diseased. And this disease, whether I completely cleared or not, only I can see by endoscope. I cannot see from outside. There is no other, go than that. So endoscopically, if you see inside, I showed you in the morning also, in simple fistula, if you have curated everything, all pus or debris and everything, then you can clear fistula is there. How that fistula should be treated is another point. So once you do learn endoscopically, and this endoscopic, sir, this is with 4 mm optics. 4 mm optics will show always better than 1 mm optic. So that is what, contrast is there.
Okay, we got cases. I want to show you the video.
This is what curating we have done, and lot of curating material has come, that we removed everything, because you have seen this patient was quite a long suffering with abscess and other thing. So this is curating which is done from the upper fistulas. Then, see, this particular kidney tear I would like to show you. Once abscess is there, once infected fistula is there, always our attitude is there. We wait till fistula gets matured, what is called as. So we put draining set on, this set on. But in curating immature fistula or suppurative fistula, it gets curated very well. You have seen this fistula is so much curated, you are getting fats around. That fat is floating in the kidney tray. That's what I want to show. Once this fat is there in the kidney tray, that means you have completely curated fistula. And again you are confirming by endoscopy. Yeah.
So, collagen.
This is collagen material what I use, because see, my main aim is there. For putting collagen, two things are there. One, this collagen can pack the whatever dead space is there. So no collection will be inside. That is one. Second thing, this collagen can stimulate fibrosis. It has got itself fibroblast. So this can do that, and it will try to heal faster than what it is. By chance, collagen extrudes till that your cavity has been kept open and no collection will be there inside. So you can keep on washing that thing. So it serves both purpose to cover the dead space, and cavity can be sterile later on. This is, you can see all fistulas have been put collagen in that.
Sir, morning we had this discussion, some surgeon was saying that not to pack the abscess cavity. How do,
Shekhar, this is collagen. And packing, we're talking about...
Packing is with bandage or this material, I agree with him also. And now also I agree. This, for abscess, where big cavity is there, collagen will not take place there. There we have put catheter. This is what fistulas are there around. Those fistula we have packed with collagen. Abscess cavity we have put, after curating, we have put Foley's catheter. Once abscess cavity is curated, and once you have kept Foley's catheter, within 2 days total cavity collapses. Because we have removed all capsule or whatever, linings have been created. That gives better results. And nowadays also, I don't open any abscess except 1 finger breadth. And I don't break anything inside, but we put scope inside and try to curate everything. And once curating material comes something like fat, we are satisfied. We put Foley's catheter in abscess cavity, and even you put collagen in that, collagen will not get infected. That may come out because abscess cavity is very big. You cannot pack it. So you put a Foley's catheter inside, so that will, collapsing will be known to you. You can give wash few days. If there is no collection, you remove catheter.
Do you do primary fistulotomy in such cases, sir? Huge abscess.
This is with huge abscess only we have done.
Do you do primary fistulotomy?
Why we should do? We don't do anything. We close the internal opening. That is over.
So will it cause hemorrhage or bleeding when you are doing extensive curettage?
Yeah, we do all curating till internal opening.
Will it produce a bleeding in the patient? Or excessive bleeding or something like that?
No, usually not there. Because
sir,
I'll tell you.
I would like to answer that question. Bleeding will only occur when you put your finger in. Because you are then breaking the pudendal vessels and all other vessels there by pulling it out. As long as something straight is going in, it can cause temporary loss, but you will not rupture. So therefore there is no bleeding. But when you put your finger and try to break the loculi, which don't exist, they are basically blood vessels, then you have torrential bleeding coming. Okay, Dr. Jailal. Now, before we start, I want to ask you why you wanted to show this case and what message you want to give across. Tell us about the case.
Yeah, this mainly to see that before doing any fistula, it is better we go for a MRI test, so which will be able to give us an idea how much is the sphincter is involved, how much is, what is the exact plane in which you are. If there is a total sphincter, both internal and external, there is the option which you are going to choose is different. But if it is only the external sphincter is very much preserved, and definitely we will be go to the primary fistulotomy can be done. So this patient is just shown the
same patient.
Patient was having a multiple fistulous tract, and we yesterday morning also we thought of the Good-Salt's rules, and it is one area where we are able to see the external opening anterior to that, but it is the primary source all coming from the posterior aspect. The internal opening was only at the 6 o'clock. The tract is going towards the anterior aspect. So when we are able to see the internal opening and identify the internal opening, it is there. Then we are able to identify that the tract which is going, so that tracts can be kept open. The post-operatively, the healing will be much better when we are opening. The fistulotomy is being done in this case. This is a fistulotomy is done. Extensively, even going to the anterior aspect, preserving the intersphincteric plane it was going. So we are able to keep the recovery.
What Dr. Jayalal is saying, when you have a fistula opening at the base of scrotum, don't jump to the conclusion that it is going to open at 12 o'clock. It may open at 6 o'clock. And if it's open at 6 o'clock, then you have a surgery like this, which goes around the anus and cuts the whole thing out. Total fistulectomy was done. And because it was a low, so he could do a total fistulectomy. And the wound healing is quite nice. And you can see that on the slides. Your second case. Long fistula tract.
This is your case.
Yeah, I mean, I will ask other panelists will be able to.
You are supposed to say why it is interesting. I am going to ask you.
It is the external opening, internal opening is the 6 o'clock, but again the same type of case, the opening which you are seeing, and then anterior, the scrotal, the opening is, external opening is there anteriorly. So it is intraoperatively we have to go up to that area. This just to save, same with the anterior opening is there. As you said, don't think that it is always, it is a short.
Correct.
It is identifying the primary internal opening is the most important thing, so that we will be able to track that track. But it will also help when we are putting the methylene blue and the hydrogen peroxide. We know that the tract is opening, it is continuous with that. So we were able to do the extensive dissection and take it out.
One thing I want to ask you, during my residency times, whenever there is a big fistulas and multiple fistulas, our senior surgeons used to do colostomy and keep the tract open for healing. How do you feel about it?
No, so that time probably we may not have the preoperative investigations. Now, and since we have the MRI facility, then we will be able to assess what is the level of that. If it is going to the supralevator and going to the rectum, we are suspecting, yes, it may be a possibility you do the diversion colostomy. But these cases, definitely it is.
Yes.
See, I think I am of your age only, or a little elder than that. Still in my life, I never thought of doing colostomy for fistula. I work in general hospital also. There, multiple fistulas and other things people used to come. But colostomy for fistula is not to be thought over. Unless traumatic fistula is there, all over the rectum has been destroyed completely. Otherwise, no.
Yes, sir. I would like to add to it.
Sir, there is
The only exception probably will be in Crohn's, where you have a very bad perianal disease with a lot of sepsis, where you are not able to control. You have a stricture, you have a sigmoid or a rectum which is very bad. That situation, we may consider a colostomy or an ileostomy. Otherwise,
not to be. Yeah.
I think Dr. Kamal, you have been.
Yeah, sir, I just wanted to ask you that it's a simple case, 6 o'clock going anteriorly, scrotum, scrotal junction, simple case. So why such an extensive surgery has been done when you could have managed with lift or any other minimally invasive technique?
Yeah, you are right, sir, but we are working in a...
Sir, for lift you don't require anything.
No, the lift, I think, in fact, there is a good option that the lift you could have done. The curating and other things can be done, sir. But such a long tract, just by a curating, that we may not be exactly sure that we have removed that. We may not have the facility like fistuloscope. Sir has the facility to the fistuloscope, then you would have seen the extent.
Dr. Jayalal, I would like to just mention one small thing. The only portion you are really supposed to be interested is from the internal opening to the intersphincteric space. That's all. It doesn't matter how long the fistula tract is. It can be 10, 15, 20 centimeters. That is not the issue. You can just curate it, like Dr. Chiote has shown, curate it. But if you don't manage that inside part, the fistula is going to be recurring. And the other thing by colostomy, sir had asked.
I will quickly tell one more point about it.
Yeah.
Sir, the current IBD guidelines, especially the 2022 ACG guidelines, have mandated 2-3 important things beyond the primary management of local sepsis. They very firmly believe the MAP therapies, 4 different type of MAP therapies which has come. I'm not sure whether we'll be able to afford at all. Some things are costing $40,000 per month. So, but things apart, they have very, very typically proven the Ustenicab, leave alone the names, specific maps have avoided stomas.
Okay.
Because by merely doing stoma, you are not controlling the disease. That is the message they are trying to tell. If your inflammation is controlled with appropriate combination therapies of MAPS, the fistulas does not require surgical treatment. This is the statement the current guideline goes on. Unfortunately, we do not have access to many of these MAPs, what they are talking about. MAPs specifically for anal fistula management have been recommended now. So one should spend time reading about it before jumping into it, because they very categorically say stoma is not going to change the immune reaction of the body or immune response of the body. Only condition where, as long as the patient is not able to pass motion via naturalis and principal motion comes out through the fistula, is the indication for diversion.
Okay.
By then stricture would have already developed. Those are the cases stoma is essential.
So when you have a anal stenosis, you have a lack of... Okay, one of the things I observed, which was very surprising, I went to St. Mark's Hospital and Professor Robin Phillips, who was head of department, we saw 11 cases being done, and 5 were rectovaginal fistula, and all these 11 patients came from different countries. And all of them, even for a simple fistula, there was a colostomy. And there was a colostomy.
Yeah, yeah.
And I asked him, why do you do colostomy? Because we haven't done it. This is the other countries who are doing it. So your question was very good, sir. Do you need a colostomy? You don't need a colostomy unless the patient is in dire circumstances, who has fulminant sepsis or other indications as proven. So let's go to the next case. And is Dr.
Got some questions.
Yes, ma'am.
Good evening. Sir, we know how to do lift and we have lasers, but we do not have the fistuloscope. I want to know from you, how would you want me to manage this case?
This case?
I am not
okay,
in the
okay, you can,
preference to open the patient like this.
you can do lift, and then you can manage the tract by curating it out, or you can even core the tract out. You don't want to cut the whole thing, but you can do lift because you're taking care of the primary pathology. And the primary pathology has to be taken care of when you're going the intersphincteric sleeve to close it off.
Do you suggest DLPL, distal laser?
Well, Dr. Kamal.
Sir, I think what you said made a lot of sense, because just to remove the source of infection, if you just remove the primary source of infection, which is the internal opening, even then the patient is going to be cured.
Yeah, Dr. Kamal, actually what you should do is pass a probe from the external opening to the internal opening, do lift procedure, close the internal opening, and what I do, I keep a draining seton in the distal tract after curettage. I'm going to show
Okay, so now, even after lift, you will not be able to open the deep intersphincteric space in this patient, sir.
You see my photographs. I have got enough evidence.
Okay. She's saying how to put a seton. See, putting a seat on, you have to remember this is a very long tract. And your probe is not going to go all the way. Till the point it goes, make a small incision there and put the probe again to go towards internal opening. Or start from the internal opening, go out till where you can feel the probe. Make a small nick there. You can make small nicks to gather this huge long tract.
Staging. And
Okay.
Step,
Okay. Arey, light band kar do. Itna flicker. Okay, this is nice. This is nice. Yeah, good. Okay, now I'm going to ask Dr. Kanagavel, why has he given such a simple case? So why have you given such a simple case? Do you have a big message behind this?
Yes, sir. Sir, but then before I would like to listen to my colleague panelists. Sir, this is a straightforward young lady, mother of 2 children. You can see the episiotomy scars down. And this lady came to us with telling, getting stained in the undergarment. That was the only thing she landed up with us. But then she gives history of little bit constipation, and couple of times she has had pain. That's where we landed up to on. Looks fairly straightforward, but as morning, the message given by Dr. Kushal, any doubtful location of fistulas, we do a MR. It is part of one of our thesis. So this patient had an MR. Sir, can we see the MR running, sir, please? I would recommend you, all of you, to watch carefully.
So you have to tell us, we really can't make it out.
I'm sorry. You can see various weighted images being shown. Fairly straightforward fistula. It was reported as an anterior fistula draining into the 12 o'clock zone. And we confirmed it. But to our surprise, when we went in, it never had a direct communication at all. So eventually, when we put in the hydrogen peroxide, I don't use upfront methylene blue because the entire area goes stained. So initially hydrogen peroxide. Hydrogen peroxide didn't come to the internal opening for quite some time. I took time to look at the internal opening at all. Then finally what has happened was, then I had my own suspicion. Then eventually I had to put in methylene blue. Again, it took more than 7-8 ml of methylene blue before it could come onto the anal side. It of course did come at the 12 o'clock position. But if you could see the ramification, sir, I will have to have the next slide, sir, please. Sir, I will have the next slide. So eventually, this was the complicity of the track. So this case, I would like to bring into your notice, don't blindly trust the MRI. MRI also has limitations. Mere fact, MRI shows a simple straightforward track. Surgery need not be true. This has not happened very often, but this is one case which took more than 1.5 hours of my time. But meticulously, the methylene blue helped me to save that thing. Eventually, the patient healed off without much of a trouble. So I would like to listen to the experience from seniors here. How many times MRI has fooled you?
Many times.
So where we have to be suspicious, where we have to be doubly cautious?
You have to match your clinical findings with MRI. And if it doesn't match, then you talk to the radiologist and still trust your clinical, because MRI many a times will say the internal opening is 4 centimeters from anal verge or 5 centimeters. And on the table, the moment you push it in, it's at dentate line. So that is the measuring problem they have. So you always have to take it. Dr. Patnaik, would you like to say something?
Also, this radiologist, they change the position. We will be having
yes.
the opening at 6 o'clock, they'll tell 12 o'clock.
This has happened
then you get confused.
Twice with me in this year. The opening was at 6 o'clock, they said 12. The opening was at 12 o'clock, they said 6 o'clock. It changes. I mean, how can you, clinically it's not there.
Probably,
yes.
Yeah, actually, this is the reason why whenever you find that the fistula is extrasphincteric, fistuloscopy will make sense. I always do, if I find that fistula is extrasphincteric, I always do a fistuloscopy and it tells me about the cavity, where the cavity is and what are the ramifications. It's of really good value, actually.
Okay.
MRI report is like going to Italian restaurant and having a kothimbar vadi, which they describe as a marcelated porcelain leaves.
I'm sorry. All people will deny doing MRI then.
What I mean to say.
Still a useful tool.
What I mean, sir, my message, my contention is that all surgeons must train their fingers to assess.
They should know how to examine fistula.
Yeah, they should train first.
Where is pure rectalis?
Yeah, they can corroborate with MRI findings, but not totally rely on MRI.
When one more message I want to give out is, whenever you are operating a fistula, you have to always palpate the anorectal ring. You have to know how far away you are. You have to know, like Kamal reminded me today morning, how much muscle you're leaving behind, which is the most important part. The muscle you're cutting, but how much muscle you're leaving behind? Is it suffice to prevent incontinence? Dr. Balu, you want to say something?
I think we are going into this medico-legal problem again and again. The courts are not going to be very kind even if I say that my finger is trained by the most expert. So whenever you have an atypical case or a difficult case, we have to get an MRI. Only way is spend time, like we learned the CT as a resident. You look at the patient, look at the report, go back to the film and see, and then over a period of 2-3 years, we really become comfortable.
You can go to the console of the radiologist and see.
Looking at the plates is not going to help us.
Plates don't help. But the diagram they have to make.
Look at it. You have a doubt. You don't, agree with that. Then go to your radiologist. Discuss with that. There is no way we can escape.
A quick comment adding on to that. After this, the same thing I did. I went back to the radiologist, sitting with the console. What is the problem? Then he has made a mandate. Any non-straightforward fistulas, he is now using contrast. After that, our yield has definitely improved, but I am not sure, I don't have a qualifying statement, all MRI should be done with contrast, because it adds up
No.
another 3,000-4,000 rupees.
No.
But he claims contrast MRI is the current RSNA guideline for a complex fistula.
For a complex. Okay, so you have a recurrent complex fistula, you can think of contrast. Okay, now the next square, I'm going to show you, and I just want your possible diagnosis, and then Dr. Jasbal will talk about it. Dr. Chiote, sir. He will talk, but what do you think it is and what should be done?
I think seems to be clinically tuberculosis. So we should rule out tuberculosis first, and then we should proceed for any treatment.
Dr. Patnaik.
Hydronephritis can be
correct.
second diagnosis.
Doctor. No idea. Dr. Jailal.
I will ask the sexual history. Is there any associated disease with the sexual?
Okay.
Apart from history, I would like to do imaging first, colonoscopy second, and third one to do a full core biopsy before going in for a definitive
Okay.
procedure.
What are you expecting in colonoscopy?
Sir, colonoscopy is principally to exclude IBD, sir.
Very unlikely IBD, sir, because there is no perianal edema. Or
Correct. That's what.
Very typical.
No, I'm not saying don't do it. I'm saying what are you going to look for?
This is the order of investigation any young surgeon should follow.
Okay,
Especially
fine.
when the fistula is not conforming to standards. Number 3, edge biopsy will give me an understanding whether I'm
Correct.
going to
Biopsy is a must. I know.
Yes.
Dr. Balu.
Yes, sir, I fully agree with what sir.
Biopsy.
But clinically, when you have a look
Suratkar,
at that,
you
it
want to
doesn't
say
look
something?
like
Dr. Jaspal, was he retroviral positive?
He was
It
not
looks like Kaposi's sarcoma because I had a patient like this and he.
Okay, now you know this is all we're going to show you in this. Yes, Dr. Pradeep.
Sir, he was a laborer by.
Was he a farmer?
He was a laborer.
Was he a farmer?
No, sir, he was not a farmer. He was a laborer.
But was he a laborer working on the field?
Yeah, he was a laborer working for brick making on the field itself.
Yeah, so I think I have got the diagnosis.
So you have to tell us the diagnosis, huh?
Disclose.
Okay. Is it actinomycosis? Right.
Dr. Jasbal, is it actinomycosis?
No, sir.
No.
It came out to be tuberculosis.
Tuberculosis.
Just want to.
Okay, now this is the only.
Standalone lupus vulgaris, sir.
Sir, it
Was
was.
there a communication with anal?
Yes. He had a fistula. That's why we are showing it to you. So, unfortunately, Dr. Jasbal had to come a few days earlier and he doesn't have the rest of the films. So, I have just, what he did was he made diagrams and tell us, Dr. Jasbal.
He was a 56-year gentleman. Actually, he was suffering from tuberculosis 10 years back, for which he had taken ATT for almost 9 months. And he was staying with this particular disease for almost 6 months. Then he came to me, and earlier we took a biopsy and one skin biopsy with one of the sinuses. We sent for HPR and took some material for culture. Everything turned out to be negative for tuberculosis. We put him on a trial treatment for almost a month, but he was not happy and he was discharging a lot of pus. Then we finally decided to get a cyanogram, and we could find the whole communication with all these cavities were there, and to our strange surprise, we found that one of the drainage sites was internally in the anal canal. And then we tried completing our procedure by doing a fistulotomy. I can show the probe where we had inserted from the very nearby. Sir, we can go to the first picture so that we can zoom there, sir. There was a very nearby external opening, and that was communicating in the anal canal, and the rest all external sinuses were all multiple and
connected with this. Okay, so you did a fistulotomy. What did you do then for all this?
I did excise the whole mass.
Yeah.
Excise the whole mass, and this I took up for 2 phases. First, I completed the fistulotomy with excision of the whole mass, and then later on, when the granulation tissue was doing well, then I did a skin graft.
Okay.
Interesting, very
Anyone wants to add anything?
Kushal, can
Yeah.
I?
Yes, please.
Share? I had a similar type of case, very similar looking case, and he was a farmer and he had these multiple sinuses, but the anal canal rectum was totally normal. So when we did a biopsy, we found it to be actinomycosis. Now, retrospectively, we went into the history, and then what happens, these farmers, they ablute on the field. Okay, and many times, especially in the barren part of Maharashtra where there is no water, they cannot clean themselves with water. They don't have access to water. So they clean themselves with the soil. Okay, and the actinomycosis is present. As you know, Madura mycosis, actinomycosis, that is present in the soil. So small abrasions in the gluteal area, they get infected with that, and that's, then they develop this disease.
They wipe with a stone and leaves.
Correct.
The floor.
Correct.
Yes. Thank you.
We tested him for actinomycosis also, which was shown negative.
Pardon?
Negative, sir.
Negative. Okay, okay.
Okay.
No, I just shared a very similar looking case. Means I have photographs also of that case, and I presented in one of the meetings. So this is again one diagnosis. If you have to keep in mind, if your patient belongs to the rural part of India.
Okay. Now this patient is a 56-year-old male who came to me simply because he was told at a tertiary center that they will do a colostomy first and then they will operate this. And he didn't want a colostomy. Now I asked, starting from Dr. Balu, what would you do?
I will drain the sepsis and also assess on table how much is the sphincter involved. If I can,
Where will you drain from?
sir, as close as to the anal sphincter complex margin, just outside the sphincter
But
complex.
look at the first diagram on the left.
I saw
It is
that.
staggered, so it's difficult to reach there. That is not that simple to just reach that abscess which you're
I may
saying.
make more than one incision if
Okay.
needed, but I will not make a huge incision. I will make
Okay.
one incision just outside the sphincter complex. If needed, one more on the highest bogginess if I'm not able
Okay.
to drain that. If I have an access to my waft in my unit, we have, but if it is outside, I may not. So
Okay, Dr.
I can put the
Kanagavel.
soap.
My concern is inadequate drainage in spite of incisions. This looks little complex because it goes way out up also. So dual incision will be my choice. Maybe I will consider placing a seat on in this patient before embarking into a definitive procedure.
Putting a seat on is not going to be easy because the internal opening
It is
at-
indeed difficult, but rather than leaving an inadequately drained thing, I would prefer to have a seat on and tell the patient that it will be a stage procedure. That
Okay.
will be my approach.
Okay. Dr.
Maybe
Jailal.
I will prefer to go through the post-anal approach, open that intersphincter space, identify that area, try to wash as much as possible.
Yeah. Dr. Patnaik.
You can put in a needle first to the cavity, what we are seeing, and put in a scope and
Yeah.
wash, do a
Okay.
thorough washing and curettage.
Yes.
Sir, I would also like to put a needle first, see where the cavity drains well, and then.
And you have to see clinically, you could not palpate anything in the
No, sir.
ischorectal fossa. And clinically, there was a very tiny little opening, fistula tract, very close to the anus. So that was not the whole solution. Dr. Chiote, sir.
See, two aspects are here. One is the intersphincteric fistula is there, or you can say small abscess cavities. And second is there in ischorectal fossa. In such cavities, you have to be really careful. I would like to open intersphincteric space in the posterior region by palpation of the cord.
Okay.
And then we will go into the intersphincteric space and ischorectal fossa, what we can palpate or we can put a needle, we can open there. So both things we can drain with the Foley's catheter or any catheter. Let this settle and we can curate it also.
Dr. Dumre.
Meaning you will do internal sphincterotomy. You will open the abscess from the
Not
intersphincteric.
internal sphincterotomy.
Intersphincteric.
I am going to open
intersphincteric.
posterior aspect of the Hilton's line, where I will get access to future cleaning of the wound. Internal sphincterotomy, if you do it inside, you will not get access for washing your this thing. Upper one, you will get it washing, facility if you put drainage tube there. But lower one, you will not get it. So that will again recur.
Sir, what was done, sir, eventually?
Sir,
I'll prefer to drain the ischorectal abscess and try to pass the set on.
Sir, what will be your access, sir?
Access by palpation and aspiration.
Okay. I did a most unconventional way and I expected a recurrence. And I told him you will have a recurrence. And it's been 1.5 years, patient is on regular follow-up and there's no recurrence.
What did you do, sir? Unconventional.
web. That is not unconventional. That is conventional.
It's an accepted way.
No, but see. External opening.
You made this opening?
No, it was there. But you know that there is another one at dentate line, higher up. So curate this out. And then when you put the waft in, then there's another opening up.
So you did the internal sphincterotomy. You have made the incision in the. You have cut the internal sphincter there.
Yeah. So you just cut it down.
You are lasering it, sir.
See, it doesn't matter. Cautery hole, laser hole, blade hole.
So how did you enter that high transsphincter space?
Yes, with the scope.
Hysterectal.
With the scope.
Okay.
You can go with the scope.
You see, you just follow. It is going to move out, and you can go into the tract. So I went into the tract. I went into that cavity. First, I did the. This is opening the internal sphincter to 1 centimeter below the anorectal ring. Once I opened that, then I had access to that opening which was there. And after cleaning everything, curate very thoroughly like Dr. Chivte told us, then I put a Foley's catheter in it. And this Foley's catheter was inside. And it was day 2, this was the pus which was draining. A regular irrigation was done. And day 4, pus coming out.
So you removed the infiltrated
I did it from
source.
inside,
Yes.
and this is day 6. And after that, I kept calling him every month because I was expecting a recurrence. And I'm just thankful it was okay. Dr. Jailal, did we do this? No, we didn't do this.
Shall I make one comment?
Yes, sir.
See, wherever you feel or you get on MRI, there is intersphincteric fistula is there. On any way, posterior, lateral or anywhere. Cord or anything is palpable at the posterior aspect of the Hilton's line. If you open that line there, like a lift, you can go into the fistula on any direction.
Yes.
Whether it goes posterior, left or right. You can go through the scope and you can curate it. If you don't have scope, at least you can have your curate it totally, pass a catheter in that, like a Foley's catheter. Why I said Foley's? It is soft, it will not endanger rectum or anywhere else. So you keep on giving wash, at least that track will remain small, and sometimes miracle happen that can heal also.
Okay. I think it's time we can't take any more. We had one more thing I want to say. I had a case, but just giving a message. Many gynecologists are draining Bartholin abscess. In this year alone, I got 5 patients who were by gynecologists who were draining Bartholin abscess twice, thrice, but they were actually fistulas. So you have to tell the gynecologist in your city before, when they're draining the Bartholin abscess, put in some saline with hydrogen peroxide. If it comes in your canal, not to touch it, to send it to you. Because I have 6 patients like that, I know that there must be a big problem in public, and we have to just tell them to do it. Thank you. Thank you so much. Everybody waited till the end. Thank you. Yes.
Thank you.
Photograph.
So for the delegates, we'll require at least half an hour to set up the stage for the entertainment program, following which the Sargam medicos are going to perform here for your entertainment, which will be followed by fellowship and dinner for the banquet night. Tomorrow morning, the live operative workshop will start sharp at 9 o'clock. So you can be here by 8:45, so that you can occupy your seat and nobody needs to complain that they didn't get a place to sit. So please be early. And there are around 13 cases to be done tomorrow. And Dr. Parvez Sheikh, myself, Dr. Kushal, Dr. Arshad, Dr. Kamal, Dr. Chivte, these are the few, Dr. Parthasarthi, these are the few surgeons who are going to operate, Dr. Roy. So you will see all varieties of fistulas and all modalities which can be used for the fistulas. So please bear with us for half an hour till we set up the stage for your entertainment. Thank you so much.
बोलने गए
Hello.